full live surgeries being done by surgeons who are the best in India. So that you can relate, number one, you can learn and overcome your inhibitions. So that is the reason we have packed 4 lovely surgeries today, okay, so that you can learn while the procedures are being done. Okay? The podium is open for you to ask questions. So by the end of the day, we hope that you will take back a lot of information home. We are thankful to the IAS for providing us the best faculty. They have come down all the way to provide us with the latest in the field of arthroscopy. We start this program today with a live surgery. Dr. Sandeep Birares is operating. The details will come up soon. We request Dr. Rajiv Raman, sir, to please come up and moderate this live surgery. Dr. Vikram, so we would request you also. Yeah. So I hand over this session to Dr. Rajiv Raman and Dr. Vikram, and after this surgery we will take up the talks.
Thank you, sir. So, first live surgery by Dr. Sandeep Birares, and I think it is arthroscopic ACL reconstruction. Can we connect to the OT? Hello, Sandeep.
So, yeah.
Hello, Sandeep. Rajiv here.
Yes, Rajiv.
Yeah. So welcome to first live surgery and the inauguration of IAS One live surgery by a dynamic secretary, Dr. Sandeep Birares, and it's a brainchild of our president,
So
Dr. Sachin Tapasvi.
Can we go ahead now?
Yeah, please, Sandeep, please. Can you tell about the patient, Sandeep? A short history.
Ishmak. Which camera is working? Huh? Then why are you doing? What are you doing there?
So it's a 28-year male. Should I explain? Yeah. So he has an injury to the left knee due to fall 1 year back, and now complains of pain, difficulty in climbing stairs, and instability. So can we have the MRI findings?
Rajiv.
Yeah, Sandeep.
I think there is a PowerPoint presentation by Dr. Sridhar. So I just saw
already. Yeah, I am running that PowerPoint, and so you can see this sagittal cut. There is a complete ACL tear, and on clinical examination.
Light off.
The trochlea and so it's always better to see the MRI rather than MRI reports most of the time. Now in our state people are getting a grade 1, grade 2, grade 3 ACL tear. You don't understand what it is. Very many of the time you will get partial ACL tear. Semi-partial ACL tear also being repeated. I don't know where this term comes from. So you can see the anterior drawer test is positive. The Latchman this is a classical way of demonstrating the Latchman. You can see there is anterior translation of the tibia with a soft end point which the clinician can assess. So there is a classical instability, and that is suggestive of your ACL tear. So over to OT now. Yes, Sandeep, we have shown the clinical photographs and the MRI.
300.
Yeah, please connect to the OT. So at what position you want to do your surgery, Sandeep? It's leg?
So I am comfortable with both leg hanging or in 90 degrees flexion, like we do it in TKR.
So here you are versatile in all position.
Sorry?
You are versatile in all position, doing in all position ACL reconstruction.
Yeah.
Yeah, fantastic. So today you are showing TKR.
Inflate, please.
So what graft you are planning, Sandeep, today?
So I'm planning mostly only semi-T.
Fourfold.
Fourfold, yes.
All right.
That's what is the plan.
All right. And what is your fixation plan?
For femur, I'm going to use ultra button, that's adjustable one.
All right.
And tibia, we'll see, depending upon graft length.
All right. So this is, since this is the first live surgery, we want to see from graft
11 number
harvesting,
blade.
graft preparation, everything. And we would like to see your to see your graft preparation technique, which you showed in Durgapur also.
Sister, don't come in way.
So you are doing for your diagnostic roundup first?
Yes.
Oh, fantastic.
Take this. You come here, sister. Water start, please. What is this? Clean it. No.
I think some fogging is there.
Yeah.
Yeah, that will.
Don't do anything. Don't do anything. I told you don't do anything.
Vikram,
Don't do means don't do.
you are supposed to.
Shravan.
So, Dr. Sandeep, any rotational instability in the patient?
No, clinically no.
No.
I don't know what is the problem with the picture, I don't understand. White balance किया है क्या? Huh? Is it visible correctly to all? Dr. Vikram,
Hi, Dr. Sandeep, Dr. Vikram here. I have joined Dr. Rajiv.
white balance. Boss, it's not working properly. No. No, don't do that. Just start. अरे यार, what white balance? Just exit. Do it upper button. Yeah. What white balance you have done, Shravan? Yeah, is it clear now?
Yeah, very clear. Thank you.
So, I'm in the suprapatellar pouch. I'm just checking that's a femoral trochlea. That's patella. Patella looks pristine. That's medial facet, and that one is the lateral facet. So I'll go into the lateral gutter. I'll just quickly go and check the lateral gutter. Lateral gutter looks okay. That's the popliteus hiatus. You can see the popliteus tendon coming up. Then I'll again come in the suprapatellar area. Now going to the medial gutter. Medial gutter also looks okay. So now gradually into the intercondylar area. So now I'm in the intercondylar area. So once I'm here, so I know there are no loose bodies or no at least peripheral meniscus pathologies in the body. But now once I come here, so we can see ACL is completely torn and there is some part of ACL is left there. And PCL looks okay. So here first before taking my portal, I'll just do quickly, I'll check the menisci, because as per the MRI, meniscus looks okay, but I'm still going to probe it.
So, Dr. Sandeep, do you routinely harvest the graft before you do your diagnostic, or?
I always do diagnostic, and then only I take graft. So patient has got little wear and tear on the medial femoral condyle. Meniscus, prima facie medial meniscus looks okay. So I'm going to check now lateral meniscus. So Dr. Vikram, you do, if you are convinced, you do take graft earlier or after diagnostic only?
I think it's a good habit to take the graft later, but I usually trust my clinical decision, so I take the graft first. But wherever a doubt, always good to do a diagnostic arthroscopy first.
So now I'm going to take my another anteromedial portal under vision, of course. So whenever I do it, I always check that I am much higher up, just above the meniscus, not too low, and away from the cartilage. So, and I see, so depending upon if I am addressing meniscus pathology, so I decide my this anteromedial portal with that, or otherwise here now I am going to do ACL reconstruction only. So I think that will be my adequate trajectory, very much away from the intercondylar region and going into the ACL femoral footprint. Take out, please. Number 5, if you want to open. Yeah. Trocar. So I'm just clearing out the synovium, because when we do hyperflexion for femoral socket, then this everything falls into the intercondylar area.
So it's nice to have this empty wall, no?
Yeah, actually, that's what I was thinking in my mind. Thank God I am so lucky. There is nothing there.
So I think we can demonstrate the ridges and all very well now.
Yes. So I don't use femoral guide for the, or femoral aimers you can say, for the femoral tunnel. So now my drill bit is my guide. So here, so that's where I think I'm going to get my tunnel here, somewhere here. So we'll see, depending upon how much graft we get. So I have already layered out because it's a chronic injury. So there is nothing much. Give me probe. Elise आ गया? You have Elise? Elise is there or no? Yes, sir. Not now, it will be needed later.
So, Dr. Sandeep,
Yes.
you routinely go posteromedially to see a ramp tear in these
Yeah,
chronic
I do.
type of
I do go.
lesions?
Yes. So because first I wanted to clear it out, and you can see, well, it looks okay. Now I'm not going to, I'm not going to put my needle and check if it is there or not. But yeah, it looks okay to me. Laterally, now I'm going to go medially.
Just underneath the PCL. Yes, now yes, posteromedially.
Oh, I think he's got a ramp.
I think he has a ramp tear also, yes.
Yeah. Needle?
Yeah, it's a big ramp. So you will do first ramp repair, then ACLR, na?
Yeah, that's what. So this was completely unprepared for.
Suture lasso, you can ask Smith and guy to give suture lasso, and
You
then I
have
think with any throat.
everything for the ramp? Suture lasso है? First mini है? Cannulas है? Hold it. Bend.
I think, Sandeep, you can go with your graft harvesting and all those things. By that time, they will prepare, because that will save our time.
Yeah, no, I
Yeah,
just first want
so-
to confirm that.
Yeah. And just see whether it's separated or not.
Yeah,
I think
that's what I'm
sometime,
checking.
I think fibrous, it's
It is,
fibrosis
I think,
is
old
there.
injury, and it is separated. Yeah.
So I think by that time they are preparing the instruments. You can take graft and
Nah.
yeah,
Yeah, it is.
and make your posteromedial portal. Keep it there.
Yes.
Yeah. Good. So this is the best technique, needle technique, by which you can see the ramp. Sometimes there is a fibrosis in the layer also. So you can just divide those layers. You can see it's a big ramp here. So.
Yeah. So that I have
So by the
taken
time the
my
OTA staffs are preparing for this, all those instrumentation for ramp repair, I think Sandeep will go for ACL reconstruction first.
बोलो. The ACL reconstruction, and then later on I'll come out, do ramp, because I don't want to take out the time of the conference.
I think it's important in all these patients to always check chronic ACLs, do a pivot shift test,
Vikram, am I
always
audible?
check whether there is any kind of rotational instability. And one of the most common causes are these ramp lesions.
Am I audible?
Yeah, please.
Yes.
Sandeep, you can go with graft harvesting
Yes.
and everything.
So
and
Rajiv, I am
yeah.
going to do graft harvest, and I am going to finish everything for the ACL. And
Yes,
going to do
and then
ramp.
by that,
Yeah.
at last you can show ramp
Lights
repair.
on, please.
So this is important what Arun told. Whenever you are getting explosive pivot, it's not only because of ACL. Sometimes the ramp lesion also produces the explosive pivot. So in those cases, always try to see the posteromedial corner. And today you can see once you put your scope there, you can a big long tear is there. So it's a new dimension. Don't try
Show
to
this camera.
avoid it in your diagnostic roundup. The assessment of the posteromedial corner.
Focus this. Why his picture is coming like this? Can you see a picture from both the
Yeah,
cameras?
we can see Sandeep very well. It's very clear and you are audible also.
Yeah.
Please go ahead.
Yeah. So I am in favor of this oblique incision. So I have marked tibial tuberosity and I feel I am palpating the posterior ridge of the tibial proximal tibia, and then I go in between. So I take little oblique incision and again I check my hamstrings by palpating into the middle aspect of the popliteal fossa. Right angle, please. No, not that one. Sorry, sister. 50 number blade. एक कैमरा इधर से आओ.
Cameraman, can you focus it from medial side so that we can see
Yeah.
the skin incision? Cameraman, please focus it from, yeah. Now we can see, yes, Sandeep.
50 number blade. So trick here, I use very thin retractors. Lights. Elise. Number blade.
So you are planning to take only semi-T?
Yes,
Yes.
that's what is the plan.
So what is the minimum graft diameter you prefer for ACL reconstruction?
Minimum 8 has to be there.
All right. And your graft choice is always semi-T?
Yes.
It varies with your professional sports person. Sometimes when you are treating
Sorry?
sometimes if you are treating a sports person, the person who is involved in sprinters in contact sports, your graft choice is semi-T only. Those patients also?
Sorry. Come again, Rajiv.
Oh, contact. No, for graft choice in a sports person. What is your graft choice in a sports person?
Graft choice in sports person is either semi-T, I mean like it's blade, BTB or CQT. But CQT I hardly take it for the primary.
All right.
Elise. See that. I always create a window blade. I just go above the gracilis, the whatever the prominent structure I palpate. So the globular one, and once I am above the semi gracilis, then I put my finger inside and palpate both semi-T as well as gracilis. These have got very thin grafts. Right mixed. So I have tried out the, if you want, so that's the semi-T I have removed. Give fast. Number 5, huh?
Yes, sir.
Do you have original if you want? not sentinel. The other. Original ET bond. Get original ET bond. Get original ET bond. Hold. Lock. Hold it. Hold. Hold. So he has got very thin, unfortunately, I don't know, very thin grafts. Give. Hold. Right. Relax this. No, that retractor is okay.
Yes, Sandeep, you can tell few pounds how to differentiate between the semity and gracilis
Yeah.
for the juniors.
So
Some junior guys are
here
there.
the semity, when you put your finger and you palpate, semity is the one, gracilis is the one which is very prominent and it's very globular, and then semity is just below that, which is very flat. So here, many people they go in between interval of gracilis and semity, but I would always like to go between, go above the semity and try and take it. Sorry, go above the gracilis, I see it from the top, and then 10 times I confirm that I am going to first remove the semity only, not gracilis. If there is no other choice, then I do take gracilis. Give. Yeah. So that's 1 second. Take this. Give the mosquito. So I have isolated both semity and as well as gracilis. So the gracilis is the top one, semity is the lower one. So now I'm going.
Welcome, Dr. Mukesh Ladda. Yeah.
Sorry. Yeah, hold this. Hold this. Give it to me, feed it. तुम कैनुला वगैरह सब रेडी रखो और रैम्प still is Caesar. Give the mosquito and right angle. Give right angle. जल्दी hold this now. Blade 50 number blade. Good. Release. So I have released CBT.
All right. So you have
Gracilis.
removed your vinicula, yeah?
No, I'm removing. Yeah. Yeah. Okay. So vinculas are out. I doubly confirm. Release. Graft. Paper.
So I think it's very important to keep flexing the knee so that more and more vincula come out so that you can cut them. I think that's not seen, but I'm sure he's doing it in the background.
You need to feel it. Because sometimes they are under the fat, maybe adhered to the grasper. So whenever I am doing this, I always doubly check. I am putting my hand and checking in the popliteus fossa. I make sure that I have removed CMT only. Yeah. It looks like I've got quite a big graft. Yeah.
I think, yeah. It's
Yeah.
a big graft, thick
So there
graft.
will not be need for the another gracilis. So it's good graft. I think so.
You can show graft preparation
Yeah.
also, Sandeep.
That's okay, let him relax. Focus here. So I'll start preparing. Needle holder, please. Original ET bond. Where is original ET bond?
Cameraman, focus on the table for graft preparation. Yes.
Length. So I think it is almost more than 35.
Good enough. Eh?
I don't know, somehow during live surgeries I always get lucky. Or I think Sridhar has kept patient.
Thanks to Sridhar for,
Yeah, exactly.
for arranging a patient with long CMT. Yeah?
So Sridhar has
An
chosen
empty notch.
patient. It has got a long flank open, please. Yeah. Elise. Mosquito. Come, sister, work fast now. Hold this. Mosquito. Hold this.
I think Sandeep will
ET bond.
show you a special technique.
Still is. Caesar. Am I visible?
Yeah, you are audible. Your graft is visible.
Okay. Perfect. People, anybody can give light here. Need a holder? Yeah. Original ET bond. One more original ET bond. So what I do, I don't use this commercially available one. So this is a number 5 ET bond, the original ET bond. Not some Sentinel or something, or Lotus is also okay. So I make this needle straight.
Cameraman, focus on hand. Yeah.
I make this needle straight. Once needle is straight, I will ask sister to hold this end. Hold it, don't leave. Then
Zoom, please. Sandeep, please wait. Let's zoom in. Zoom. Yes, Sandeep, please. Go ahead.
so sister is holding the end. Don't worry. I'll put this inside.
This everyone should see. No?
Okay.
Yeah, good.
So now leave sister and hold this. Now sister has given that to me and she's holding very closer to the needle. I'm going again in. So this has made my loop.
All right.
Yeah. So that's the loop with straight needle.
Yes.
So here, take one more. Don't worry. Hold this. Leave. So the original inventor of this technique, or the one who taught me, is my very good friend, Dr. Pradeep Nemade, our earlier EC member, who never sits idle. Something or always going on in his mind. So devises many things. So this has become like a speed loop, which many companies they market. So zoom out please. Now I'm both the ends I'm holding here. So now I have made graft as a double. I'll go and take the loops like this.
Cameraman, please zoom.
Like roti, braid.
Yeah.
So that gives good compression from either side. And there is only one hole in the center. So even if you go
So you are passing it through the center of the graft.
through the center, and I'm coming
good.
all around.
Publish it, otherwise.
It's already under process.
100%.
Yes. So that is the reason I'm showing in the live surgery, because it's already under submission. So that has made, hold this. Buy me graft sizer, please. Yeah, 8 it is.
Good.
Yeah. So hold this please. I'm just removing this vincula. Hold this. It is. Sure. Adjustable. Come.
So you make it 4-fold now.
Yeah, I made it.
So you always use this graft preparation board for tensioning of the graft?
Yes, only tensioning. Yes.
All right.
Almost every time you can say. Lanco. Yeah. Lanco wait करके इस पे डालो. Mosquito. So now I am not going to take gracilis from this gentleman. Prokar, come. Drill ready? So I think Dr. Mukesh is going to show different techniques today. We have three different surgeries. One BTB, one hamstring, and one with innovative tunnels. I'm in the intercondylar area. Take a drill bit. Hold this. Light off, please. Make it 6,000. Shaver 6,000. Company person 6,000. Shaver speed. मोड चेंज करो. 8 ठीक उल्टा ठीक है. ओके, लेट इट बी. Take a trimmer in my hand. blade. Hold this, sister. 11 number blade.
So how do you plan for your femoral tunnel, Sandeep?
Yeah, so I not comfortable with the aimer, so I use this 8.5 reamer. So now you can see this is the posterior, completely behind the femoral condyle, and that's old footprint was here somewhere. So I'm going to go in this portion. That's where will be my tunnel. Take drill with pin. 1 second.
So what position of the knee is
Hyperflex.
you kept it?
So, down knee.
Sandeep?
It is hyperflex, Vikram.
Okay.
Yeah, please go. Yeah. Wait, don't drill, withdraw. झटका क्यों मारता है भाई? हाँ जल्दी है क्या तेरे को? हाँ, गिव काउंटर, गो. No, झटका. Yeah, drill please. Go. Watch out for the wire. Go. Bas, hold this. Chabi, hold this. So now this acts as my drill also. So I have put there. Now I'm going to go straight away 25 with this. Hold this. Pump kar. This pump. Go. 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 Go, 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 go. Go, 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 go. Go, 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 go. Bas, come out.
See, he should not pierce the lateral cortex. Yeah.
Bas. Yeah, 4.5. Don't worry, it will not come out. Because we have not drilled lateral cortex. So here, the advantage is it never comes out because it is holding on to the lateral cortex.
Yes,
So I have drilled 25. I'm going to, I don't check the size of the socket. I'm going to mark graft at 20. So my aim is to have minimum 20 graft inside the socket. Take. Go drill, don't worry. Go. Fast. So that ends. Are
Yes,
you okay?
Sandeep, can you show the tunnel view from the medial
I'll
portal?
be doing that when I'm pressing the graft.
You have a good 2 to 3 millimeter posterior wall.
Yeah.
Yes.
Yeah. Breathe pin लगा. Breathe pin लगाओ. So that's my tunnel for the full. So here my landmark. So this is the anterior root of the lateral meniscus. So this is I am taking peep aimer. So I will try and come somewhere here. Come, bullet please. Rotate.
So posterior to the lateral, anterior
Yeah,
horn of the lateral
yeah.
meniscus.
please go. 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 Now I think he's touching me. So go, go, go. Don't worry. Go. You just go. Okay. Go, go, go. Don't worry. Go. Go. No, out. Hold this.
This happens sometimes, it
Yeah.
misfires. Yeah.
Too posteriorly.
Yeah.
Take again.
What I do, I keep that pin there and then I make my second hole so that it doesn't follow the same track. Yes, seems to be.
Take out. Yeah.
Yeah.
Okay. Scoop. Scoop. Curate. Curate.
So you try to keep your tibial stump there.
Yeah, but I hope this gentleman helps me. Don't go direct in, huh? Do go with little Zumba dance. Go, 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 please go. Go, go, slowly, go. Right. Yeah. Don't go directly, huh? Slow, slowly. Go, go, go. Go, go, go. 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 Push. Push it in. Pass. Come. Don't remove. You know Zumba dance. So you go there. Go, see. This is. You should not go completely out. You are. Grasper or suture retriever. Any questions so far?
Yeah, so
Hold this. Leave this. Don't touch.
I think the water flow is.
I have stopped.
Yeah. Oh, you have stopped it. All
Yes.
right.
I don't want to water seep out unnecessary here because it doesn't serve our purpose. So now I'm going to shift
using
to.
adjustable loop, na?
Yes.
What is your tunnel length?
25 I have drilled. So you wanted tunnel view. So this is from the medial side.
So now you are viewing through the medial portal.
Yeah.
Yeah.
Is okay?
Yes. Very good view. Yes. So you do flip under direct visualization.
Yes.
Yes. Good.
Hold this. Graft. I always see that it is getting flipped under the vision. Hold this. Hold this. Don't worry. Thank you. Hold it.
So what is the minimum graft you want inside the femoral tunnel?
Minimum 20, anywhere between 15 to 20.
15 to mark it at 20.
20, yes.
All right.
So this mark, if you can see outside, which is at 20.
And what is the length of your graft?
Length of my graft is 8, because it was 32 or so. So it is slightly above the 8. Yeah. So I have already drilled up to 25. So if I want, I can go little full. Higher also. Yeah, bus. Just take out this. You go. So I think you are okay. Is it okay? You are able to visualize properly?
Yes.
So I am not starting saline because I think this view is okay. Please.
So we can see it's near the lateral cortex.
Yeah. So I think
Yeah.
I can start the saline. Wait.
Water flow.
Yeah.
Yes.
Go. Yeah. Flip. Yeah.
Yes, got. And you
Just
can see
flip.
pull it.
Yeah. So I am able to almost pull the leg. Come here. Yes, sir. Mind your head, please. So, trocar, please. Don't worry, I am holding. Go. So during this stage, I always hold the graft. I don't trust company person, I don't trust my assistant. Because if you are like, you know, what we say, nazar hati, durgatna ghati, so if you keep aram se, you should stop in between. Zyada shakti lagane ka nahi. Go. Because sometimes they leave their hand little loose and then button also gets pulled up. Go, 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 go. That's it.
Yes.
Okay, so that's. Is it okay, Rajiv?
Fantastic. I think it's
So,
perfectly oriented graft.
And there is still some left outside. So I'm going to use the screw here. You can see mouth. So graft is still, I can feel it, it is outside here.
All right. So you can use a purchase fixation here.
Yeah. So we are going to put the screw.
So if your graft is inside the tunnel, you change your plan with disc.
Yeah, this, yes. If graft is short, and then after I put the screw,
And before that, you cycle your knee also.
no,
yeah?
I'm not going to cycle here because I have already given adequate tensioning. 925.
What is the position of the knee?
Now though it is not, I'm just passing this guide wire, but around 20 to 30 degrees of flexion. Open 925 please. And whenever I do, I always with my fist, I give posterior drawer here. Put.
It's a biosure screw, I think.
Yes.
Yeah.
This is Smith and Nephew biosure region sorb. So, correct? So once it is gone and good purchase is there, I pull out the guide
wire, yeah.
because it gets entangled or it may bend. So Rajiv, that famous cut sound.
Yeah. Durgapur I showed you. No?
Yeah. So you have told me the technique also, how to produce that if it is not coming.
So you can just give a demo here. To Mukesh is interested in seeing, to hear that cut sound.
Yeah, so you can tell him.
So Sandeep is doing with his teeth only.
So Raju had told me if you are not getting this tuck sound, so you should just do it with your teeth. So we tried there in Durgapur.
No, this is the original one, but yeah.
So once it is done, I'll ask this gentleman to pull his graft as well. Just a little. Because as
That
I
is
told
the
you,
advantage of adjustable loop.
yeah,
You can
so
again
as I had told
retension
you,
it.
we had done 25, but graft mark is at 20. Perfect.
So very nice demonstration, Sandeep. Very good.
Let's check final this view. Then we can go ahead with the session and then we can start here for the ramp. You have mini cannula. Don't open it. Lasso nahi hai na? Have to pass. So that's the final picture. This probe. Probe was here. Array probe.
Can we have the arthroscopic picture?
Yeah,
I think we'll see the graft and then we can wind up.
yeah, I have already shown it.
Yeah, very nice. Very good.
Probe.
Excellent, Sandeep. And thanks for wonderful demonstration.
No, thank you. Thank you.
Well-oriented graft, no impingement over the wall,
Yeah.
no roof impingement, no PCL impingement. Fantastic. Yeah. Sandeep, you can proceed with your surgery. We will carry on with talks.
Yeah.
And thanks to the entire team.
Okay.
Wonderful demonstration, Sandeep.
Thank you.
Yeah.
Yes. Bye bye. ये निकालो. ये निकालो. चलो. अरे बाबा. Why don't you?
I think we should
are
compliment the
you
audio
really
visual guys also.
Yeah,
Quite a
thank-
seamless presentation at the end of it.
Tisha,
And the OT team.
sisters. जल्दी करो यार just.
So, good morning everyone. So just to have a brief introduction of our meeting. So we are doing this meeting called Indian Arthroscopy Society IAS One. So Indian Arthroscopy Society as a body has initiated this to take arthroscopy teaching program or academic into the second tier cities or two tier or three tier cities. So apart from the metros, they want to educate all the young surgeons and budding surgeons on arthroscopy. So they're doing across the country. So they do every month one state. So every month one state, one program. So we asked for this program almost 2 to 3 months back, but in a short notice around 3 weeks back they've allotted this. But I hope we could organize this very well. So in a brief, what we are going to do is we have a limited number of talks. So we'll start off with clinical examination of patient. Today what we are going to do a third live surgery by Professor Shivananda sir. Then we have few talks. And we have 3 more live surgeries. So we have all eminent faculties, starting with Dr. Sandeep Biraris. To introduce him, he is the Secretary of Indian Arthroscopy Society. So he's the current Secretary. And he's the person who has to take up our IAS membership applications and accept it. So he'll be doing that. Whoever want to take the IAS membership today, so you can just sign in. We have a barcode in the reception counter. You can sign up. He will accept it because Secretary has to accept the application. Then only you can go to payment and other ratification in the coming general body meeting. So he has done the ACL now. The second surgery will be a PCL reconstruction surgery by Dr. Rajiv Raman sir. Sir is renowned Don of West Bengal. So sir is a joint secretary. He will be the next secretary of Indian Arthroscopy Society. He was elected unanimously this year as a joint secretary for IAS. So he will be guiding us as a joint secretary for 2 years. Then next 2 years, he will be the secretary for IAS. So he will be guiding and a torchbearer for Indian Arthroscopy Society for the next coming 4 years. And sir is also West Bengal Orthopedic Association Secretary, and you don't believe every weekend sir will be in any teaching program across the country. So you just remember him, any brochure comes to you or any program comes to you, you will see him. Across the globe, sorry, especially SARC countries. SAR is a key person, started arthroscopy in Nepal, Bangladesh, other all SARC countries.
Check. Hello.
So he started that program, and he goes personally as a visiting surgeon, and he performs a lot of arthroscopy surgeries in Bangladesh and Nepal. So sir will be doing a PCL reconstruction today. Third, we have ACL with bucket handle meniscal tear by our good friend Chirag from Bangalore. So he will be doing ACL with bucket handle meniscal repair. Fourth surgery is Dr. Mukesh Ladda from Nagpur. He will be doing an ACL reconstruction, and he has a specific innovative technique of doing it rectangular tunnels. He has a publication on his name. So he will be showing that in his talk also. So we'll have 4 live surgeries. In between we have some case discussions by Dr. Ashish sir and Khan sir and Shiv Kumar sir also. So any issue or any doubts, anything, you can take up the speaker podium and you can ask for questions. So we'll proceed according to our agenda. Thank you so much. Aslam sir, please sir.
Thank you very much, Sridhar, for starting of the meeting. Can I request Professor Shivanand to please come up? And he is very good at explaining and demonstrating examination of the knee. So we request him. We have a patient. By customer. And Professor Shivanand will demonstrate the systematic examination of the knee.
Hello. First of all, I thank IAS for organizing this wonderful academic feast here. And I thank Sridhar and wonderful team that is working over here for this academic feast. So in this program, it is a structured program. That's why from the clinical examination to the top and surgical procedures and their inferences and how they will work and how the prognosis will be and how they can give the good results. So please learn. Any disease, it starts with the clinical examination. So in the clinical examination, there is nothing is alternative for the clinical examination, whatever advanced investigations comes. So if you don't diagnose properly, clinically, some other things will miss, and that ultimately results with the failure at the end of the surgery. So what are the main important things we will discuss today, because this is a course mainly because on the ACL and PCL. So let us discuss about those things only. We are concentrating on those 2 particular issues.
Can I request Dr. Ashish and Dr. Raviteja to come up to moderate this session, please? Dr. Ravi.
Whenever you go for clinical examination, especially when you are examining the knee joint or any joints, all these things, so make the patient ease first. This is the first and foremost important thing. You introduce yourself and give a confidence that patient should not be hurted at any point of your examination. This is the first fundamental rule. And second thing is, whatever procedure you want to test it, the painful things should be examined last, and the painless things you should examine first. These are and your examination should concentrate on what are the most important structures that are affecting your future surgical procedures. So these are the three things you must examine, and once you are examining, it should be a systematic order, because you cannot examine all the things, everything in the clinics. So if you go through a particular systematic order, then by that order itself, it will lead you to particular diagnosis and what are the consequences of that. This order is very important. So before examining, introduce yourself. Hi, how is your name? What is your name? Varun Kumar. So, lie down. నీ కాలు ఇప్పుడు నేను ఎగ్జామిన్ చేయబోతున్నాను. ఏమ్మా పడుకో. This particular patient is having problem in the right knee joint. So whenever you are examining this clinical examination, always examine the normal knee first, then you examine the abnormal knee, because you will have a counterpart to check whether which is abnormal or which is normal. Another important thing, when patient is entering into your clinic, the first thing you should observe the gait. So certain gaits and certain patterns are very important while operating the patient. So once he is walking in this, you must see for the lurch, any lurch is there. That means while he is standing on the single stance, suddenly knee buckles posteriorly. This is hyperextension. This is the one most dangerous one you should always remember. Second thing is, while entering into the chamber, you see for the any varus of the knee joint. They will have the varus. Some people may walk like this. This is the one important thing that will definitely hamper your management, and definitely they will give bad prognosis. If you observe these two things while entering into the clinic, that is the best way. And third thing, most important thing you should observe, whether the patient is having flexion deformity of the knee. This is the one most important thing. So you should able to localize what are the possibilities that can produce fixed flexion deformity. So if the patient presented with fixed flexion deformity, hyperextension of the knee joint, and varus of the knee joint, these are the three things always you remember when you examine knee joint. Why those are important, I will explain later on. Once you try to examine this patient, so you strip and examine both the sides. From the top to bottom, you must see that whether it is important for that particular issue. Suppose patient underwent meniscectomy, or then there are certain scars or previous arthroscopy scars will be there, somebody is operated or like that. And if the patient is having any scars in the anterior aspect of the knee, this is very, very important. Anterior aspect of the knee, anteromedial aspect of the knee, that gives, indirectly it says it is a direct injury that is producing. Anteromedial thrust, usually that will produce a posterolateral corner injuries. So which is a detrimental if you don't diagnose early clinically, then it is difficult. Another important thing, most of the times MRI pictures, sometimes it may not give you the perfect grade of that particular lesion. So only clinical examination will give you that particular grade of that particular lesion. So even though the lesion is there, if you don't examine it, whether you treat it conservatively or if you want to treat it operatively, you cannot differentiate. So these are the things are very important. Anteromedial scars. That means it is a dashboard injuries that will produce a PCL injuries are very, very common. Then in the history you should ask, what type of injury produced this particular problem? Is it a direct injury, or it is a indirect injury, or it is a twisting injury? So indirectly that particular thing will give you what are the, if the injury towards medial side, you will get the lateral side structures are gone. If the, from the injury from the lateral side, medial side structures. If it is a twisting injury, definitely you will have a combined lesions. So when you operate for ACL or anything, any ligamentous injury, two things are important. One is you must exclude posterolateral corner injuries, and you must exclude collaterals. If the collaterals
and posterolateral corner injuries, if you don't identify, so whatever ligamentous reconstruction you done, most of the times they will fail. 50% of those cases will be failed. Especially if the patient is athletic individual. So posterolateral corner injuries and collateral injuries, you must identify. So once you are examining this patient per se directly, first thing, always hold the toes and try to extend. You can see this right side there is a normal, there is a certain amount of flexion deformity in the left side. Patient is having left side problem. So that classically that will tell you, so this side is having a flexion deformity of the knee. What are the conditions that can produce this particular flexion deformity of the knee? So you should observe. One is meniscal pathology like bucket handle tears. And second thing is, if the PCL that is torn and posterolateral corner injuries, these patients always walk with flexion deformity. If they are long standing, they present with flexion deformity. So flexion deformity, fixed flexion deformity of the knee is a dangerous one. Always you must suspect. So by extending it, you are indirectly doing the external rotation and you are creating the extension at the hyperextension at the knee joints. So once you do this, you observe the tibial tuberosities. So once you observe the tibial tuberosities, if they are rotating outward, that means patient is having posterolateral corner injuries, you must suspect. And at the same time, you must observe for the hyperextension of the knee. If the patient is having hyperextension, definitely that will give you that clue. Patient may have a posterolateral corner injury or PCL injury. And next, immediately, what you have to do, you hold the knee and you try to lift it. Once you are lifting it, you will find that the foot tibial tuberosity is turning out. At the same time, the tibial condyle is subluxating anteriorly. That indirectly says that this patient is having anterior cruciate ligament injury associated with posterolateral corner injuries. So if the tibia is translating anteriorly, means it is the anteromedial bundle, which is very important structure that is preventing anterior translation. Externally rotating means, that means it is a posterolateral corner injury is producing. So if you lift it, you can observe the flexion deformity as well as you can observe the hyperextension. At the same time, if you lift it, sometimes this limb will be drifted into the varus. So that is also you can identify by simply doing this particular procedure. So once it is going into the varus, always you suspect there is some posterolateral corner injuries are there. So these 3 points easily, simply without examining any other tests, you can able to get, and you will get that particular information. So this is external rotation recurvatum test. So once this procedure is over, then you go for the collaterals, which is very easy to identify. So how do you test the collateral ligaments? It is the medial collateral ligament and the lateral collateral ligament. You examine in both extension as well as in flexion, you must examine these cases. First you examine in extension. If there is an opening of the medial side, that means once you give the valgus stress, that means it is medial collateral ligament along with the medial capsulo-ligamentous structures are torn on the medial side. And once you hold it, and if you apply varus stress in extension, that means posterolateral corner injuries and posterolateral structures are gone, lateral collateral ligament is gone. Purely you want to test the MCL, then you keep the knee in 30 degrees flexion, then you keep the pressure on the lateral side and you apply a valgus force. If it is opening on the medial side, then definitely or tenderness or pain, that can be graded with that. If it is a grade 1, it is minimal pain, grade 2, it is a more pain. If it is a grade 3, it is opening out. So depending on the grade, your management differs. That's why you must examine clinically. MRI cannot say this is a grade 1 or grade 2, grade 3. Sometimes it can give you some picture, but in acute conditions, it won't give you the particular picture. What is the grade? So Purely you want to test collaterals, 30 degrees flexion. If you want to test the medial collateral ligaments as well as capsular ligamentous structures, if you want to examine, always examine in extension. These are the two things. Gently you must examine this. This is for the collaterals. Then come to the cruciates. There are two ligaments are there. One is anterior cruciate and posterior cruciate ligament. For anterior cruciate ligament, you should know what are the bundles. It is an anteromedial bundle and posterolateral bundle. The anteromedial bundle. So if you know these two things, then according to that you can examine that particular patient. So there are several tests are there. One is Lachman test and anterior drawer test and pivot shift test. All these are there, and Slocum, there is a rotatory instability tests are also there. But in these patients, what is first? It is painless procedure. You must do it in acute conditions. In a chronic conditions, you can start with any particular procedure. In acute conditions, always go with a Lachman is the first one you have to do it. So first thing is the Lachman test. You hold the thigh, and importantly, you must keep your thumb on the joint line. Then you hold the proximal tibial condyle. Then you do the movement. You can see. Keep the knee joint in 20 to 15 degrees flexion. You can observe this. You can see. Classical Lachman is positive in this case. Then you have to grade this Lachman. So how much translation is happening in this? Once you keep your thumb over the tibial condyle, normally in a normal individual, there is you can able to pass your thumb between the femoral condyle and tibial condyle. You can able to feel it even in a obese individual. In a thin individual, definitely you can feel more than that. Then once you start translating anteriorly, how much distance it is traveling, coming anteriorly, you can test it. If it is 5 millimeters, it is grade 1, 5 to 10 millimeters, it is grade 2, and more than 10, it is considered as grade 3. Why it is important grade 3 or grade 1 or grade 2? So while you are testing this, always try to keep the limb in a slight external rotation. Never keep it in internal rotation. This is the important thing. Slightly you keep it in external rotation. Then only you do the Lachman. Then only you will get the perfect results. So once it is more than 1 centimeter translation is there, then definitely it is a high grade. High grade indicates the associated lesions. What are the associated lesions with ACL which can produce high grade Lachman? One is lateral root tears is the one, and second thing is the ramp tears. These are the two things you must exclude, and the rotatory instabilities also you must exclude if it is grade 3. These points you must remember while doing clinical examination. So this grading, grade 1, grade 2, grade 3. Grade 3 is more important. You must be specific about that. So how to keep your thumb? Keep the thumb on the joint line and hold the proximal tibial condyle. Then you do gently, you do the movement. You can able to appreciate this. You can see this. You can see this. But one thing, before doing this particular procedure, always this Lachman can be misleading, and it can mislead you. Why? If the patient is having PCL tear, already posteriorly subluxated tibia, while you are pulling upwards, it appears to be it is a anterior cruciate ligament tear. So before doing this particular procedure, you must exclude the PCL lesion, whether it is there or not. How do you exclude? It is a simple painless procedure, that is keep the hip in 90 degrees and keep the knee in 90 degrees. This is a God phrase. You just keep your hold it. Then you see the silhouette of this particular tibial tuberosity. If this is fallen down because of the gravity, if it is drops down, that definitely indicates there is a PCL tear. There is a PCL tear. So once PCL tear is there, then your Lachman appears to be a false positive. So truly this is posterior cruciate ligament tear. So before doing Lachman, always start with Godfrey, then you go for Lachman. This is the order you have to follow. So once Lachman is over, you know that pretty well this patient is having a anterior cruciate ligament. Then you have to check whether this is associated with any rotatory instabilities or gross instability. Most commonly this is associated with anterolateral rotatory instability. But in this, you have to check this. Another test that will confirm your ACL tear is there or not. Keep the hip in 45 degrees flexion and keep the knee in 90 degrees flexion. Then you stabilize the foot and keep slight external rotation, slight. Then you keep the two fingers touching the index fingers touching the hamstrings and keep the two thumbs that is by the side of the ligamentum patellae. Then you feel the joint line. Then you do the, gently you draw it. You can appreciate this. You can see that my thumb is lifting off. Normally I kept it along with the ligamentum patellae. While drawing it, you see that my thumb is lifting off. That means the tibia is translating anteriorly. While doing this particular procedure, two things you must observe. So what is the end point? So is it a soft end point or it is a hard end point? So if you are pulling this, it is like a block that is against of your pull. That means it is a hard block that is appearing. Feel that gives you that ACL is intact. If it is coming just soft rope that is coming out towards you, that means that softness definitely indicates it is a ACL is torn. So whether it is a mushy end point or it is a hard end point, that is the important point you must remember in this. Both in Lachman as well as anterior drawer test. So why you want to keep your fingers here? That means whenever you are doing drawer test, patient is apprehensive. Sometimes they do the hamstrings tightness. Then it never allows it to drop forwards. So in spite of your patient is more apprehensive, what is the best method of examination, clinical examination, is examine under anesthesia. This is the most important thing. The true points of this examination always you will get if you examine the patient in under anesthesia, you will get true grades. Why you won't get normally in an individual? Because the patient is apprehensive, they can do the spasm of these particular muscles that can give you a false grade also, you can get it. The best clinical examination is examine the patient under anesthesia, then you will get absolute clinical examination results. So if the patient is confident, then you can do this. So anterior drawer, Lachman, Godfrey, these all will give you a overall information regarding without producing any pain. Till now patient is comfortable and all the clinical signs we can able to elicit. So once pain is there, patient will produce spasm and he never allow you to examine. These are the things you should remember. So this is for ACL. Once it is over, then you test for PCL injuries. So PCL, the same test, you can do this anterior drawer, that is a posterior drawer test. Keep the hip in 45 and knee in 90 degrees. Then same thing, then you keep your hand and you try to push it backwards. Push it backwards. If you are pushing backwards, if the hard end point is there, your PCL is intact. If there is a soft end point is there, it is a posterior cruciate ligament is torn. Or sometimes you can compare this. If you pass a pen like this, so if the tibia is sagged posteriorly and the proximal end of the tibia is sagged posteriorly, if you keep your fingers like this, then definitely they never touch the patella. If the tibia is sagging posteriorly over the tibial tuberosity, these fingers will go and touch the patella. That is an indirect clinical sign saying that it is a posterior cruciate ligament injury. Then last, you have to test the rotatory instabilities. So these rotatory instabilities, pivot shift test is one important test that is associated with anterior cruciate ligament injury. And this pivot shift test, keep the limb in abduction, a slight abduction, then keep the joint in extension and hold the foot and slightly internal rotate. Then you apply a hand over that and you gently lift it. You can see that. There is a sliding. You can see that at 30 degrees of flexion, already anteriorly subluxated tibia is coming down. It is reducing in its normal position. You can see that. So in this pivot shift test, rotatory instability, there are 3 grades. Always remember this. The first grade, in internal rotation, if you can able to do this particular test, and you only can observe, but the fellow who is beside you, if he is unable to observe this, that means that is grade 1. In a grade 2, the tibia is translated anteriorly, and definitely you can able to observe by everybody, and it is reduced. That is grade 2. And easily that is subluxating anteriorly, and you can able to see that particular test easily. That means it is grade 3. If you easily you can appreciate this particular test, it is grade 3. Anterolateral rotatory instability, if it is there, you must examine posterolateral corners and posteromedial corners and anterolateral corners, and all these things you must examine in these particular patients. Once pivot shaft is grade 3, please remember all these patients may have a meniscal injury, and they have a root tears and ramp tears. These are all associated with this grade 3 pivot shift test. So this is a very important test, and sometimes it is painful. And this can be again graded in, keep it in internal rotation, then you do it, particular test. If it is positive, it is grade 1. And keep it in neutral position, then you do the same test. If it is positive, it is grade 3. And keep it in external rotation, then you do the same pivot shift test. If it is positive, it is grade 3. So grade 3 lesions are dangerous, always you must check. Then last one is the borla padukunnanu okasari. So posterolateral corners, most of the times they are associated with PCL injuries. So you must check for the posterolateral corners associated with PCL injuries. This is by the dial test. So this test is very easy and simple test. You can keep it in the 30 degrees flexion of the knee joint. Then you hold it. Then you see the thigh foot angle. So you rotate externally. So if the patient is getting a normal range, this is 15 to 20 degrees is externally rotated, then both are at equal level. So one limb is more externally rotated, that means then the 10 degrees more than the normal side, then definitely it will be considered abnormal. Then definitely it is considered abnormal. In 30 degrees flexion, if you examine it, definitely it will purely says it is a posterolateral corner injuries. Then you examine the same test in the 90 degrees flexion, then you rotate. So if the both are equally rotating, then that means it is normal. One side, if it is more than 10 degrees, if it is, then the normal side, if it is rotating, definitely that will tell you it is PCL injury. If the both the 30 degrees and the 90 degrees, the rotation is there, then definitely it will tell you about both the posterolateral corner as well as PCL injuries existed in that particular patient. Because both are go together. Anterolateral corner and ACL injuries are both go together. The last one is the meniscus, because all the meniscal tests are painful. That's why, because it needs loading of that particular meniscus. That's why it is better to do meniscal tests at the ending. So that is the safe. So what are the meniscal tests? The best thing is you keep the knee in 90 degrees flexion. Then you feel the joint line. First you feel the collateral ligaments. The most common meniscal tears are seen in the posterior horn, not in the anterior horn. So any tenderness just posterior to the collateral ligaments at the joint line is the best clinical sign that will tell you. And most of the meniscal injuries associated with effusion. And most of the meniscal injuries associated with quadriceps wasting. These are the 3 things you must important. And in clinical history, they will tell you there is a locking. There is a locking. You can see this passively. If I extend this, patient is unable to do the complete extension, you see. This is the one thing where the bucket handle tear you can suspect, where you cannot get the complete extension, it is locked. in that particular position. So, this test, joint line tenderness, is the most important one. Once you come anteriorly, if you are finding the pain in the anterior joint line, it is mostly in a older individual, it is considered to be because of osteoarthritis. Because most of the weight-bearing condyles are on the anterior part of the femoral condyles. So, that will be considered as osteoarthritis. Posteriorly only, that will, you can consider this is a meniscal injuries. Then next is McMurray test. That test is keep the knee in flexion. Then keep it in external rotation. Keep your one finger on the joint line, on the medial joint line. Then you apply valgus force. Then you slowly extend it. You must observe the patient face. If the patient is complaining of any pain in the face, then definitely you must think of there is a meniscal injury. And another important thing, sometimes you may get the click or a sound. You can felt it. So that says it is a meniscal injury on the medial side, because medial meniscus injury is more common than the lateral meniscal injuries. Then same thing, you internally rotate and you apply a varus force, then you keep your thumb on the lateral meniscus, then you extend it. Once you extend it, if the click or pain it is appreciated in the face, then definitely that will be considered as a lateral meniscal injuries. So these are the McMurray and joint line tenderness. But none of the test is specific about meniscus. Even McMurray himself modified his test 6 to 7 times. 6 to 7 times in his publications. So McMurray test is not that much significant, but the best and significant test is joint line tenderness on the posterior aspect. That is the best one. The next one is Stedman's. You can see the Stedman's. In this particular test, there are part 1 and part 2 is there. In the part 1, you just rotate the limb externally and you do the flexion. If you do external rotation and if the patient is getting pain on the medial side, then definitely it is a medial meniscus injury. You do internal rotation and move the limb. So if the pain gets on the lateral side, definitely it is the lateral meniscal injury. These are all positive. You must corroborate with other investigations. That is the important thing. Then another one is, while you are moving it, you ask the patient, is the pain is moving from posterior to anterior or anterior to posterior? That is the more significant, that is the part 2 examination. Okay? And last is, if you don't examine neurovascular examination, your examination is definitely, it is not yet completed. Always you must feel the pulses, always you must examine the sensory examination. Why? Because posterolateral corner injuries can produce common peroneal palsies. So if you don't examine them, you will be in a failure. Thank you.
Thank you very much, Shivananda sir. It was very informative. You covered each and every detail, sir. Let's proceed with the next session of knee MRI by Dr. Venkat Suman sir.
Thank you, Shivanand sir, for detailedly explaining all the tests. I think clinical examination plays an important role in coming to a diagnosis. Unless and until you have a diagnosis clinically, it should corroborate with your MRI. Nowadays, I think many are directly, without the proper examination, they're sending the patients to MRI and coming to a diagnosis depending upon the MRI. I think your clinical diagnosis should confirm collaborate with the MRI findings. Thank you, sir.
Good morning, one and all. I'm Dr. Venkata Suman. I'm a consultant radiologist in Medicover Hospital, Visakhapatnam. So my topic today, I'll just start on knee MRI and essential guide. First, we'll look at the sequences. 10 minutes is the time given to me. I'll try and complete it within that time. So sequences, the PD weighted sequence is the best sequence, or the next would be the T2 weighted sequence. 3 mm slice thickness is must, and the fat saturated sequences help in seeing the bone marrow edema. T1 sequences is just to see for the any fractures or any other loose bodies which are better picked up on T1 weighted images. When we see additional sequences, which will be oblique views or flexion views and small field of views, these I'll go through next. So ACL injuries, either they can be partial or complete. Any tear that is not a complete tear is a partial tear. So most of the tears are, ACL tears are 80% complete tears. When it comes to the specificity, it is more specific and the sensitivity is slightly less. When we see the tears, either it is a low grade, intermediate or high grade when it's a partial tear. And if more than 50% of the fibers are involved, we call it a high grade tear. So here we are seeing on the left the PD weighted sagittal image where you can see the ACL which is taut and continuously seen in a continuity. Anteriorly, the black lines which is marked by the black arrows is the anteromedial bundle, and the posterolateral bundle is shown with the white arrows. These tend to be slightly hyper intense on MR images along the anterior aspect of the ACL, more towards the tibial attachment. And here when we see in the axial plane, it will be more elliptical. The width would be around 11 mm. Next, before going to the tear, we'll see one pitfall where if it is a chronic tear, because of the fibrosis which appears hypointense, which is more black, so it tends to look like it is continuous. And when it is continuous, we think that there is no tear, and it is because of the fibrosis, we can't pick up the tear. Next, we'll see the bone marrow edema, which plays a crucial role. So in the mechanism of injuries, that is the pivot shift pattern, the dashboard, hyperextension, clip injury, and axial rotation of tibia relative to femur. So first would be the pivot shift pattern, where the bone marrow edema is mostly along the posterolateral femoral and posterolateral tibial condyles. And when it comes to the posterolateral femoral condyle, depending on the amount of flexion at the time of injury, the edema tends to be either more posteriorly located if the flexion is mild, and it will be more anteriorly located. That means posterolateral, more anteriorly located in the femur when it is a moderate degree of flexion. So here we can also see a deep sulcus sign, which we'll talk about later. Next, dashboard injury, where it's a contact injury. So the edema will be more on the anterior aspect of the tibia, which is more associated with the PCL tears. So here we can see a complete tear of the PCL at the mid-substance, and another image which is representing a PCL tear which is complete at the femoral attachment. You can also see there is a injury to the posterior capsule. Next, hyperextension injury, which we call kissing contusions. This is more commonly associated with ACL tears, and depending on the stress, whether it is varus stress or valgus stress at the time of hyperextension, it tends to be either anteromedial or anterolateral at the femoral and the tibial condyles. Here on the right, you are seeing there is a complete tear of the ACL marked by the arrow. Next, clip injury, where the force is on the lateral femoral condyle, so the edema will be more on that side. When it comes to the opposite side, the edema can be at the level of the MCL or slightly below. In this case, this would have been an impaction in edema, and if it was more higher up at the level of MCL, it could be because of the MCL tear. In this case, the grading of MCL tear would be a grade 1 or grade 2. Next, O'Donoghue triad also, where you can see that there is an MCL injury and a complex tear of the meniscus and a complete ACL tear. Together they call it O'Donoghue triad. And if there is an associated patellofemoral retinacular tear, then it will be a tetrad lesion. So we'll see tears where a complete tear is represented here. So at the mid-substance, there is complete tear. You see on the other side, small stumps are remaining at the tibial and the femoral level. And in a chronic ACL tear, here you can see that ACL is not at all visualized. It's completely resorbed in this case. Next two would be partial tears. You can see that it is taut and continuous. However, the margins are very hazy and hyperintense. Then next is the partial tear, which we can see that there is bowing, and anteriorly the black line which was shown by the arrow is continuous, whereas posteriorly the fibers are disrupted. So next, the other signs that help us, one is the deep sulcus sign, which I told, where normally the sulcus terminalis is around just less than 2 mm deep. So when there is intermediate to high grade ACL injury and you see bone marrow edema at this level, and if the sulcus is more than 2 mm deep, then that comes as a secondary sign which will be helpful. Next would be the anterior tibial translation, which you are seeing here, and if normally till 5 mm, it is fine, and if it's more than 5 mm, it increases the diagnostic confidence, and if it is more than 7 mm, then it is highly diagnostic. Offa's Padfas injury is other sign, but it's not very helpful. Next, normally in the coronal planes, you don't see the whole, the PCL and the lateral collateral ligament as a whole. You have to go through the images. But here we are able to see this entire PCL and the lateral collateral ligament as a whole in a routine coronal sequences, which is saying that there might be an high-grade ACL tear. Next, when it comes to the PCL, you can see here PCL, the upper part will be horizontal, and then you'll have a vertical portion joined by a geno. So when this horizontal portion is looking more vertical and it is more concave, then we call it PCL buckling. The other one is the PCL line sign. It's not a very helpful sign, but it's rather useful sometimes, where the line drawn from the PCL normally intersects the posterior cortex within 5 centimeters. If it doesn't intersect, we call it as a positive PCL line. Next, I spoke about two sequences in flexion imaging and oblique views. So here, flexion imaging, how it helps is, if we see this, we can call it as a low-grade partial tear. But when you do a flexion imaging at 30 degrees, you can see more than 50% of the fibers are involved. So that would be a high-grade tear. So normally the knee is at 10 to 15 degrees flexion. So when we put it at 30 degrees flexion and do the scan, it is useful sometimes. Next, the oblique view. See, normally we don't see the ACL in continuity. When you are using oblique views, you can see it in continuity as shown here. Next, here it's an oblique axial view. It's a zoomed in view where the long arrow is the anteromedial bundle, and the short arrow we are seeing here is the posterolateral bundle. On the other image, you can see that the posterolateral bundle is not seen, indicating complete tear. Next, the other associated injuries. First, a schematic representation of the posterior capsule. You can see at the level of intercondylar notch, normally it is deficient to allow the neurovascular bundle to pass through, whereas on the medial and on the lateral side, it is in close association with the gastrocnemius. So here a representation where it's thin, and this is the posterior capsule we are seeing here at the level of intercondylar notch. Here you can see that it's slightly deficient, allowing the neurovascular bundle to pass through. The images below are showing complete disruption of the posterior capsule. On the last image, you can see the posterior capsule is thickened from a chronic meniscal injury, and you can also see that there is a fluid cleft posterior to it. So posterolateral corner, we'll go through these one by one. First, we'll see posterolateral corner injury, what we see. So it's, first if you see high-grade ACL tear, you should look at the posterolateral corner. Here we are seeing a grade 2 injury of the femoral attachment of lateral collateral ligament. The curved black arrow you are seeing here is the popliteofibular ligament, which is thickened and edematous, and the posterior capsule is also thickened. So lateral collateral ligament, best to see lateral collateral ligament would be in the coronal and the axial planes. I've put one representation in the sagittal plane, but it's very difficult to pick up. So this would be the femoral attachment, and as we go through, it forms the conjoint tendon, which is attaching at the styloid process. In axial view, as you can see, this is the lateral collateral ligament. The black arrow is the biceps femoris. They form the conjoint tendon and insert more anteriorly to the styloid process, anterolaterally to the styloid process. So a grade 3 lateral collateral ligament injury where you can see this complete disruption from the femoral end, presence of an edema over there, and then this is the biceps femoris, the conjoint tendon attachment, and here you can see a grade 3 injury where it is showing complete separation and a fluid cleft in between. So popliteus tendon, which is a major dynamic stabilizer of the lateral knee, so it also gives off popliteal meniscal fascicles. We'll look at it later. So popliteus tendon best seen in axial and coronal views. So I've given 3 representations. One, this is the popliteus tendon at the attachment. The arrowhead is the lateral collateral ligament. One section below, and further down at the this is the musculotendinous junction. In coronal plane, similar representation where you can see this musculotendinous junction here in the coronal plane, and you can see one small ligament that is running from the popliteus towards the fibula, which is the popliteofibular ligament. So this is a partial tear of the popliteus tendon represented by fluid around the tendon in the sagittal images. But if you want to see the popliteus musculotendinous unit, axial plane would be the best. You can see there is injury to it at this level. Next, popliteofibular ligament, we'll just have a look at it, which is attaching actually more medial, attached to the medial aspect of the fibula styloid process. So this is actually this is not a proper normal appearance, it's slightly thickened. So I thought this will help us understand better. So this is the musculotendinous part of the popliteus tendon, and this is the popliteofibular ligament. Appreciating it on a sagittal plane would be slightly difficult. In axial plane, you can see this is the popliteus tendon, this is the popliteofibular ligament, lateral collateral ligament. This is the biceps femoris, the conjoint tendon lower down, and you can see a small dot here, that is the popliteofibular ligament. So the medial supporting structures, we see there will be 3 layers. First is a superficial, intermediate, and deep layer. So we'll go through one by one. So a schematic representation first. So in the schematic representation, the blue one is the superficial layer, which is formed by the fascia. And then the orange one is the medial collateral ligament. So and anteriorly, they fuse and form the patellofemoral retinaculum. The deep fascia and the deep capsular ligaments are represented in the green. So this is axial view. These 2 images showing the superficial and the intermediate layer. So coronal would be the best to see the medial collateral ligament, which is almost inserting 6 to 7 centimeters below the level of the tibia. But in order to see the deep layer, the meniscofemoral and meniscotibial ligaments, it would be slightly difficult. So sometimes when there is fluid that forms, here you'll be able to better appreciate it. This is the meniscofemoral and this would be the meniscotibial ligament. So grading of injuries, the third grade 3 would be complete loss, grade 1 would be fluid adjacent to it, and grade 2 would be signal change within the ligament along with fluid. So here we can see the first one, there's fluid adjacent to the medial collateral ligament, calling it a grade 1 injury, and when there is a signal change within the ligament and fluid adjacent to it would be a grade 2 injury, and when there is complete disruption as shown here in the third image, that's the grade 3 injury. So next, MCL grade 3 with an ACL tear, which is shown. You can see cussing contusions here, a complete disruption of the MCL, and then there is also an injury to the patellofemoral retinaculum, and you can see complete ACL tear. So here a Steiner-like lesion with an MCL grade 3 injury, where distally the MCL is completely torn. The pes anserinus tendon is actually trapped in between the MCL and the tibia. Normally they lie between the superficial and the MCL, the pes anserinus. So normal meniscus, I have 5 more slides, I'll finish it up. So meniscus, so in the lateral sagittal views, you can see that this gives a bow tie appearance at the level of body. The anterior and the posterior horns, normally the free margin should be sharp and clear, as we can see here, and this would be the meniscal root. axial planes and sagittal planes are also good to see the meniscal root. So before going to the meniscal injury, we'll see common anatomical structures that can mimic a tear. So first, we can see this is adjacent to the anterior horn. You can see, we might think that this is a tear, but when we see in axial, that is the transverse meniscal ligament. And the other two, which can give we might think that it's a double PCL sign, where you can see the meniscofemoral ligaments, anteriorly the Humphrey and posteriorly the Risberg. So other things would be popliteal meniscal fascicles, and a discoid meniscus I have just given for representation here, where normally the length would be 15 mm, and if it is should be less than 15 mm, and if it is more than 15 mm, you should think of discoid meniscus, and also if it is seen in more than 2 sections. So tear patterns, we'll just go through quickly. First would be the horizontal tear. When you see a parameniscal cyst, it increases the diagnostic confidence. So this is the horizontal tear to the posterior horn. Then a longitudinal tear. So normally this longitudinal tear tends to be more along the periphery, and they have high association with cruciate ligament injuries. So next, the ramp lesion, which is also a vertical tear, longitudinal tear, that is more along the meniscocapsular junction of the medial meniscus. Next, radial tears, we'll go through just few signs. One would be the cleft sign. Then you can see a truncated meniscus and a ghost meniscus. Whenever you see a truncated meniscus in a coronal plane, you should always look for a bucket handle tear.
We are out of time, sir. Let's conclude.
Last quickly. 2 slides, sir, I'm done. So the displaced meniscus would be in the intercondylar notch. This is a complex tear when it's there in 2 planes. This would be a bucket handle tear, but however it is seen more towards the intercondylar notch because of an associated ACL tear. So here I've just given this is a double PCL sign where the tear from the medial meniscus is towards the PCL. Next, 3 indirect signs. One I've told you, parameniscal cyst. Next would be the meniscal extrusion. When you see if it is more than 3 mm, there is a high possibility for a root tear. So then this is just a small subchondral edema which you are seeing adjacent to the meniscus, which increases the diagnostic confidence. Thank you.
It was excellent presentation, sir. You covered every detail. Let's proceed with next session. Dr. Sandeep, sir, want to show the ramp lesion repair live video. Let's proceed.
Sandeep sir, can you hear us?
You want scopy picture?
Sandeep sir?
Yeah.
Yeah, are you audible?
Yeah. So I'll show you the scopy picture. So patient, he had a ramp. So we have repaired the ramp. And there was also meniscocapsular tear. 1 second, sorry, leave it. So I have put one fast fix there, all inside here. Can you see?
Yes, sir, yes, sir.
Yeah. So it is stabilized. And ramp, I'll show you. Leave. So I have passed 2 sutures and taken knot there.
Okay.
The Visinger rod. You come here, sister. Hold this leg. Unfortunately, we have removed the cannulas. Yeah, hold this. No, cannula. I'm sorry, Visinger. So with the help of fast fix, I have done, can you see?
Yes, sir. Yes, sir.
So I have taken 2 knots, one far lateral, and then this one. You can see the second one here.
Yes, sir. I think
one stitch
not
here.
Able to hear.
Yeah, one stitch here.
Yes, sir. Now we can
Yeah,
see. Yes,
and then
sir.
second was more medial.
Okay.
And then there was one all inside.
Okay. So totally 2 and.
See.
Okay.
Totally 2
Okay,
for
sir.
the ramp.
Okay. Yes, sir. Thank you, sir.
Yeah,
Thank you for nice demonstration.
Thank you. Yeah.
We'll continue with the.
Yes, I'll join you in 20 minutes.
Thank you, Sandeep, sir.
Yes.
I think we are going ahead with the talks.
Yeah.
So I would like to invite Praveen, sir, to give his talk on diagnostic arthroscopy and portal making of the knee. I request the speakers to kindly maintain the timeline. We are already lagging behind. So please maintain the time.
Good morning, everyone. On behalf of IAS and Andhra Pradesh Arthroscopy Society, I welcome you all. Today I am going to discuss about a very basic topic, diagnostic arthroscopy and portal making of the knee. This is very essential for the beginners, and I want to make it more interesting. Let us go ahead. So, as you know, the indications of arthroscopy ranging from diagnostic to therapeutic, different indications. These are all the indications. And the key point to remember in making the surface anatomy is that the lateral tibial plateau is usually at a slightly superior to the medial tibial plateau. Making the surface anatomy will facilitate the accurate placement of the portals. So if you see the surface anatomy, this is the joint lines, and just above the joint line, we have to go for the portals. The primary portals are the viewing portal main is the anterolateral portal. It should be placed just superior to the lateral meniscus and close to the patellar tendon. It is a standard portal. And the anteromedial portal, after going inside, we'll decide, after diagnosing the pathologies, we'll decide depending on if the PCL is there, we will go close to the patellar tendon. If it is a ACL, we go little bit lower and little bit medial also to the patellar tendon. So the vertical incisions have the advantage of increased superior and inferior mobility of the instruments, and horizontal have the advantage of increased mediolateral mobility of the instruments. The secondary portals, making a posteromedial portal will be difficult for the beginners. If you follow the guidelines, it is very easy for making the posteromedial portal, and this helps in posterior cruciate ligament reconstruction and avulsion fracture fixation of the posterior cruciate ligament, meniscal repairs, and ramp lesions. So I use a trans-illumination technique in identifying the posteromedial portal. So these are all the anatomy and the surface marking. I go with a under trans-illumination, under arthroscopy guidance, 18 gauge spinal needle, and this helps in identifying the ramp lesions. So accessory other portals are the posterolateral portals. Transportal, central transportal was suggested first to complex meniscal lesions and subsequently for a better femoral footprint view during reconstruction of the ACL. So I use far medial and far lateral portals, especially for removing the loose bodies. So diagnostic round, Sandeep is already shown us in the first live surgery. So instrument setup, this is my instrument setup. This is very important for me. Oh, back. So what we should have, all the graft master board and the tension device, and this is a small video showing the instruments, and position and setup is important. This will help us in hassle-free surgery. Otherwise, we will struggle for waiting for the instruments and all. So always keep ready for all the meniscal repair systems. So this is the diagnostic round, where I go, see the patellofemoral joint and suprapatellar pouch, and then go on the lateral side, lateral gutter, and you can see a lesion there, and ACL tear, lateral femoral condyle, and I go medially, medial gutter, and this is an ACL lesion. So if you go close to the medial to the patellar tendon, and your direction will be away from the femoral footprint. So I will take much more medial point, and that point helps in better fixation for the femoral tunnel. So after identifying the lesions, then I will put the medial portal. And here, yes. So if you go too close, that will help to treat the PCL lesions. And if you go a little bit medial, much more medial, then your trajectory will go directly to the femoral tunnel. These are all small tricks that will help in hassle-free fixation for the pathologies. And then sorry. So this is I go through the trans-illumination technique to the posterior compartment, posteromedial part, and posteromedial portal. And I always check for the ramp lesions. For every knee, I check, I pass the needle, and I stretch the capsule and see whether there is any ramp lesion or not. This is very important because so many ramp lesions will be missed, and patient will not be happy after doing the ACL alone if the patient is having ramp lesions also. So this is another patient where I went in. I have seen that there is a meniscocapsular separation and a ramp lesion there. And making the correct portal placement will help in the passing the instruments for the lasso instruments and repairing it. That is all important. If we are unable to put the correct placement of the portal, then you will have a difficulty in triangulation. So here I pass the lasso, and then I took a bite, yes, of the ramp. And with this simple posteromedial portal alone, I tied and fixed the ramp lesion. So this is all about posteromedial portal. The correct placement will help not only in identifying but also in treating the ramp lesions. So this is another video where I want to show you that after going into we have to probe every meniscus. So because sometimes we may miss the undersurface tears. Without probing, we cannot diagnose the undersurface tears. This is one of the example where I have an undersurface tear, which I will show you. See, there is undersurface tear. Superior part is normal, but there is undersurface tear. If you diagnose and your trajectory of the portals are correct, then you can fix it within no time. Within 5 minutes, you can fix it with a all-inside meniscus repair system. That undersurface tear can be taken care easily. So placing the portals is very important in treating the things. So this is another video, it's a small one, where if your lateral portal is perfect, viewing portal, if you go in and turn your camera, you can see your entire femoral tunnel. So this helps in identifying the femoral tunnel. Only 2 to 3 millimeters of, 1 to 2 millimeters of posterior cortex is left, and it helps in the ideal placement of the tunnels. So as you know, the complications, iatrogenic articular cartilage damage can happen. Beware with your instruments and hemarthrosis, neurovascular injury. The posteromedial portal, if you keep the portal in 90 degrees of flexion, you can avoid saphenous nerve injury. So the take-home message is diagnosticoscopy is very much essential in identifying the pathologies. Always look for root and ramp lesions. Take time in probing meniscus. Beware of undersurface tears. Instruments and setting up position and portal placement are essential for hassle-free surgery. Thank you.
Thank you, Dr. Pavan, sir. Next, graft harvesting technique by Dr. Sridhar Gangavarapu, sir.
తీసేయాలి కదా. ఆడియో ఆపేసారా? ఆడియో ఆపేసారా?
Okay, sorry for that. So I'm going to just show two videos of graft harvesting techniques. One is hamstring graft and peroneus longus graft. So the debate comes where you want to use which graft. So using a quadriceps BPT graft or a hamstring graft is a long run of debatable issue. So most of the surgeons, some prefer BPT graft where they have shown very good results, and some surgeons have showed hamstring graft and they do very well in their hands. So always literature or a personal experience according to different surgeons, whether it's in a BPT graft or in a hamstring graft, this is always a debatable issue. But what are the other graft options which has recently come up is a peroneus longus graft, quadriceps tendon graft. So many graft options have come, especially if you have a multi-ligamentous injury. So when do you prefer a hamstring graft? So if in my personal experience, if I do any isolated ACL, I always use a hamstring graft because I am not a fan of a BPT graft as such when I am trained. So I personally use all hamstring grafts. All my ACLs will be done by a hamstring graft. If the graft, I take semi-T. If the graft is thin, even after quadruple, I take both semi-T and gracilis. So where I don't take hamstring grafts, if a patient has a medial side injury, So patient has a medial side MCL injury, or patient had a contusion, or patient has an ACL and PCL, patient has a multi-ligament injury, then I take a hamstrings along with the peroneus. And if patient is a sports person or an athletic, or patient has any football player or something with the foot, then I go for a bilateral. So opposite side hamstrings, usually I prefer on the both sides. So if I take a hamstring graft, usually if a multi-ligamentous injury, so use a semitendinosis for an ACL, peroneus longus for the PCL, because we get a very good thick graft diameter with a long graft, and use the gracilis for MCL reconstruction, or if you want to reinforce the MCL. So I just quickly finish that run through because this has been quite a number of time showed today. So this is the surface marking of hamstring graft harvesting. So we mark this tibial tuberosity and medial shin. So we have seen that today morning, Dr. Sandeep has shown that. So what happens is, it depends on how you are trained. So either you take a vertical one, you take a horizontal one, or you take an oblique one. So whatever you are comfortable with incision, you can take it out. So I tried vertical, horizontal, everything, but recent times, usually I am going for an oblique one. So oblique one allows me to go either anteroposterior or mediolateral. This is an older video where I am doing a vertical one. So once we are exposed it, so go for the sartorial fascia. So once you can expose the sartorial, here you can see nicely sartorial fascia. Recent times, I don't cut the sartorial fascia completely. So usually what I do is put a nick on that and try to loop out the tendons. And now recent times, usually I don't stitch the tendons. Take a loop around the tendons and take out the tendons hanging out and take out with the stripper. So once you identify the tendons, you release them. And once you identify both the tendons, so unless you see gracilis and semitendinosis, hamstrings, both hamstrings, unless you identify them, don't try to cut it off everything. So because once you cut the sartorial fascia and once you are inside, so you don't know whether you have cut the tendons or you have cut the sartorial fascia, you don't know anything. So unless you identify both the tendons inside, never try to cut it down. So once you identify, loop the tendons or identify and stitch the tendons, then you try to take it out. So we just marked it with gloves. So once tendon we have looped it out, so isolate it. And another, especially for the young surgeons or junior surgeons, is unless you release the tendon up to the fossa, never try to put the stripper in. So usually as an enthusiastic young surgeons, our main motto, or seeing so many senior surgeons, we feel that once you keep the stripper in and push it in, you will get the graft out. But that never happens. So unless you release it, you see all the, see you can see the bands here. So unless you release all the bands, and other technique is once you pull the tendon, it has to cross the tibial tuberosity. So you have that elasticity, tendon slides out up to the tibial tuberosity or past the tibial tuberosity, then you know that it is released sufficient length, then you can take a chance of taking out the graft. So if you can't see the tendon full length, or if the tendon is not released completely, if you see the enough bands, never try to put the stripper inside. So once it is released, so you can see when you pull on that, you have that elasticity. So this is what I'm showing here. If the bands are not released, this is how the graft have premature cuts. So once you are released completely, whether if you can see it, the stretchability, so that is the time where you put your graft in and do it. And especially another thing, if you're an young surgeon starting off, never use open strippers. So once you are well versed with that, you can use an open stripper, but as an enthusiastic or an young surgeon, always use closed stripper, because if you use an open stripper, there is a high chance you skip out of it and you can cut other structures inside the joint, because you don't know where it is passing through. So once the stripper goes in, once you released it, you can take out the tendon and repeat the second process. So always you spend enough time to identify the tendon, to know the stretchability of the tendon, cut all the attachments of the tendon. So whole time goes only on identifying and releasing the tendon. So once you release the tendons, you know that tendon is completely free, then only you put the stripper. Never put the stripper initially itself. So again, repeating the same thing. So once it is done, released, you can take a nice tendon and then go for a graft preparation. Next video. So next one is a harvesting of a peroneus longus. So if I do a multi-ligament injury where you are doing an ACL and PCL or an MCL multi-ligamentous injury, usually we prefer peroneus longus because peroneus longus is thick enough and patient gets a good length and thicker graft. So this is the surface marking. One should be very familiar with. There is a sural nerve going posterior to the peroneus longus, and near the fibular head you have a common peroneal nerve. So unless we don't keep it in this mind, there is still chance you can injure both the nerves at the ankle and at the fibular neck. So you take it 2 to 3 centimeters from the tip of the lateral malleolus, extend it, and try to identify peroneus longus and peroneus brevis. So how you identify peroneus longus and brevis? Usually brevis is more of muscular, have a lot of soft tissue attachments, and peroneus longus is a quite very white shiny structure without any attachments and very easy to identify. So brevis you can see attachments with the synovial membrane and other facial things. Once you identify it, leave out the peroneus brevis, take out the peroneus longus. Most common problem with peroneus longus is it will be thick enough so that your tendon stripper mouth doesn't go in. In that stage, you can nibble it or shape it out in a star mark. So you make it like a triangle because whole tendon doesn't go inside the tendon stripper because the peroneus is very thick enough, it doesn't fit into our stripper. So then you have to cut it the mouth in a fish mouth margin. So once it is through, then you try to pass on the graft stripper in. So this I am showing the peroneus brevis with attachments. So just to confirm that what we are taking is a peroneus longus, what we left behind, what I showed now is a peroneus brevis. So you can see here it is passing inside. So once I do this, I'll ask my associate to keep his fingers on the fibular head. So I just don't want to rush in and damage any peroneal nerve. So I ask my associate to keep the femoral hand on the femoral neck and keep 4 fingers. So from 4 finger breadth below the fibular head, you are in a safe zone. You are not going to injure the peroneal nerve. So once that is done, you can try to harvest it. So you can see the stripper going in. And you will get a very good lengthy, thicker graft. So you can see that. So you can see. So you will get a very lengthy one and a thicker graft. I think I have one. So this is what we prepare. And this is for comparison. Hamstring one with the peroneus graft. So that's what we do. Thank you. Thank you so much.
Thank you, Dr. Sridhar, sir. Next, we shall proceed with lamp lightning inauguration program. We invite Aslam, sir, to take over.
We'll get on with the function after this speech. Of late, we've seen a lot of multi-ligament injuries, and it is important that we are well versed or at least familiar with harvesting all the other grafts. We've seen that hamstring is quite common and familiar. Peroneus also is catching up. But somehow, surgeons are a little shy away from taking the patellar tendon graft. As we've seen that professionally, a lot of people are taking up into sports, and a few of them do require a robust tendon. Okay, we will not get into too much of theory. But we are very fond of looking at our anatomy, and we normally want to replicate anatomy as far as possible. So looking at the anatomy of the ACL and trying to replicate or get a graft closer to the anatomy would rather be good. So we just get back and see relook at the anatomy and see what it really shows. Okay. This was a study done earlier by Smijelski et al. And they looked at the anatomy of the ACL, the shape, and found it to be looking more flat and a ribbon-like ligament. Right. Here you can see that once the soft tissue is stripped off the ACL, it looks more like a flat ribbon-like structure. Okay. A dissected section showing the ACL and a dissected segment of the ACL. Okay. And this doesn't have a very groupish kind, anterolateral and posteromedial kind of bundles, and it is not round at all. This is quite flat. Okay. Of the options on hand, quadriceps and patellar tendon do simulate this kind of an anatomy. So why not get familiarized with one of these techniques? So I'll be demonstrating today a very simple technique on how to harvest your patellar tendon. All it requires is a little hardware. You see here further that we see on the femoral condyle, on the attachment on the femoral condyle, the shape of the ACL. Okay. It goes down from the posterior femoral condyle, from the cortex, the line of attachment, okay, and the tibial insertion around the anterior horn of the lateral meniscus. Okay, if you can appreciate, right. So now we'll get to the harvesting technique. This is a little older video, okay, and I've taken a long incision, midline incision. This is a freehand technique. If you can familiarize with yourself with, is marking the middle third. Slide your blade down the fibers without too much of pressure, and the blade will find its way to the tuberosity, separated from the underlying fat pad. Mark your tibial bone peg. You can either harvest the femoral side first or the tibial side first, but familiarize yourself. For me, it makes it easier to first take the tibial peg off. And then I will show you a modified technique on the femur side. You hold your blade vertical. This is a very nice blade from Stryker with a very high RPM, which gives you very fine cuts. Connect your corners. Use an osteotome just to separate it and lift it off the bed. You don't need too much of force to do this. Just your fingers are enough. Separate it from the fat pad so that you can see the undersurface of the patella. Just use a wrap-up gauze so that you can have control on the distal segment. Then mark your femoral cut, patellar cuts. You can mark in 8 mm or 7 mm on your blade before you start this cut so that you don't go deeper into it. Sometimes the patella vibrates, so your assistant could hold it for you. Just by pulling the patella down, by holding the tibial peg, you could control, connect your vertical cuts. Separate the soft tissue so that your blade doesn't entwine in, because this is a critical step. Gently lift it up, slide your blade down 7 to 8 mm, which you will get gradually, and just lift it off. So now you have a good 10 mm patellar tendon with very good bony pegs on both the tibial and the femoral side. Okay. A lot of people have a apprehension that you could have patellar fractures. So the graft that, or the bone that you harvest from the tibial peg, you can graft it back onto the defect and suture the paratenon on top of it. And you will get very good results and they heal up very quickly. Preparation. Inko video on the preparation. Just a little bit on the preparation. Okay. Once you have the graft, forward check. Okay. Fast look at it. In the patellar tendon, you normally see that the preparation is normally done by the surgeon. You don't trust your assistants, because if you don't do it well, then you will have difficulty in passing the tendon through in the joint. Okay? And this, slow. A lot of surgeons would like to drill holes before taking the graft off, but I'd like to do it a little later, 4 to 5 millimeters away from, and it's quite simple. One on the patella and one in the tibial pegs. I use ethibond on the femoral side. And SS wire on the tibial side. Only reason is that when you tighten the graft, you can put a lot of stress, and sometimes it happens that while passing the graft, your ethibond could tear and break. So SS gives you more stability, strength, and you can take the slack off before fixing the tibial peg. Thank you very much.
Thank you, Aslam sir. A nice demonstration of BTP graph. I think we'll have an inauguration ceremony now.
Later the session will be chaired by Dr. Uday Kumar sir and Bhavani Prasad sir.
I request all the faculty to be on the dais, please. Okay. So I request Dr. Shivanand sir to be on the dais, please. Thank you, sir. Thank you for gracing our occasion. I request Dr. Rajiv Raman, sir. Please come on to the dais, sir. Please receive a bouquet from our organization. Thank you, sir. Thank you, sir. Thank you for coming. Sir, please be on stage, sir. I request Dr. Mukesh Ladda, sir. Please be on stage, sir. Thank you, sir. Thank you very much for coming and gracing the occasion. And I request Dr. Chirag Thans, please come on to the dais. Please come. Thank you. Thank you. I request Dr. Vikram. Please come on to the dais. Yeah. Yeah. And I request Dr. Ramohan Reddy, sir. I I request Dr. Sandeep, Secretary IAS. Thank you. Please receive a bouquet, sir. Thank you. And I request Dr. Venu Madhav. Sir, I request Dr. Achyut Rao, sir. మీరు అవ్వండి. థ్యాంక్ యూ సార్. చెప్పండి. I request Dr. Shivakumar, please come on to the dais. Dr. Abdul Khan, Ashish, please come on to the dais. Raviteja, please come on to the dais, please. Dr. Raviteja? I think he's not here. I request Dr. Venkat Suman garu, please come on to the dais.
Sir, we'll have one faculty photo, sir, just. Proceed with lamp lightning, sir. We request our Meniscal Hospital Group Vice President Padma Chigaru and our unit head Sridhar Garu also, please join us. So we hosted all our surgeries from our Meniscal Hospital operation theaters. So they are very kind enough to provide all the infrastructure and all the equipment from our hospital side. Thank you, ma'am. We are very thankful to our hospital management also. Sandeep. Sandeep, lamp lighting. Antana, lamp lighting chepistan.
Sir, I request Dr. Uday Kumar sir and Bhavani Prasad sir, please come and join the lamp lightning, sir.
So I request Dr. Sandeep Biraris to, so I just want few words from other faculty, because once we start off the session, everyone will be busy rushing through all the live surgeries and to catch up the written flights. So what we are doing is we'll ask them to speak a few words and we will give them the mementos now itself, so that we can have a smooth run of our academic program now onwards. So I ask Sandeep to speak few words regarding our IAS One program.
So, thank you, Dr. Sridhar, for arranging this conference in a very short span of time. Means I am thankful to Dr. Sridhar, Dr. Praveen Kumar, Dr. Aslam Arif, Dr. Shivananda sir, and all the members of Arthroscopy Association of Andhra Pradesh, Orthopedic Surgeons Society of Andhra Pradesh, and North Andhra Orthopedic Association, and also Medicover Hospital, for making the arrangement for the CME in such a short span of time. On behalf of Indian Arthroscopy Society President Dr. Sachin Tapasvi and the whole Executive Council, I am thankful to all of you for registering for this conference. And my sincere request, Indian Arthroscopy Society is a body of over 3,500 life members. So my sincere request, the ones who are not members and who are interested in the field of arthroscopy, to become a member and join this society and consider it as your own society. And the ones who are already a member, and if their contact details are not updated, kindly get in touch with Aslam Arif sir, Praveen Kumar sir, or Dr. Sridhar to get it updated. Thank you very much.
Thank you, sir. So Raji Raman sir, few words from your side regarding IAS and our IAS One program.
So IAS One is a brainchild of Sachin Tapasvi sir, and I think Sandeep is carrying it forward. The first meeting was in Durgapur. We did it in West Bengal, and after that, every month we have a meeting. And under dynamic leadership of IAS Executive Committee and our President Sachin Tapasvi sir and our dynamic secretary Dr. Sandeep Biraris, we are looking forward for more such courses in Tier B city of all states of India. And thank you, Sridhar and Sivananda sir, for organizing this event. And thanks to the Mediversal Hospital for making this possible.
Thank you, sir. Thank you. Shiv Kumar sir, please sir.
First of all, I thank the organizers for inviting me to this IAS program. I and Sridhar are very close friends. We started Arthroscopy Association of Andhra Pradesh 4 years back, and it is running successfully, and we are doing good programs. And we thank all the IAS members and all the faculty for coming here and sharing your experiences. Thank you all.
Thank you, sir. Ramon sir. Sir from Hyderabad came all the way for us yesterday.
Yeah, thanks a lot to the Indian Arthroscopic Society and Dr. Sridhar. You're doing a fantastic job. When he said yesterday, I'm putting down a 10-kilometer cable, are you mad? That was my thought. But that shows on the videos, such crystal clear pictures. Unless you plan, unless you have a dream and execute it properly, it is difficult to do such a meeting. I have not been able to do one in 12 years. So Sridhar, very good job. And I've met definitely a few friends. My first trip to Vizag, and I hope I will come a few more times in the next few years. Thanks a lot.
Always welcome, sir. Uday Kumar sir.
First of all, congratulations to the IAS AP branch for organizing such a wonderful conference in the very, very short notice, I believe. And today I am very happy to meet my friend Dr. Raju Raman. In fact, I have registered for this conference only to meet sir because I am not an arthroscopy surgeon. Anyway, having come here, I thought I had done a right thing for registering. Anyway, I would like to see national conference here, sir. All the IAS bosses are here. In future, maybe coming in 3-4 years, we want to say the national conference at Vizag. I'm sure you must have enjoyed our ambience and the view from your Novotel hotel. And thank you for coming over here. Hope you enjoyed our hospitality. Thank you very much.
Thank you, sir. Bhavani Prasad, sir.
Good morning, all of you. I congratulate Indian Arthroscopy Society, Visakhapatnam branch, Adi Guru of Arthroscopy in Vizag, Aslam Arif, Sridhar, Praveen, Ashish, and it's a fortunate thing that we have all the stalwarts of Arthroscopic Society here, and we should utilize this opportunity to gain tricks and tips from them, and I wish good luck for this conference.
Sir, Achutrao, sir. One word, sir. Sir has come as not like ortho, sir is a APMC observer.
Congratulations for Vizag team, and thank you very much.
Thank you, sir. Padmaja ma'am.
Good afternoon to everyone. I personally thank IAS to giving this opportunity to Medicover Hospitals for being part of this fantastic program. And my heartfelt thanks to Sridhar sir for taking the entire responsibility on behalf of Medicover Hospitals to take this forward. And I have one more request. We have many hospitals in Tier 2 cities in Vijayanagaram, Srikakulam and Kakinada and other places. We'll be very happy to associate for future programs. So we will be very happy if you consider us. And I request Sridhar sir to take forward from here.
Sure.
Thank you.
Sridhar sir, just 1 minute. That's it.
Well, very good afternoon to all, and it's very honored that to be part of this IAS, and thanks for choosing us one of the partner to be to associate to having this event today, and I hope such kind of events to be more ahead, and congratulations once again to everybody. Thank you.
Thank you, sir. Thank you so much. We'll take one photograph. Secretary. Thank you, sir. Thank you. Uday Kumar sir and Bhavani Prasad sir, we request you want to stay back, sir.
Shall we start?
So, because all the faculty are together now here, we'll just give them an honor with mementos. Then we'll disperse for the coffee break and we'll proceed with the other session. So we'll start up. We request Shivanand sir to come on to the dais and receive the memento. Shivanand sir, please. Vinay. So I ask Dr. Sandeep Biraris. Rajiraman sir, please sir. Mukesh Ladda sir, please. So I request Dr. Chirag, please. Thank you, Chirag. So, Dr. Vikram. Dr. Ramohan sir, sir please. Dr. Ayappan Nair. Dr. Venumadha sir. Dr. Aslam Arif sir. Dr. Praveen Kumar sir. Dr. Shiv Kumar sir. Shiv Kumar sir, Papa Rao sir couldn't make it because he has some personal work. We want you to receive the same from on our behalf. Dr. Abdul Khan sir. Ashish Kumar sir. Dr. Raviteja. So, Dr. Sachin Tapasvi sir is supposed to be in our meeting and need to perform on live surgery, but he's abroad, has gone for some presidential talk in Vietnam. So we missed him, but we have a recorded talk from Dr. Sachin Tapasvi, president of IAS now. So you well known maybe Pune knee course from Pune. So because he is not here, on behalf of IAS One Visakhapatnam, we want Dr. Sandeep Birarish to take out the moment for Sachin Tapasvi sir.
And to the chief organizer and man of the day, Dr. Sridhar Gangavarapu. Who has given us such a wonderful conference. We'll break for 10 minutes and be back with the next session. So don't take long. We'll be back in 10 minutes. Thank you.
make perfect ACL tunnels. Dr. Mukesh Radha, I request Mukesh Radha to come and proceed with his talk.
Thank you, Shri, and thank you, whole Andhra society, for inviting me. Instead of perfect ACL tunnel talks, I'll give you some different concept of how I am doing the ACL with some different rectangular tunnels. And during my surgery, I'll show you all the landmarks of how to make an exact anatomical tunnels. I'll start it. We all know we are yet evolving how the anatomy of ACL is. Some says it's a ribbon-like, some says we have double bundle, some say we have triple bundle ACL, some say it's circular, the broad. So if you see the original ACL, it has a very broad attachment on the tibial side, mediolaterally as well as antero-posteriorly. Even on the femur, if you see, it's not a circular shape. It's somewhat oval. You see the original attachment of the ACL on the femoral side. And if you view from the posterior-medial portal, see the attachment of ACL on the femoral. It's very big. It's not a small, simple circular tunnel. So the original footprints of ACL are not circular, somewhat rectangular or oval in shape. And maybe in the central part, it may be ribbon-like. And if you see the footprint, it's never circular. It's rectangular. It's more antero-posteriorly compared to mediolateral. And even if you see whenever you do any open surgery, say for TKR or anything, and if you remove the stump of ACL, you will see that's the footprint of what the ACL looks like. And here also, if you see the ACL footprint after you remove the ACL, it's not circular. On the tibial side, the antero-posterior is more compared to mediolateral. That's the lateral meniscus, that's the tibial spines, and that's the whole footprint. So it's not circular. Even on the femur side, lot of discussion have been done, and we all know that the footprint of ACL also is not what we'll say is circular, but it's somewhat oval. If you see the shape here and what you see in your arthroscopy view, that's the whole footprint of ACL, more so superior, inferior, and less antero-posteriorly. But and what we are creating is the circular tunnel in the oval footprint. So can we do something to enhance the surface area of the ACL by converting the circular tunnels to a rectangular tunnels? We all know the more footprint coverage was given by double bundle ACL, and it was very well popularized by Freddy Fu. And we all know biomechanically it gives more antero-posterior and rotational stability, but they have a lot of troubles also. So another study from Freddy Fu itself says that whatever graft are available, none of them is matching the footprint of the original ACL and PCL. None of them are near whatever we are doing it. So even the double bundle ACL came, it covers more, but we all know the fate of double bundle. It's double trouble and no one does it. So now Semlinsky has come out with a ribbon concept. The ACL is very thin. So we are still getting to know what kind of original ACL is. And is rectangular ACL the new thing, or whether it has been tried? It has already been studied in 2014 that the rectangular ACL reconstruction resemble more normal knee behavior in Japan. They have even studied the rectangle with the round tunnels, and they found that rectangular ACL tunnel significantly lowers the anterior tibial translation. And even why oval tunnel? The benefits of oval or rectangular is that it gives larger surface area, closely resembles the anatomic ACL insertion, advantage of good bone tendon healing because you have good rotational stability in the rectangular tunnels, and the dilator technique provides more mechanical stability. Even the clinical studies have been done with the round rectangular tunnel, and it shows that the rectangular tunnels have more stability compared to the rounded tunnel. So this is what I have designed in my city with the small carpenter. These are small rectangular tunnel punches which comes in size of 7, 8, 9, 10. And the 7 size comes in the form of 7 by 7.5, 7 by 8, 7 by 9, and 7 by 10. So usually why it is so, I'll let you know in next, and we have got the patent from Government of India for the same. So this is a small video what I have done on cadaver. This is the whole original footprint of the ACL on the femur. What we usually do, we make a circular tunnel in this whole footprint. And we know we create more of an AM bundle, or sometimes we are in the middle. Sometimes, if you're not wrong, you are more on the PL side of bundle. So with this kind of rectangular tunnels, which the anterior-posterior thickness is same and slowly it increases, we punch and convert the same oval tunnel into the rectangular tunnel. So you can see the footprint difference between this circular tunnel and the same circular has been converted into a rectangular or oval type of tunnel. So it has increased the footprint coverage area. Similarly, on the tibia, if you see, that's the original footprint on the tibia after you remove the complete ACL from the tibial side. And this is what we are recreating it with the help of our special rectangular tunnels. You have to just punch it from the way you make the circular tunnels. And you can see we are recreating what the footprint is mentioned in the literature, and the same we are recreating with the rectangular tunnels. Now, what type of graft to pass with it? So you take your routine hamstring graft, and if suppose you have a 9 mm diameter, you start drilling with 8 mm. So the pilot hole which you make is of 8 mm, not 9 mm. And and the tunnels can be dilated. Now, if you have 8 mm femoral or tibial tunnel, and you have a 9 mm circular graft, but I have drilled first with 8 mm, so my dilators are 8 mm mediolaterally, and then sequentially they are increasing to 0.5 mm anterior-posteriorly. So the dilatation will convert that 8 mm circular mediolaterally to 10 mm anterior-posteriorly, 8 by 8.5, 8 by 9, 8 by 10, and 8 by 10.5. So final, the mediolateral will be 8, but anterior-posterior will be 10 mm. And your graft size is 9 mm. So this is a graft squeezing technique because the graft will take the shape of the tunnel. It's 9 mm, so mediolaterally it will squeeze, but it will expand to 1 mm anterior-posteriorly. So the 8 becomes 8 by 10, and you can use your same implants, whatever you are using it, and it's very easy to pass the graft the way you are passing it. And once you finish that, there's the final fixation, and it mimics like you have recreated 2 bundles with a single tunnel. So this is the anterior half of the tibia going medially, giving the anteromedial bundle. This is posterior going laterally, giving a posterolateral bundle. And in the flexion, you can see the AM bundle is tight. And as you extend the knee, the AM bundle, the sort of AM bundle, it will become lax and PL becomes tight. So it's a single tunnel with a sort of double bundle-like effect, converting just the shape and using rest of the steps, whatever you have. So if we calculate simple mathematical, we'll increase the surface healing area by 25%, and we will be here somewhere with our normal semi-TN graft and then circular. We are at least very near to the complete femoral footprint and extend somehow to the tibial footprint as well. So practically, how can we do it? So this is what you usually do. This is the circular tunnel you prepare, but we know there is a footprint still remaining here on the inferior aspect where PL bundle is attached. So even on the tibia, and then you use the punches and convert that circular tunnel to an oval tunnel. Similarly, on the tibia, you see this is what we routinely do, a circular tunnel, and with the punches, you can convert that circular tunnel into a rectangular or oval tunnel without damaging any anterior horn or anything. And then once you pass the graft and you see it covers most of the area, and once you see the same graft from the posterior medial portal, and you move the knee from flexion to extension, you will see the laxity, the tightness in the anterior medial half of the graft, and as you extend, it becomes lax and posterolateral becomes tight. So whether it heals, how it heals on the MRI, so this is the 7-month post-op MRI, and you can see the robust ACL. No impingement, and the signals are like the original ACL. So this, and healing fast, it's not in one patient. The same patient, another patient, if you see from behind, the footprint of the ACL is so big. And in the last video, if you see down there, this one, you are able to cover much amount of the footprint with the help of that rectangular tunnels. And if you want to see the MRI of the same patient post-op, 8 months post-op, you can see a robust ACL, both in coronal, sagittal, as well as in the axial plane, you can see the rectangular tunnels. So I have done, and this is the way we punch it through the anteromedial portal. So it doesn't break the posterior wall, and it sequentially dilates and converts the circular tunnel to a rectangular tunnel. So this already have been published 2 years back in arthroscopy technique, and so far I have done almost 28 to 30 cases, was waiting for 2 years results. So what I have found in my 2 years result is that the healing is little faster, and you can see the tunnels, they are not circular. The anterior-posterior, you can see it's almost 8 to 10 mm, and mediolaterally it's, and even the post-op MRI at 6 months, all are giving an excellent healing, because we all know the healing is at the mouth of the tunnel, not inside the tunnel. So we are increasing the surface area, which will increase more blood supply, and these are the post-op MRIs of all the patient, 6 to 8 months, and you can see all robust ACL within 6 to 8 months. So in conclusion, rectangular tunnels create more native ACL footprint, excellent ligamentization because of more surface healing area, excellent stability as you have a sort of both bundles. As a surgeon, I don't want to change from my routine technique, which is giving me excellent result. So I'm not changing the graft harvesting technique, I'm not changing the graft preparation technique, I'm not changing the fixation methods. It's only the shape of the tunnel which will take you hardly a minute or two to convert that circular to rectangular. So very surgeon friendly, less learning curve, and same cost what the implants you are using. Thank you very much.
Thank you, Dr. Mukesh, for that demonstration of anatomical tunnel making. Now I request Dr. Chirag to just proceed with this talk on fixation options in ACL reconstruction.
On the outset, I would like to thank Dr. Sridhar and the Vizag Arthroscopy Society for putting up this wonderful event, and it's such a delight to see a full hall on a Sunday, especially even though so many meetings are already on the roll. Now, since I see a lot of young patients, young delegates here, so rather than going back into the modalities of fixation, I'll just probably talk about something which is commonly asked about when we start off with our practice and we see these buttons getting flipped and somebody use the buttons. It's a very common question what usually the younger boys ask: how does this femoral buttons work, and what are the flips, and what are the maths and mistakes we do in this endo button? And let's concentrate on that. Basically, these buttons are nothing else but suspensory fixations. Suspensory fixations in the sense you have this cortical fixations and your graft is suspended to that. You see this? The cortical button suspends the graft to your cortical side of the bone. So suspensory fixations can be either fixed loop or adjustable loop. The first generation were always fixed loop, and then we advance ourselves to adjustable loop these days. Fixed loop, what does fixed loop means? You see this, you have a fixed loop which is attached to the button, which is not adjustable. And the components of this fixed loop, we have the leading thread, we have the flipping thread as you see here, and then you have the loop which suspends your graft. The size of the fixed loop, it would be, the button would be about 1 centimeter, the diameter would be about 4 millimeters, and the loop length may vary depending on your tunnel diameter and your tunnel length. Suspensory fixation, endo button was the first generation suspensory fixation. The femoral tunnel has two parts. One is the insertion part and second is the connecting part. Insertion part is drilled with the diameter of the graft, and the connecting part is drilled with 4.5 millimeters endo button reamer. Now, what is the math behind this endo button? The femoral tunnel length minus the desired graft insertion length gives us the loop length. How do we calculate the loop length? What kind of a loop length do you take? What kind of endo button size do you take? Depends on your endo button maths. Let's get this clear. Femoral tunnel length is the desired length of your graft inside the femoral tunnel, and the desired graft insertion length should be minused from that to get the loop length. Now, the insertion tunnel length should be 8 millimeters more than the desired graft insertion length, so that you have a button which goes out and then flips back. Let's look at this in an animation. Now, this is the femoral tunnel length, which is 40 millimeters, and the desired graft length would be about 20 millimeters, so you have about 28 millimeters of your desired diameter which needs to be reamed so that your button goes out, flips into the cortex, and then suspends your graft in a similar fashion. Let's look at it in real. This is a graft which is prepared. The graft is piggy banked into your endobutton. We have an endobutton loop of about 20 millimeters and the tunnel length of about 40 millimeters. So I made two markings here in my graft. One is at 40 millimeters and other one is 40 plus 8, that is 48 millimeters, so that your graft flips into the far cortex. The button goes and flips into the far cortex and then suspends. You see here, this is the total length of your femoral tunnel, that's 40 millimeters, and now I'm reaming it to about 28 millimeters of the 8 millimeters reamer, and so you have the graft going in here with the two markings, one at 40, one at 48. As you insert the graft, the leading thread pulls the graft to the first marking, and then over inserts the graft to about 48 millimeters, and once you flip the button, it's then reverse tensioned so that your graft comes back again and sits at about 20 millimeters intratunnel length. Now you need to confirm your flipping by toggling. This is a cortical fixation, hence your endobutton is sitting on the cortex. Make sure the endobutton is sitting on the cortex and it has to be flat, flush to the cortex, and it needs to toggle. Now what happens? The tunnel can flip intratunnel, or it can not be flipping, which may probably make your graft lax. So the best thing what one could do as you start off with a practice is to use a C-arm intraoperatively to confirm that your endobutton is flipped. It needs to be horizontal. It needs to be probably perpendicular to your tunnel. As you see here, if it is in line with the tunnel on the second image here, it is not flipped, whereas when it's perpendicular to the tunnel, that means your button is flipped well. A second way of confirming your flipping is by arthroscopic confirmation. You can take a lateral portal, shave off your gutter there, the lateral gutter, as you see here. This is a visual confirmation of your endobutton which is flipped, and this could be a better way of doing it. Flipping in the soft tissues, if your math is not right, if you're not marked your graft, and if you do not have a feel of your endobutton flipping, it's always possible that this graft can go and flip off, or else if your loop is long, it can go and flip off in your ITB, and this could probably, over the period of time, get your graft to be loosened, and you will lose the tension of your ACL. What happens if you have a lateral cortical blowout? Maybe sometimes due to logistic issues or vision problems, you may just blow off the lateral cortex. Do not panic. You always have a backup in terms of your X endobutton. Make sure that you have this in your OT always, so that you always have a backup plan when you blow off your lateral cortex. Tunnel dilatation used to be the problem. What happened in the first generation suspensory fixation? You see here, the graft is well fixed, but you see the tunnel is dilated much beyond what you can think. Why does it get dilated? Let's look at this diagrammatic picture here. You have your total femoral tunnel, then you have the desired graft tunnel. When you have to flip, you have to over-ream the tunnel in the third picture to about 10 millimeters or 8 millimeters more than your graft insertion length. Over the period of time, this void space could lead on to a little bit of a bungee effect, and the tunnel could dilate. Hence, the second generation of suspensory fixations did come into play. Adjustable loops, second generation fixations, loop length reduces after flipping by tightening the rope, and it allows full length of the filling of the graft in the femoral tunnel. Adjustable loops have got their added advantages. They can be retensioned, 360 degrees bone integration, and these are termed to be bone preserving ones. You see here, you have the lead thread, you have the flip thread, and you have the cinch thread. So it has got three components. Unlike your first generation endobutton, which had only two components, we have three components, and of course you have a longish loop here. If you see the diameters or the dimensions of the button, it's almost the same, no difference. But what does the adjustable loop do? You see here, there's the total femur length, which is about 40 millimeters, and you need to ream your graft length exactly the dimensions what you want to have your graft placed inside. So you're not over-reaming your graft length here, so that 10 millimeters of void is not there, so that you have 20 millimeters of 4.5 millimeters reamer, and you have 20 millimeters of 8 or 9 millimeters desired length. So how do you use it? So it's a 40 millimeters tunnel. This is your loop. You mark it as 40 millimeters, and then you take your graft and mark it at the desired length you want intra-tunnel. That's about 20 millimeters I would want. This is a graft which is prepared, and what I would do, once you've drilled your tunnel, the graft is then inserted with your adjustable loop, and here the marking. You exactly go up to the marking and then reverse tension this graft by pulling it down so that your button gets flipped, and after that you can cinch the threads in this fashion with the 2 cinching threads, and your graft just goes inside, and as your markings just arrive there, once you have your graft inside the tunnel, you can feel for your flipping using your flipping threads. Graft link technique, where you can use adjustable loop on either sides. I'm not really fond of them. Now, an added advantage of a fixed loop is that you can easily prepare a 5-fold graft. Here you see the 4-fold graft was inadequate in diameter, whereas I have fixed this one end of your yosemite into the fixed loop and then used it as a 5-fold graft. This used to be a myth that only your fixed loops can be used in your 5-fold grafts. A simple technique, what you can do, a 5-fold grafts can also be used with adjustable loops. Take your yosemite, fold it into 3 folds, and then suture one end in between here, and then reverse fold it with the loop, so that you have 3 strands of your yosemite, and then over that you can have 2 strands of your gracilis. So you have a 5-strand this as well, 5-strand graft as well with your adjustable loops. Now, fixed loop or adjustable loop, both are time tested and both work well. It's how you make it work is what matters. Choose the right graft, put it in the right place, fix it so that the tension is right, and rehab the patient. These are the keystones of your success. Saying that, I would once again thank the Vizag Arthroscopy Association for hosting this event, and I would invite you all for the 2nd edition of our Bangalore Arthroscopy course, which will be on the 4th of November 2023. Block your calendars and be geared up for 9 live surgeries in a single day. Thank you.
Thank you, Chirag. So discussion will be after all lectures. Evaluation and management of failed ACL reconstruction. Dr. Vikram Mahaskar.
Can you put it on the title? No, put it on the title. All right, thank you. I think at the outset, ACLs happen, we do a lot of them, but unfortunately some of them fail. So this basic talk is on what are the parameters that we should be looking at, or what are the main parameters that make our ACL successful or not successful, and how do we basically treat it accordingly. So I've tried to divide it into 5 main individual subheadings. So let's start with tunnel position. All right. So put the ACL at its native footprint is what we've all been taught. So what is the native footprint? So there's a wonderful paper by Magnuson where they've done 3D CT scans in revision ACLs and said this little green zone that you see there is where you should be putting your tunnel in, and it's considered appropriate. All right? So important is to improve your predictability of tunnel position. How do you do that? You can use a AL portal to view, or even better, work and view from the medial side. So you see the footprint end on. And I've done reasonable amount of work and published on the same as to how your portal can improve your predictability of ACL tunnel positioning. Now this is a classical CT scan that you would do before doing a revision ACL. Now can you see this tunnel position? It's not really elliptical or oval or circular or whatever you say. So here you may be in a little bit of a trouble if you try to do a single stage ACL, revision ACL. This is another case where you have good tunnel position. As you can see here, if it's failed due to a re-injury, you may as well use the same tunnel after making it raw enough. So this first video is when you're planning to do a two-stage revision ACL, what should you do? How should you fill the tunnel? So important is to first make your original tunnel raw. You do that with a curette followed by a shaver. Make sure you view it end on. And while you're doing this whole process, release your tourniquet to see whether adequate bleeding has occurred, so that whatever cancellous graft you put inside integrates adequately well. You get individual sleeves from various companies with which you could impact cancellous graft into this tunnel, much like an Oates kind of a procedure that you do to fill it up with good cancellous bone, which will ultimately heal. So you do the femoral part arthroscopically, and the tibial part, you open up at the bottom, remove whatever implant has been used, fill it with cancellous graft, get your x-rays done. At 6 weeks, 3 months, once it's adequately good, you're good to go ahead and do your ACL reconstruction again. Now sometimes you may have a good tunnel position, all right, and you may want to do it as a single stage where there's been a traumatic failure of your ACL. Then you do exactly the same thing. You may change your graft source to make a thicker graft than what you want or the way you do it, but you can use the same tunnel like a standard ACL. But the main thing is to make sure that the bone all around the orifice of the tunnel or aperture of the tunnel is nice and raw when you pass your graft through and through. As you can see here, so you see specks of bleeding, and then you measure your tunnel like a standard ACL reconstruction, and then you pass your graft, as you can see here. Rotational instability. Please look for this, very important. A thorough clinical examination. Chronic ACL explosive pivot shift test. Patients with ligamentous laxity, obese patients. This is my go-to operation. Do a lateral extra-articular tenodesis in your revision cases, all your revision cases, because it takes care of rotational instability, one. The other is the concept of a ramp lesion. So what is a ramp lesion? It's a meniscocapsular separation. How does that happen? So typically there are two hypotheses. One is when the femur internally rotates, with a valgus force at the knee, this is what happens. It's like, you know, yanking a cloth or a poncha or whatever. Your ACL breaks. But as a consequence of the ACL breaking, as it proceeds, the meniscus separates from the capsule posteriorly and leads to a ramp lesion. The other philosophy is due to excessive translation of your ACL anteriorly or your tibia anteriorly over the femur, again, the capsular portion of your meniscus disengages from the meniscus tissue and leads to a ramp-like lesion at the end of it, or a meniscocapsular separation, as you can see here. So this is how you go about it. Today Dr. Sandeep very nicely showed it, but this is a classical lesion that doesn't look that innocuous when you look at it. But when you debride it adequately well, lo behold, you get this kind of a picture. And this is a cause of rotational instability. There are various ways to skin a cat. I use a single portal these days, but you can use two portals, a low medial and a high posteromedial portal. And suture lassos are a wonderful way of taking bites through the capsular portion and the meniscus portions. Those adept at doing shoulder surgery wouldn't find this too difficult to do. And I like using PDS sutures here because remember, this area is waiting to heal. So PDS is absorbable sutures. At the end of it, you've taken care of it, and you have a nicely repaired lamp lesion. Remember to take care of meniscotibial separations. These are also ramp lesions of sorts. So once you do this, always come in front, check your meniscotibial separation, and do a proper repair of it. Lurch. All revision cases, make them walk in your OPD. Very well put by Dr. Shivanand in his clinical examination lecture. Make them walk, see how they are walking. You may just find this in medial compartment osteoarthritis associated with an ACL. In this kind of a situation with a thrust, I do a revision ACL along with a HTO and make sure that my slope is conducive for ACL healing. As you can see here, I've reduced the slope. Coming to slope. So what is the normal tibial slope? So 9 to 11 degrees of the medial slope or 6 to 8 degrees of the lateral tibial plateau slope. How do we measure it? There are wonderful techniques, many techniques of doing it. Standard lateral radiographs of the tibia, you draw 2 circles, connect them with the plateau and a perpendicular down it. The angle it forms is your slope. What does current literature tell us? Slope reduction reduces anterior tibial translation, and 10 degree slope reduction has less force on the ACL. So when you do it, how do you decide how much to remove? So typical finger rule is 1 millimeter equals 1 degree, and the aim is to reduce about 2 to 4 degrees of slope ultimately. So let's see how this slope affects the ACL. So this is a normal tibial slope. Imagine if the slope is more, as you can see here. So typically, like a ball rolling down a slope, you see that the femur goes backwards, and as a consequence, the ACL stretches. When it stretches, it gives way. The opposite happens with PCL. In PCL, the femur rolls forward and the PCL stretches. So this is a classical case. I had this patient revision ACL with re-revision, actually 2 ACLs done. 17 degree slope. You can see 2 degrees of valgus in the knee. So I was stuck with a unstable knee, with a ACL deficient knee and an MCL deficient knee. So his MCL was deficient, the alignment was not conducive for MCL healing on its own, and he had a increased slope. So this is how I do my slope reduction osteotomies, how I like to do it. Here you can see I do something called biological plating. I take the tibial tuberosity off completely, like how you do a TTO. Then you see the tibial plateau right in front. So when you see the tibial plateau right in front, I do a trapezoidal osteotomy here because I want to correct my valgus into slight degree of varus for my MCL. Once you do this, you collapse the proximal on the distal fragment, put your tibial tuberosity back, fix them with screws and 2 staples. And lo and behold, you've got your slope reduction. So these are typical radiographs. Aim at your PCL, take a converging, another K wire in the same direction. You should know how much is your wedge that you intend to remove. Once you've done this, use your osteotomes. Make sure you preserve your posterior cortex. Once this is done, you've collapsed your osteotomy. You fix 2 staples on either end and put back your tuberosity on top that acts as your biological plate. So this is classically how this patient was when he presented to me after his 2 ACL reconstructions. This was his valgus stress test. You can see that there's so much opening medially, and at the end of it, immediate post-op, this is what I had. I had a rather stable knee without, I did a revision ACL with a quad tendon graft. I did a slope reduction osteotomy and an MCL reconstruction along with it, and the alignment correction to make it conducive. So this is what I ended up with, from 2 degrees of valgus to 1.5 degrees of varus at the end of the procedure, and the slope of 17 degrees was reduced to 2.25 degrees at the end of it. So where are we today? This is a technique established for re-revision surgeries of ACL. We are starting to get very aggressive with PCLs and osteotomies, but with ACL, re-revision. Primary and revision surgeries in PCL. Don't miss other ligament injuries. This is a classical case that had come to me. You see the anterior drawer is not too bad. This patient had an ACL done elsewhere. It looked okay. The valgus stress test or varus stress test showed a lot of lateral opening in this patient, as you can see. And there was some kind of rotational instability in this patient, like a grade 2-3 pivot shift test. Always use fluoroscopy in your OTs to objectively quantify your anterior translation. So I'm doing it in a fat patient especially. You can see that the tibia is not translating that much anteriorly. However, with a varus stress test, you can see that my lateral compartment is opening up quite a bit in extension and 30 degrees of flexion. This is the arthroscopy. You see such a wonderfully ligamentized ACL. Everyone told him you need a revision ACL reconstruction. May not be such a good ACL. Will you be able to give him something better than this? No. So what I did was a PLC reconstruction and an LET along with it for my rotational instability. And post-surgery, as you can see, I do my pivots on table to be sure that it's all right. And of course, we check the anterior drawer, and we also check the, the varus stress test in extension and in flexion. So what is my algorithm? So you have a failed ACL, first rule out infection. That's a whole topic altogether. Take a good history from your patient, clinically examine them for ligamentous injuries, meniscus injuries that you could have missed. Observe their gait for any lurch or any thrust. Check the gross alignment of the patient. Is it conducive for other ligament healing? Implants used, like metallic implants, etc., you need to plan to remove these screws, etc. What was the technique? Was it a transtibial? Was it a transportal ACL used? ACL done? Always get long leg films done, hip, knee, ankle x-rays, standing, weight bearing, MRIs, and 3D CT for tunnel positioning. This is a must. Lateral view x-rays of your tibia are very important to check for the slope in revision cases. Once you decide, then arthroscopy is your best bet. Always be open to a single/2 stage procedures. Don't promise them that it's going to be single stage always. Lo behold, you may find something quite unusual when you put your scope inside. Supplement your fixation with an extra-articular procedure in all your revision cases. And consider osteotomies wherever you feel that alignment is non-conducive towards healing. So remember, the previous surgeon is an intelligent man. You need to learn from his mistakes. Thank you. Can I get my second talk on? So I just have one more talk I was asked to deliver, so I'll finish that also here. I've taken care of ramp. I'm just going to talk about root tears now. So we try to get done with this quickly. Start from the beginning. Yeah. So we're talking about root repairs here. So typical dictum. So you may not have seen it, but the root tear has seen you. So that's why it was missed for generations together. The root anatomy, it is the, remember that the medial root is always more posterior than you think, and the lateral root is more anterior than you think. What does the meniscus do? So meniscus is like a tent. It is attached to the bone in front and back. So when the root moves out, it's literally like your cushion coming out of your butt on your chair. When it comes out, your butt touches the chair. Same way the two condyles touch against each other. So what happens when the root tears? So look at this, a lady sitting on a cushion. Imagine the weight is quite evenly distributed between her butt and the cushion. Once the cushion slips, the femur directly touches against the tibia, and as a consequence, there is less tibiofemoral contact area and hence more stresses that happen. Remember, in the lateral side, the lateral meniscus takes 70% of the load passing through the lateral compartment. However, on the medial side, 50% is shared by the meniscus and the cartilage. So, lateral meniscus roots, remember the lateral meniscus root is the primary knee stabilizer for internal rotation at higher degrees of knee flexion, and hence these are more commonly found with ACL tears and should be repaired along with the ACL. Otherwise, the stresses on your graft are much more. So what happens in the root tear? So this is normal pressure that goes through the knee in a pressure gauge system. When there's a total meniscectomy, you see the green and blue area, increased pressure, and the root tear is almost like a total meniscectomy. So you see that there's direct point contact between the two ends of the bone. So how much extrusion is bad? Greater than 3 millimeters extrusion is associated with meniscus and articular cartilage degeneration. What are the techniques used for root repairs? There's a suture pull-out technique and a suture anchor technique. So the suture pull-out is what we commonly use. It could be single tunnel or it could be two tunnel fixation. And suture anchor is using a suture anchor posteromedially and tying your knots onto the meniscus tissue and the root tissue to reduce it anatomically. This is how I do it. This is a small little animation of the technique that I use. So you can see a root tear at the back. So first you use a curette to curette out the footprint adequately well so that you have wonderful vascular tissue, cancellous bone exposed, and you put your normal ACL jig there, drill it with a bead pin first, comes out right at the root footprint, then with a 4.5 or a 3.5 drill bit. You can use an antegrade suture passer to use tapes. I like using tapes. I use 2 tapes, one more medial, one slightly more lateral to it, and then through an ethibond loop that goes through the anteromedial tunnel, we, using a flexible cannula, load these suture tapes through this little loop, which is delivered anteromedially, as you can see here, and tied over a suture disc at the end of it. So let's just see arthroscopically. So every root tear, your x-rays may look absolutely normal. So any case with medial compartment OA, you'll have good merchant views, lateral view x-rays. Always get long leg weight-bearing films, a hip, knee, ankle x-ray, as you can see here. You may have varus, so that may not be the only solution, but check the other side. It could be constitutional varus on both sides. So in that case, root repair may be the solution. Get an MRI done. So MRI, there are certain telltale signs. One is extrusion. As you can see here, the meniscus moves out. The ghost sign on a lateral view, you can't see the posterior horn, and the truncation sign in your axial sections. I use ultrasound in my OPD, in my OT also. Ultrasound is a great test to actually see extrusion of your meniscus over the tibial plateau, and you can see that here. You could use it in your OTs. On arthroscopy, you may find a classical root tear, complete root tear, as you can see here, with reasonably decent cartilage, maybe a grade 2 fibrillation on the medial femoral condyle. So use a standard curette through your anteromedial portal. Identify your footprint in advance properly, so that it's very important that your meniscus is reduced to its anatomical footprint and not too anteriorly or posteriorly. So once that's done, that's where your footprint should be, very posterior. Spend time on this step. Once you've curetted out and decorticated it, you can place jigs. You get various types of jigs. You get these low profile ones also, which make your life quite convenient, but I quite like my standard ACL jigs. You should do a good pie crusting. It'll help you introduce these instruments in. You drill with a bead pin, as you can see here, and then a 4.5 drill bit. So once this has been done, you introduce your flexible cannula through the anteromedial portal. Use your antegrade suture passers with 2O fiber wire, and you could shuttle your suture tapes through them. I like using 2 tapes, one slightly more lateral, one more medial towards the root, as you can see here. So once this is done, you have your tapes passing through the meniscus tissue. Various types of devices available. This is the Smith & Nephew First Pass Mini. The first was the Knee Scorpion by Arthrex. So use what suits you. Some of them are a little more low profile. Advantage of some of these devices are they let you pass thicker sutures through them. So the moment you have your suture tapes through the root of the meniscus, you use an ethibond loop to deliver it through the anteromedial tunnel. So the ethibond loop passes these suture tapes through the tunnel anteromedially, and these are ultimately tied over a suture disc anteromedially over the tibia. So you can see all these suture tapes coming in. So while you're tying it, very important to visualize it arthroscopically, because lo and behold, sometimes you may just find that your sutures are loose. So see your root while tightening it. As you can see here, the medial most suture can almost not be seen because you've reduced the meniscus to its anatomical location. So once you've done this, this is your final repair. You can also see that the meniscus has come in inside. Make sure you preserve your cartilage at the end of it. This is a follow-up MRI at the end of 3 months. There's no extrusion at all. I do serial ultrasounds myself to be sure that my extrusion is more or less in control. So where is alignment in this? So remember, standard root tears, it doesn't really matter. You can stitch your root and bring it back down when your body weight passes through the center of the knee. However, if you have a varus knee and all your body weight is passing through the medial compartment, this may just be the tip of the iceberg. So correcting alignment so that the patient's symptoms go is more important than just the root tear. So you may do a root repair with a HTO, but nowadays it's said that a HTO itself would suffice. A little bit on the lateral roots. So the classical appearance of a lateral root, look out for them in ACL tears. So remember, at the end of this talk, look for ramp tears, look for lateral meniscus root tears. Remember, the lateral meniscus root is more anterior than you think. See the reducibility. The same technique is used. to repair it, but remember to repair it more anterior than posterior as compared to a medial meniscus root. So here you can see the lateral meniscus root back in position, and then you do your ACL reconstruction along with it. Which suture configurations work? So what does science tell us? So science tells us the one which I showed you, that is 2 simple passage of tapes through the meniscus is your best technique of doing it with best pull-out strength. So don't try anything else, just focus on 2 tapes, make it simple. What implants work? Suture disc versus washer. Suture disc is your choice according to literature. Centralization, it's done to reduce extrusion. Be very selective in the cases you do it. It's still an experimental operation which has shown reasonable results. This is a classical case of centralization. Once you've passed your sutures, when you feel that you need to reduce your meniscus further and your extrusion is not to your liking, you can use all suture anchors. Make sure you make a high medial portal so that you can introduce your standard drill sleeves that you use in your Bankart repairs. Use your all suture anchors. They have number 2 fiber wire passing through them. Then through a lateral portal, you can use any anti-grade suture passing device, take bites to the meniscus. Various ways of doing it. You can also deliver the knot exterior to the joint. Various surgeons have shown various ways of doing it. All of them work. It gives you a better, I would say, ultrasound and MRI picture. How does it help ultimately is still open to discussion and debate. So once you take these bites, of course, you tie multiple simple knots. These knots can be tied over the capsule with various other techniques. And once you've done this, you tie your meniscus sutures back, and you've ultimately got your extrusion that's been taken care of at the end of it. So where is centralization? Where is it today? So only porcine and cadaveric studies showed decreased extrusion, okay, not in adult human studies. Human studies are only surgical techniques as of now. There are no long-term studies on the same. Thank you. I've finished the ramp part of it.
Thank you very much, Dr. Chirag.
All right.
We had some very wonderful talks in the session. Could we request Dr. Sandeep and for the next session, Dr. Mukesh, please come down to chair the session. Dr. Rajiv Raman is ready. No, sir will be there. You can please join them.
Wait.
The PCL surgery has just started, and the graft harvest of the peroneus is going to start now.
Yes, Mukesh.
This monitor.
Yes, Rajiv Da.
Yeah.
So what are you doing?
Yeah, this patient has a history of twisting injury almost 2 years back. So at that time when he did his MRI, it was a clear-cut PCL tear, and 7 months back, I think he reported back to this hospital, and then he had a repeated MRI at that time. At that time, it shows the PCL is intact. So most of the time, I think the junior guys will also know the PCL is not an MRI finding, because most of the time the PCL graft heals well because of the good vascularity. It's the clinical finding which is important. So yesterday also I saw the patient. Patient has a history of symptomatic posterior instability, and today also posterior downward stress is positive. So we have planned for peroneus graft, and think for PCL usually it is my graft of choice. So normally I put a small incision, 2 centimeters.
Rajiv, it's isolated PCL or with corner injury?
No, there is no corner injury. Dial test is negative. So it's an isolated PCL injury. So there are 2 or 3 important tricks. I think in morning Sridhar has shown very nicely how to take the peroneus graft. So when you are harvesting the graft, you can see I am everting the ankle, and you can take maximum length of the graft. You can see here. And how to differentiate between the longus and the brevis. Normally longus don't have a muscular attachment here, and you can see the brevis has a muscle here. You can see inside it's a brevis, this was a longus. So he is everting it, and at that time with the lumbar blade you try to, so when you are harvesting the graft, under protection you try to cut it. I don't go for tenodesis of the longus with the brevis. And now
Dr. Rajiv,
yes,
Chirag here. Chirag here.
Yeah, Chirag, please.
Yeah, so if you are not wanting to take your peroneus, what are your other graft choices for your PCL?
So other graft choices are either a semi-T with gracilis, but the only issue is that for shorter female you can use it, or sometime I use the central quadriceps tendon also.
Okay. Are you fond of using two semi-Ts from?
Yeah, so again, when you are planning for using two semi-T, what happens? One can put your thumb here, any one of you, and at that time try to invert your ankle. So when I'm harvesting your graft, you are trying to invert. To two semi-T is a good option. So you can see here, it's a long tendon here. Two folder. See,
a point to add for corner injuries in chronic cases, sometimes the clinical examination may not be that inclusive. So always do stress X-rays of both the knees, varus and valgus stress X-rays.
It's a very good point,
the
Mukesh.
opening, and then you decide, because isolated PCLs are rare to occur in chronic situations.
Yeah.
So go for stress X-rays. Even in doubt, go for posterior stress to see the amount of posterior tibia.
Yes. So I think for PCL, posterior door stress is very important, because like ACL, you will not see empty fossa sign when you put your scope inside also. It's a very vascular structure. So whole of the PCL usually heals well with stretching. The issue is that when you allow this patient to walk with this stretched PCL, chances of anterior knee pain is there. After 4 or 5 years, this patient will come to your in clinic with patellofemoral pain.
Yes.
So what is your graft choice, Mukesh, for all those PCL injury? Is a ipsilateral, you want to take graft from one limb only, or you want to
I have changed from my bilateral semi-T to now peroneus longus for PCL.
All right.
Yeah. I never use central quadriceps.
So central quadriceps is also a good choice. And
I know, but we all know that for PCL you need a strong quadriceps to have that anterior draw.
Yeah, so that is because what happens, the agonist muscle for PCL is your quadriceps. So normally you don't want to damage the quadriceps part, but yes, sometimes you are dealing with multi-ligament, you have to do ACL, PCL, PLC. In those cases, you can take the central quadriceps also. I take the superficial part of the quadriceps. You can just wrap it.
Rajiv?
Yes?
By the time you take portal and start doing diagnostic arthroscopy.
Yeah, I have done the diagnostic arthroscopy already before taking the graft. By that time the talk were going on. So I will show you. No, yeah, please.
So the portal placement, anything different from routine ACL?
Yeah, I always use a high portal here. High anteromedial and high lateral portal.
So you prefer inside out femoral or outside in?
So femoral portal I will go inside out.
Okay.
What position your knee is in?
Yeah, it's a knee holding position. You can show, cameraman, you can show here. Zoom out and you can show here.
So you finished diagnostic arthroscopy?
Yeah, I did a diagnostic. For PCL also I did always do a diagnostic arthroscopy. There are some telltale signs. First sign is your lax ACL. I will show you. And operatively you can go for posterior door stress test also. You can see the translation. Put it there. Subblade, yeah, done. So you can see the lax ACL here. You can see whole of the lax ACL. And this is the PCL. You can see most of the time you will see the PCL heals well. So what I do, before going for a routine diagnostic roundup for the menisci, I make my posteromedial portal first. Because bulky guys, sometimes it's very difficult to reach the posteromedial compartment. Again, both of my portals are high portals.
So to go into the posterior medial compartment, you go between PCL and condyle or between ACL and PCL?
So here I will prefer to go between PCL and the condyle. Yeah. So you can go with, just take it out. Yes.
That is called as Gilchrist view.
Yes. And second option is your intercruciate also, where you
So I hope you are doing remnant preserving single bundle PCL
single bundle. So I don't believe in double bundle, neither for ACL nor for PCL.
So what he wants to say is most of the time when you enter into PCL reconstruction, it's unlike ACL. You will see the whole PCL sort of.
This is very important because classical empty fossa sign is not there when you.
So it heals with stretching. So you try to preserve most of the native PCL and you augment with your graft.
Suction on, please. So I will try to take some amount of PCL from the posteromedial part, try to preserve rest of it.
So are you going to take only posteromedial or posterolateral portal as well?
I am not doing a transeptal technique today, so only posteromedial portal. A bit of pump will work. The Sandeep, you are finished with your talk? No.
Sorry?
Sandeep is not finished with his talk yet, I think.
No. My talk was like it was supposed to be now.
So you demonstrated such a nice life surgery, na? Now Sridhar has told those who will do good life surgery, they will not give talk. So normally, what is your preferred technique, Mukesh? You plan for transeptal because transeptal, when I am dealing with a PCL avulsion, I do it transeptal.
I didn't got. What was the question? Yeah, I remove the septum completely when I go between the interval of ACL and PCL.
Yes.
So that once you remove the septum, the capsule falls back and you get enough space to
Yeah, so you are at least 10 to 15 millimeter. So luckily I am not having the ramp tear today, so I am lucky.
Even Sandeep was lucky.
Sandeep was lucky to have ramp tear because he was interested in showing that ramp repair. So light off please, can you focus there? So this is very important step, making of a poster. You can see here, so I use the trans illumination technique. You can see here the illumination.
Opposite side
please.
This side. Yeah. Focus this here.
Yes, we can see.
Yes, sir. So this is a very good technique, trans illumination technique, and by this you can make your posteromedial portal. You can see you can make it high, you can make it low also. So I use this technique only. So whatever landmark that is been described by the posteromedial for posteromedial.
Inside picture, please.
Yeah, inside picture you can see. This is your medial femoral condyle. This is the posterior horn of the medial meniscus. And you can see, this is the way you see your ramp tear. You can see this fibrous. Normally you get ramp tear here, which Sandeep has demonstrated very well. And this is very important. Always tie your blade. When you are doing a shoulder or knee arthroscopy, you can see here and tie, because sometimes what happens, you have done a very good surgery and your blade is inside.
So most importantly, he's making a very high posteromedial portal.
High,
because you have to go down on the tibia.
Down on the tibia.
So you won't get that trajectory of working on the tibial footprint if you are on low posteromedial.
So this is your you can see the inside picture. I have cut the posteromedial capsule. Don't try to cross this fold.
Very well.
Yeah. Cannula? No, dilator you can put a dilator you can give that. Take the needle out. No more pump, please. Go push. So Mukesh, you prefer single portal or to a double portal? You prefer a double portal technique as you told, no?
No, I do single posteromedial portal.
Blade. Wait. Single posteromedial portal, all right? Yeah. Go. Rotate and go. Rotate, yes. Rotate. Yeah, rotate. As Sandeep was telling, go. Rotate. Yeah. Rotate. The young guy, thick caps. Yes.
There is a request from organizer.
Yeah, please.
Can we finish to talk quickly?
Done. Prepare.
Clearing out.
Yes, done.
Before you make tunnels, by the
time I will be back. Yeah. Not an issue. So this is the most important step, posteromedial portal. So you can see. So once you have done with it, your 50% job is over.
Yes.
We'll come back to you, yeah? You can see this is a classical posteromedial portal, yes?
Yes, very good.
Get done. So now, all right. Now I will go for diagnostic roundup. Probe, please.
just finish one or two talks and then we'll come back.
Stop.
Always pass that cannula posterior-medially so that it's easy for you to pass your RF, your shaver, your scope also when you are drilling the tibial tunnel. Otherwise, you'll keep damaging the tissue more and more for entering it.
PLC is intact, huh?
Yeah, so we'll go ahead with the next talk. Dr. Sachin Tapasvi, who was kind enough to record his talk and send to us, why should you save the meniscus? Sound, please.
The meniscus, and if you look at the meniscus, you will see that there are two lovely menisci, the medial meniscus, which is attached at the anterior and the posterior root, which is very mobile and wider posteriorly, and on the other hand you have the lateral meniscus, which is of similar anteroposterior width, but it covers a greater articular surface. The medial root on the posterior side is closely attached to the PCL, and the lateral is closely attached and in relation to the ACL. The anterior root attaches for a far distance in a variable location proximal to the ACL, which is what must be kept in mind. The menisci serve many important biomechanical functions. The medial meniscus carries about 50% of the load in the medial compartment. The lateral meniscus carries about 70% load in the lateral compartment. And if you look at the ACL injured knee, which is a fairly common injury that we see in our clinical practice, you would find that a third of all ACL injured knees will have a medial meniscus and a third of them will not be repairable. On the same hand, you would find that almost about 40% of all ACL ruptures will have a lateral meniscus tear and only 10% are non-repairable, which means that we have to go all out and try and get to these injuries early to save the meniscus. The main biomechanical functions of the meniscus are those of load transmission, which is the main role. The menisci allow to transmit load from the femur to the tibia, and they convert the axial loading to circumferential hoop stresses. The roots of the meniscus play an important role. They help dissipate the force to the subchondral bone area, and hence the meniscus root is now recognized to be an extremely important reason for getting back the stability of the knee joint. When you perform a meniscectomy, there is increased peak contact pressure on the articular cartilage, and the amount of meniscus that you remove will be the most important predictor for development of osteoarthritis. So the more meniscus you remove, the higher are the chances that you will get to osteoarthritis, because there is increase in the contact forces. This is more important on the lateral side than on the medial side, because on the lateral side you have a convex on convex articulation, which makes the role of the meniscus so far more important. Meniscus tears can be classified on the basis of the tear depth, location with respect to the zones of the menisci, the pattern of the tear, and the quality of the tissue. But on a broader aspect, you can classify them into traumatic tears, which are essentially seen in young athletic individuals, which are usually associated with an ACL or some cruciate tear, and they're usually of a peripheral longitudinal type and are amenable to repair. On the contrary, you have degenerative tears, which are seen usually in patients above the age of 40-45. They will occur with a trivial injury, and you would find that there are pre-existing degenerative changes in the cartilage, and the meniscus may not also be of normal quality. These may not have the same healing capacity as that of a traumatic tear, and these are usually of complex tear patterns, and repair may or may not be possible. It was way back almost 100 years ago that the meniscus was found to be capable of healing if the tear had access to a synovial blood supply. And Warren and Ornoxy about 40 years ago did show us that the peripheral capillary plexus, which originates from the synovium and the capsule, richly innervates and supplies vascularity to the periphery of the meniscus. So based on the same, you can classify tears of the meniscus as zone 0, 1, 2 and 3 based on whether it is at the level of the capillary plexus or with decreasing vascularity towards the central area. You could also classify them based on the configuration as we discussed, whether it is a radial tear or a flap or a horizontal cleavage tear or a longitudinal vertical tear, which is what we need to look into in proper details. On the basis of chronicity, a chronic tear is less likely to heal, and which is why we must look at this aspect very critically, because a tear which has been out for a very long time may not heal properly at all. And of course, we need to look at the age of the patient. Older the patient, less the chances to heal, and a non-compliant patient is someone that you should stay away from. An unstable knee needs to be corrected before you perform any form of meniscus surgery, and this becomes critical because if you leave a knee that is unstable, the meniscus repair is bound to fail. If you look at surgical techniques, the meniscus can be repaired with an outside in, inside out, or an all inside technique based on the zone or the area of the meniscus. And we now have better devices of all of these three techniques which allow us to repair more and more of meniscus zones with increasing ease. If you look at the repair principles, we understand that we should perform divergent superior and inferior vertical mattress sutures, something which will be highlighted by my next speakers. Why is it important and critical to repair? It is important to repair because if your meniscus repair tides over the first 24 months after the repair, then there is a good chance that it will survive for more than 10 years, which is very important. And this happens because 20% of the meniscus repairs will fail, and probably they could be as a result of a wrong indication or a poor technique or a meniscus which did not have good biology. Another important critical aspect is that if you remove the meniscus at the first go, then you will perform a meniscectomy which is 85% more than what would be if your repair failed at a later date. Also, this study showed that you will have a 50% higher chance of landing up with a chondral lesion if you perform a primary meniscectomy. The association between anatomical healing and clinical results has also been demonstrated that with improved meniscal healing, there is improved clinical outcomes. Also, is very critical to understand that if you perform a meniscus repair, you are more likely to not get osteoarthritis and you are more likely to return to the pre-injury levels. So which are the factors to consider? I think consider tears which are in zone 0 and zone 1 and some selective tears in zone 2. Definitely repair all the lateral meniscus tears as much as possible. They stand a lower risk of failure than the medial tears. Repair the smaller tears for sure. If you have a longer tear, then it may lead to a poorer prognosis because the healing rates may be lower, but please understand that if you perform a large meniscectomy, you are definitely going to get a poor result, which is why you should try and repair as much as possible. It's also important to understand that partial meniscectomy will lead to lower reoperation rates than meniscus repair, and this is more so on the lateral than on the medial side. But what is important and critical to understand is that we need to do a good combined repair if we want to ensure that we want to have good stability and good outcomes. The Lishom scores and the amount of chondral degeneration is definitely going to be more when you perform a meniscus repair, and that holds true for osteoarthritis as well. So to conclude, to save meniscus tissue is of prime importance. It prevents osteoarthritis and restores normal biomechanics. You need to be aware of the various different methods of meniscus repair, including those for hidden lesions, which are the ramp and the root tears. Thank you very much for your kind attention, and I hope to meet all of you soon in person.
So next talk will be by Sandeep.
No, not your laptop. Just give me slide.
Management of ACL avulsion injuries.
Very good afternoon. So I'll try to be very quick because we are running quite a lot behind our schedule. It's not working. Huh? Big one only. Yeah. Greetings for Indian Arthroscopy Society. So when we look at the avulsion injuries of ACL, so this is very famous classification by Myers, where type 1, type 2, type 3A, B, and type 4. These are the various types. So why it is important? So usually type 2, 3A, and onwards, they usually need surgery, while type 1 can be managed conservatively. So there are various techniques mentioned in the literature, ranging from putting a screw or staples, then with the wires, or pull-out technique, then by putting anchor. So I usually do this pull-out technique. So this one particular patient is 12 years boy. He fell down while playing and injured his right knee. He was unable to bear the weight. That was his X-ray picture. You can see there is an avulsion of ACL. Then these are his MRI pictures. You can see the ACL is like a hinge type, or it's slightly got pulled. So whenever I plan for these avulsion injuries, I do have a checklist which I follow. C-arm is a must. Then we need to have 8.5 mm clear cannula, which we use for the shoulder surgeries. Then other implants like fiber tape, fiber wires, loose endobuttons, or suture disc. Then there are various suture shuttling devices, like this, the one which I used in the morning. And there are certain special instruments. So this, actually, I have just skipped it because of the time. So I'll just click video. So this is a video of the same patient. So what I'm doing, I'm just debriding. It's a fresh injury. So you can see the clot, and even there is a bony fragment. So with the help of gentle debridement, I'm trying to clear out the crater. Then with the help of either shaver or even with probe or trocar, we try and lift and make the crater free from the clots. So you can see it is elevated. Now I'm just clearing out the synovium, and that's the crater. Then again, I try and see if it is reducible. So with the help of trocar, I'm trying and reducing it. So whenever I do pull-out technique, so my initial plan is always passing a 2 bead pins. If needed, then I pass another 3rd or 4th, depending upon, because sometimes when you pass your tunnels and shuttle your sutures and try and pull them, then you find it that at some point it is sitting, but then it gets lifted up from the opposite side. So if such thing happens, then I try and change my trajectory. I take the new trajectory for the new suture so that it can be shuttled very well. So I use this first mini. So I use this fiber tape. I shuttle through the substance of the ACL. So I usually use 2. So I make like a configuration of X type configuration. So now here, earlier was going from lateral to medial, and this one is going from medial to lateral. So that way, one end of each fiber tape goes onto the either side of the portals. So I just take them out. So that's how configuration which I prefer. So that whenever it is getting pulled, so it gives good support onto that bony fragment. After after this step, next step is to pass the bead pin. So I take ACL jig. Now my first bead pin is going in. So now what I'm doing here, I'm checking under C-arm so that I'm trying my level best to avoid physis, so that I'm just above the physis. Now once tunnel is, the bead pin is passed, I make that bead pin other way around and pass number 1 ethylon through the eyelet of the bead pin, so that I can use it for shuttling of these fiber tapes. So already bead pin has made the tunnel there. There are techniques where many people, they drill with 4.5 over this bead pin, so that makes it little more wider. Can you forward little? No, I told you to forward. Forward. Why? Forward. Anyway, I think I'll just.
Vikram, you also use the same tunnel technique, 2 tunnels? I have developed a new technique which is under publication. You take the bite with the fiber tape and use the lateral row anchor anteriorly. So no tunnels, nothing, and it's complete transfacial. I use single row, only 1 row, because the fracture fixed in the crater very well. It doesn't move. So making the tunnels and other things, everything is gone. And you can even be transfacial.
Now, first I have already shuttled. I'll just go back. So then I'm taking second one, which is little more posterior. So that will be, then again I'm doing this bead pin with an ethylon loop in his eyelet. So when, or that ethylon, so I'm just pulling it out. So once 2 are done, so here I'm taking third one, which is coming from the opposite side. Again, similarly, I drill, then remove the bead pin, and then pass it, I shuttle this. And once it is shuttled, we try and push it down. Shuttle these fiber tapes through those nitinol loops. Now you can see here, it is sitting perfectly well into the crater. So it gives very good reduction. So that's the immediate C-arm picture. That's patient's follow-up, final follow-up. These are patients' clinical photographs. Thank you very much.
Excellent way. Rajiv Da, can we connect to Rajiv Da? Hey, that's what. Rajiv Da, can you hear us? Rajiv. Guys, there is loss of communication from OT.
Yes, RF.
Rajesh sir, can you hear us?
Yeah, Sridhar.
Yes,
So,
sir, we can
thank
see you very well.
We are back again. So, after making the posteromedial portal, second important part is preparation for your tibia. And this is very important. So, you should go for an adequate release so that your capsule goes outside. You can see here. So, and the second question which is asked, what should be your distal limit of your release? So once you see the red fibers of the popliteus, you can see the red fibers of the popliteus down there. Okay. So that is your distal, so don't go beyond that. So that is your, if you can see this red popliteus bundle there, then you have done adequate release posteriorly. Now I will put my PCL jig, you can see, he has set it at 55, 60 degree. So under visualization, try to park it in that tunnel. You can see, just I am going there. So the best way is that just kissing the condyle, you go there and under visualization, park it there. So once you have parked it, now I am switching my scope in the posteromedial compartment. And you can see.
Yeah, very well.
So normally you can see this is a good adequate release, because sometimes what happens, this jig also misfires 1 or 2 millimeter. So you should have adequate space medially and laterally. You can see here. And
very well visualized.
Normally you should go 15 millimeter, 15 to, you can see this is a 5, 10, 15 mark is there over the jig. Yeah. So you should be at least 15 millimeter below the joint line. This is your joint line. So I would like to make my tunnel here. And second point is your sample drop. You can see the posterior part of the tibia slope, suddenly it changes here. So try to make your tunnel at this point. So can you put your bullet here? Any one of you? Yes. Very good assistant here.
What's the size of the graft?
It's 9.5. I think good enough. I have to add a semity over that. Earlier it was 7.5.
Okay.
So 2-fold semity and 2-fold peroneus.
Okay.
So by that time, you gave me time. In between talk, I harvested the semity. Yes, fire. And slowly, first cortex, feel second cortex. So arthroscopy surgeon has only 2 hands. So you need a very good assistant also, third assistant.
So any special precaution to prevent vascular injury at this stage when you pass the beat?
Yeah, so you should do it. See, so once you see the fat bubble, you can see the fat bubble there.
Yeah.
Yeah, so you have pierced it, leave it. And second important thing is good release. You can see my posterior capsule is almost 1.5 centimeter posterior to the jig. You can see here. Yeah. And you should have a good medial and lateral visual. At least 1 centimeter of medial and lateral posterior tibial capsule should be visualized, because if some amount of misfire, now hammer, yeah, take it out, hammer it.
One more technical tip to it is keep the length of your drill bit only 5 centimeter, 4.5.
Fantastic.
Considering
Mukesh,
the
yeah.
length of the bullet.
Go more, go.
And keep it to only 4.5.
Go.
Just mallet it into
yeah.
last 5
yeah.
mm. You inadvertently you won't go.
So, yeah, 9.5. 9.5.
Can you just zoom out your camera out a bit so that we can have a bigger view?
I will take this cannula out. So
yeah,
now it's go, okay?
Yeah, much better.
So you have a protector also, na PCF protector. The angular protector is there. Na? You can, or you can drill over this also.
So they don't have that instrument?
Yeah, they have.
Yeah, that's the good instrument.
Yeah. This is a very good instrument.
It will prevent the bead pin from overshooting and will also help you to
hold the cannula.
Distract
hold
the
the
capsule
cannula
as well.
Actually, it has got 2 functions. You can use it as a liberator also.
A liberator.
Yeah, so you can use as a liberator also. So again, you put it under direct visualization. Don't try to damage your cartilage. Go that and park it in the desired area. So once you have parked it, again move to the posteromedial portal.
It's a good way to do that, to avoid iatrogenic cartilage injury.
Yeah, so always do under direct visualization. You can see this is a good protector. You can see here, I think, yes.
Clearly
fire. So always use this, and this is there with the Smith & Nephew set. Yeah, go.
So you do direct 9.5 or you do sequential removal?
Today I think he has put 9.5. Let's go with. What happens with sequential limbing? Your bead pin is every time coming out. That is the disadvantage. The advantage is that you go less charring of the cartilage.
Got it.
The cancellous bone. Go. Don't worry. Yeah. Go.
You always
slow. Yeah, slow. Go slow, to and fro. So at this time, this is very important. See, now you can see the movement in the posterior cortex. Hand with hand. Try to push it with hand. Yeah, go. Yes, and then again push. Go. Yeah, go. See, with hand rimming only, I have come out. Huh? Go with hand.
Very important.
Yeah, go with hand. Yes, fantastic. Yeah. So come out again with hand is coming out. Take it out. Oh, fantastic. Yeah, wonderful guy with me today.
You always prefer to do tibial tunnel first?
Always.
I prefer to do it last to prevent extravasation of fluid.
So this is very important step. So most of the time this soft tissue, it comes in between your graft. So you prepare it. So burn this part so that you have a clean tunnel there. You can see the whole of the tunnel here.
Yes,
so there should not be any soft tissue in between. Yes. Again. See, I have shifted it to posterior portal. Again, I will clear the soft tissue. Most of the time, we struggles for only to pass the graft.
Agreed.
So you can see. There is a very good sound system for this RF. I don't know. My RF in Calcutta, they give different sound. In Vizag, I don't know.
Them to transfer this to your place.
Oh, so Sridhar has made some very good musical setting here in his RF. So loop. So now I will pass my loop to the tibial tunnel. No, hold. So no, do it like this. See, this is the best way. You lock it.
We are not able to see.
Yeah, I will show you. So now I am you can see I am locking this loop over the bith pin. You can see here, and you just passed over here.
Okay.
So passed here. Hold it. Hold this one. Push. Sucha manipulator. And just push it. Your bith pin is there. Nothing to worry. And hold the cannula, please. Someone. Yeah. So you can see here. This is my. Just rotate. Just rotate. Yes. And yes. And now you park it in the postomedial portal. So you take it, you park it, and now take it out. Both the thread. Yeah, wait. Take it out. Yeah. Only pin. Yeah. You can have one another thread. Hold it. Yeah. Take it. Wait. With mosquito. So you can see now I have parked it. Another one, a smaller one. Hold it. Push. Pull. Nothing to worry. Pull. Leave that one. Yeah. Pull. Equal length. You got it, na? Bas.
So Rajiv,
wait. Yes.
All your PCL you take posterior-medial portal or can be managed because there are surgeons who do manage with only 2 portals as well.
2 portals means only the no posterior-medial portal. You are telling?
Yes.
No. I think for PCL you should make posterior-medial portal, or you can reconstruct your PCL, but that will be high up. You can't go 15 mm or 20 mm.
They are very experienced surgeons who are doing with only 2 anterior tunnels if they are not seeing the posterior anatomy well.
Alessandro Lilly, he does with only 2 portals.
But we have seen his surgery. The tunnel was quite proximal,
very high.
Quite high. So always.
9.5. 9.5. So here 11 number blade. Can you focus here?
Very risky.
The same Sandeep technique I use for femoral tunnel. I put for first my 9.5 millimeter. Yeah. So what do you prefer? Passing your graft from tibia to femur or from femur to 9.5? Yeah. Anyone from here? Flex? Yeah.
From tibia to femur.
All right. So I will. So you can see here. This is the point I have marked. You can see this is our notch, center of the notch. You can see here. This is the center of the notch. So high up and just close to the condyle bone. You can see this is 9.5. So I am. There, go. A bit of flexion. A bit. That's good enough. And fire.
I pass my graft from femur to tibia.
Oh. Any advantage, Sandeep?
Sorry?
Any advantage of that, Sandeep?
I think it's very easy to negotiate the killer turn.
Yeah. So take it out 4 millimeter. Or you can go through and through also, not an issue.
So femoral
Yeah.
fixation is always
Yeah.
with a suture disc.
9.5, no? Yeah, go through and through. This is 9.5, no? Over the, yeah. Just take it out a bit. It's not a bad, but we'll take, its position here is good. Yeah, it seems to be good here. Not bad position. Take it out, take the both, yeah. Now flex a bit, yeah. Yeah, and now. Now take the bit pin out, yeah, take the bit pin out. Just I will readjust it, huh? Yes, good position. Yeah. Take out. A bit of flexion is needed, huh? Just to flex. Leave it. Yes. Take it out, take it out, take it out. Good. Fantastic. Fantastic. So I will try to make it here. Yeah. And go. Bas. Bas. Good enough. Good. So it should be at least 8 to 9 millimeter away from the subchondral bone. Wait. So don't try to push. Yeah. Just fire. Yeah. Go. Take it here. No. Go. Just drill it first and then go. Fire. Go.
So he is using that drill sleeve as
so
the
through and through.
9.5 mm drill bit as a sleeve, so that you remain as close to the cartilage and as high as possible.
Just 4 minutes, through and through. No, yeah. Just, and now I will ream through the 9 meters. So if your condyle is good enough, sometime you may use an adjustable loop also. So I will use a aperture fixation. What is your preferred choice? Go.
I do suspensory fixation on femur. And,
Go.
on tibia.
No, it's not working. Please make one more bead pin, a loop ready. Huh? Keep a loop ready over the bead pin. Yes. Go through and through. Go through and second cortex. Yeah. Go. Done. Huh? Come out.
So how much you have drilled, Dr. Rajiv?
Yeah. Hello.
Yeah.
It's 35. 35 we have drilled. So I will use you can load this loop there. Na?
What was the size of the drill bit?
It's 9.5 only. The graft is 9.5.
So you drilled through and through both the cortex?
No, 5 millimeter lateral medial cortex is intact, but.
So you are trying to put 35 mm graft in the femur?
25, I think I will put.
What's the length of your graft?
Graft is good. It is around 14. It's around 14.5 because it's 2 semity and 2 gracilis. Na? Yeah, one peroneus and one semity. Can you RF please?
So usually we put 20 mm graft in femur.
25 I try to put it in femur. In this for PCL.
No, he had not done through and through.
So for ACL 20 is good enough.
So, Rajiv, you have done through and through the whole tunnel. You are fixing with screw?
Yeah, I will fix it with the screw. So done. Leave it. छोड़ दो इसको बस. So now you have shifted to suspensory fixation, Mukesh. The only issue with suspensory fixation for me, Mukesh, is that most of the time, what happens, the medial cortex is very thin. If you see in the X-ray also, suture manipulator. So you need at least 10 millimeter of medial cortex as compared to the lateral cortex. So now I will ask my assistant to push it like this. Yes, fantastic. And one of the assistants will hold the lower limb of the tibial tunnel suture loop. And just push it. Just I will take it. So what you do it like this? Yes. So you are making it in front of me. Huh? You are bringing it in front of me. Good. Fantastic. नीचे वालों को पकड़ के रखा है ना बेटा? बस बस ठीक है. So now this is my tibial tunnel. Take it out. So Sandeep,
Yes.
use नीचे वालों को पकड़ के रखना, बस ठीक है. So I have taken it to the anterolateral portal. All right, good, done. So now I will first pass my graft through the tibial tunnel, and then I will take this graft to the femoral tunnel. All right. So I will do like this. It's a reverse manner. I will. Can you focus here? Anyone of you? Graft is ready. Diameter ठीक से देख लिया ना? So I will. So this is no. This not. Which one is tibial side? This one. 4 थ्रेड है ना? चलो ठीक है. इक्वली गुड. दिस इज. अरे इसको नोट करना था बेटा. रुको रुको एक वेट. अब तो एक ही थी बॉन्ड ले लो. इसको भी बांध लेना था. अदरवाइज क्या होता है, ब्रेक कर जाता है ना. एक ही थी बॉन्ड से थ्रू एंड थ्रू ले लेना था. दिखाओ मेरे को तो. नहीं इथी बॉन्ड एक मिनट. So you can see the graft. I have tied it at both the end for aperture fixation.
Zoom out picture, outside camera.
20 मार्क बाइकिल से यहाँ पे कर दूँ. यहाँ पे 20 मार्क. here.
Outside camera, please.
Outside camera.
Zoom
बाइकिल
in.
ले आओ. 20. Like here 20. This marker pen. Yeah, you can put it here. 20. This is 20. 20. Yeah. All around. 20. And then this is 25. Put it there. Yes, 25. Yeah, bas, done. Yes, 25. So this will go in. So one more. Because sometime what happens when you pull it, equal length. Good. Mukesh, you prefer using a screw also with your loop, because what happens when you put your loop inside, you see some amount of residual space is there.
I always prefer suspensory. Sorry, Rajiv.
Oh, no, after putting suspensory, so the surgeon put a screw also there.
Additional fixation, no, I don't do. I do additional fixation on the tibia for my PCL, screw along with the suture disc or a
All
post.
right.
Always
Cut it.
dwell on tibia.
All right. So different way, good. So now focus it here. So I will take this thread to the tibia, take it out. Take. Take. Yeah. Yeah. No. So, hold it here and rotate it. इससे पकड़ लो needle holder से and rotate it. Graft will go inside. No, all the threads. Yeah.
So Rajiv, you are shuttling through the portal, right?
Yeah, through the portal only. Yeah.
Lateral portal.
Yeah, lateral portal.
So from portal to tibia out.
Yeah, tibia out. That makes my life easy. Hopefully today also it will make my life. Pull. No, you rotate it. Yeah? Don't hold it. Just I will do it. See, leave it. So just rotate it, because sometimes what happens. This is there. So you can see the graft is just out.
Yes.
At this stage, hold it like this. Again. Now pass your suture through the femur.
Okay.
You got it?
I got it.
Yes.
So from the portal, from the anterolateral portal, he had passed the graft in the joint and took it out of the tibia.
Yeah.
So this will prevent the killer effect on the graft.
Yeah, go,
it
take it.
reduces. Rather than going up, you have that
Take
the
it.
edge of the tunnel, it scratches the graft. So this is the other way around.
Take it out.
So when you do this way, the soft tissue which is there on the mouth of the tunnel, it tends to go in and it prevents also
Needle holder.
some of the damage to the graft. So from portal to
And guide
tibia
wire.
and from intra-articular to femur.
See, right now you can see my graft is at the tunnel at here. So you can see here. So
Yeah.
just you put your guide wire and your job is done.
Yes.
Hopefully it is done. So now I put my guide wire here, yes, and now with the, such rotate, just the way I rotated there, huh? Just rotate and your job is done. You will love this technique, huh? Go, rotate, just rotate, rotate.
We love all your techniques, Rajivda.
I will do it for you. Some issues, wait. Just halka, gradually pull, huh? Gradually pull. And the 20 graft is inside, gradually. Put a counter traction there. So, yes. And see, on the direct visualization you can pull. All right, go. This 20, this is 25. Go. Screw 9. Keep ready, 20, 25. Just pull, gradually, pull. Don't worry, na. So, whatever, do it. Hold this one. Hold this one, or here. Camera, hold my camera here. Anyone can hold the camera here. I will pull it for you. Yeah, you come this side and hold this camera.
9.5 diameter. Rajivda, what was the length of the graft?
It was 14.5.
14.5. He took double peroneus and double 70.
हल्का लूज करके रखना है बस, हाँ हल्का. Yeah. So you can see gradually my graft is going in.
Yeah, clearly visible.
It's a tight graft, 9.5. It was 10. I told them to make it 9.5. 20 is in. It's very tight here. Let's see here. 25 screw is there, na? Can you give me a cocker or something like that? So it's 9.5, na? Give 8, I think 8 would. Let me see, I will tell you. Just show it here. Yes. From here. Just hold it here. Yeah, yes.
So in what position you fix the screw?
Yes, it's going in.
Raju,
just a 100 degree of flexion I will put it, because otherwise.
Another way to pull the graft is what I do. I just ask my assistant to hold that artery tight and you take the knee into flexion extension. The graft easily moves up.
All right. Yeah. So, wait. Yes. Wait. Yes. Hold it. Yeah. I will just probe it and yeah. Now it's there. 22 is wait again. Another 2-3 millimeter. It is done. I think they're tight here. Yeah. Now we pull it just halka. So just some amount of what happens. This graft usually get tags also there. Just pull halka. Grow gradually. Yes. Go. So what amount of graft? Just wait. Pull. Huh? That will be good enough. Just pull. Oh. Wait. Ow. 5 number ithi bond has broken out. Not an issue.
You had a plan B ready for that?
Yeah, plan B is ready. Don't worry. Because I will make it. You have to take it out, no issue. Again, tie it.
So that's why I don't pull it hard. I just ask my assistant to pull it and you just keep doing flexion extension. It automatically comes up.
So by that time you can complete your talk. Just I will repeat this because I have to repeat those steps. Yeah.
So we'll go ahead with the next talk. Do we have case discussions?
So leave it. It will come. Not an issue. So what you do, Not an issue. The tight is not an issue. Huh? It happens. Huh? So you tied the ET bond through this. Give me. And make it a bit thinner. Huh? Here, no, here only. Hold it, I will do it for you. Just hold it there. I will make it a bit. So what happened? This part of
Rajiv
the
da,
yes,
by the
yes.
time you redo your graft, we'll take one case discussion.
Yeah, please, go ahead. And
Mr.
once
Shiv.
I am done, I will come back. Huh?
So once you fix the graft, then only people will get lunch.
Done. I will do it in next 15 minutes. Don't worry.
So it's up to you when you want to give them lunch.
I want them to have a good lunch today. Yeah. Chalo. Now it bond. Yeah. Hold it like this. Not an issue. This 5 number, na? Ethibond, it is ethibond? No, I don't think. It is ethibond only. Centibond, it's not true bond. Huh? So you should have used ethibond. Ethibond will not break. One more we will need. Huh?
So we'll have Dr. Shiv Kumar with his case. Can
Good
you change
afternoon,
the screen?
everyone. So till now we have been seeing ACL reconstructions. So I thought I will present a different case, that is ACL tear in a pediatric age group. So here is a 11-year-old boy who had a history of fall while playing football 2 months back. He took some rest, he is all right, he is doing his normal activities, and again he wanted to play. Again he had a history of fall 2 months later. At that time he presented to me. On he has a history of instability, and on clinical examination Latchman test was positive, anterior drawer test was positive. Range of motion was 0 to 100 degrees, and this is his X-ray. And on MRI, there is a complete tear of ACL. There are no other injuries like meniscal tears or chondral injuries. So, how do you proceed, sir? Mukesh, sir?
Is he complaining of instability, frequent fall?
Yes. This is the second time he had fall while playing football.
So I'll definitely go for surgical management because MRI is showing complete ACL tear, and also on your clinical examination and history wise, so it's not going to heal without surgical intervention. He is 11-year-old only, so I'll do total transfascial ACL reconstruction with outside in femoral.
That part will come later, sir. Any other opinion, any other conservative treatment opinion from the
Anyone
panel?
conservative? Sandeep?
Sandeep.
He is busy. He had not seen the game. He's an 11-year-old boy with complete ACL tear, complaint of instability, clinically and MRI wise, this complete ACL tear. 11-year-old boy. So will you do conservative or you will go for surgical?
Latchman is positive, anterior drawer positive, range of motion 0 to 100 degrees, and no other pathology like meniscal tears or chondral injuries, nothing.
Is unstable.
It is unstable.
Then I think it's surgical only.
11
No
year.
role of conservative.
Yeah.
Anyone from audience will conserve this?
Anybody wants to conserve this patient? 11 years old boy.
Okay.
So I hope everyone agrees for the surgical management. So when to do surgery? Immediate or delayed after fascial closure?
I'll not wait. For fascial closure, you'll have to wait for another 5-6 years. He's 11 years. The growth, secondary growth spurt has just started. It's not been completed. Then there are various scoring systems which you do to assess the amount of growth remaining. If he would have been, say, 13 years plus, I would have done a transfascial also. But now he's 11 years, The physes are yet open, and being a boy, the secondary growth spurt is just about to begin. So here I won't do any delayed reconstruction, I'll do right now, but all fascial sparing.
Sandeep sir.
Immediate surgery.
So what is the problem if we delay, sir?
Being unstable, 2 times he had fallen in 2 months. He will break the meniscus, he'll get some cartilage injury.
So that is the reason we should do immediate surgery in this patient, because if we delay for the fascial closure, meantime he will have repeated falls and he will have other ligament pathology or meniscal pathology or chondral lesions. So what technique you want to follow? There are 3 techniques. Fascial sparing, that is all epifascial, the first picture. Second is partial transfascial, that is femoral side it is epifascial, and on the tibial side transfascial, and complete transfascial, the third picture. Which technique do you want to follow in this patient of 11 years old boy?
Sandeep?
Sandeep?
For the femur, fascial sparing, and for tibia, means, like I'll be going for the suspensory fixation, so I won't be hesitating to do transfascial.
Transfascial. Your
Total,
take, sir?
I'll be do complete fascial sparing.
Okay. Any criteria do you follow for selecting these procedures, sir? Any criteria do you follow, like age or
I was saying
physis?
age, secondary growth spurts, I think it's a Tagnard scoring or something which you have to do and see how much amount of growth is remaining. But being 11-year-old boy, the secondary growth spurt has just started. So another 2 years he will have a significant growth phase. So I don't want to damage any physis neither on tibia nor on femur. So I'll prefer both fascial sparing ACL reconstruction.
Any difference of opinion, sir? Mike.
I think both are good options. One, because complete sparing of this physis, epiphyseal is great. With CM guidance, we can do it. And what Sandeep also mentioned, because we have to go according to the Tanner stage. And the only thing is, we have to keep the principles of when we're using the physis. 11 years, we can still do it. But certain principles of when we are going through the physis, we have to keep certain principles. The only thing we have to remember. That's what I feel.
That means oblique tunnel versus vertical tunnel.
Right. Yeah. And the other, I think the panel can discuss, I think it should be a more vertical tunnel, because more oblique the tunnel is, the more of the growth plate goes. Yeah. And what Sandeep was saying is very valid, because he's planning to do a suspensory fixation both sides. So that's a very critical point, because you don't want any kind of metal or any kind of hardware in the fascial area. Yes. So that is another important thing. And another, I would say that there is a very important paper regarding the graft size. What is the size of the graft? Yeah. I think the panel can elaborate more on the graft size.
So we have to decide depending upon the Tanner staging, whether it is stage 1, stage 2, stage 3, 4 or stage 5. And we have to take bone age into consideration, not the physiological age, bone age. For that we have to take X-ray of the hand to determine the bone age. Depending upon the bone age and Tanner staging, we can decide the treatment in this aspect. So here, this is the algorithm we will follow usually. For a complete ACL tear in a prepubescent, that is less than 12 years, if that Tanner stage is 1 or 2, we can give a trial of non-surgical treatment, activity modification, functional bracing. And if there is recurrent instability, then in that age group, fascial sparing is the ideal. All epiphyseal, that is all inside, hamstring autograft. If he is an young adolescent, that is growth remaining, Tanner stage 3 or 4, and 13 to 15 or 16 years age, then we can consider partial transfascial, that is on the femoral side, all epiphyseal, and on the tibial side, through the transphysis. And older adolescents, Tanner stage 5, or more than 15 years, then we can do adult ACL reconstruction, like in adults, without considering the physis. So what graft do you want to prefer in this case, sir? Soft tissue or BTB?
No doubt, soft tissue. BTB you can't have, his physis are still open.
So no bony grafts in this age group, only soft tissue graft, either hamstring or peroneus. So what is the fixation method you want to follow, sir, on the femoral side and on the tibial side?
So first of all, the tunnel will be very horizontal on the femoral side.
Femoral side.
It will be a horizontal tunnel outside in technique.
Outside.
You have to be parallel to your femoral physis. And tibial side, you have small tunnels. So the graft will be hamstring, only semi-T, maybe double bundle only. I don't want diameter more than between 6 to 7 mm diameter only. And on the femoral side, I'll prefer to use endo button direct, because I want my whole graft to be in the tunnel, because the tunnel length is too small. You can't use your any suspensory fixations like endo button CL or any adjustable loop. So I'll loop it over endo button direct, and on the tibial side, I'll tie it on the suture disc or anything like that.
Any other fixation method?
No, so for me, femur side is adjustable button, all inside with the flip cutter. Tibia is through and through over the jig.
Okay.
Graft either semi-T or CQT, and femoral tibial fixation with suture disc.
Suture disc. Any other difference, sir, from the panel? Okay. So what is the rehab you want to follow, sir, after the fixation?
What you did first.
I'll show you.
Then we go for rehab.
Okay. So this is the position, and this is the diagnostic scopy. He has complete tear of ACL. So femoral tunnel outside in with flip cutter. And on the tibial side, through the CM image. This is also fascial sparing, all epiphyseal. So we need to use the CM in doing the tunnels for pediatric ACL, because we have to avoid the physis. And this is the quadrupled semi-T graft. And on the tibial side, I have pulled it and tied it to the suture post below the epiphysis.
Very well done, sir.
Yeah, this one. This is after 3 months. He has complete flexion and complete extension. And this one after 1 year. Just yesterday's video, I asked him to send a video. And this is after 1 year.
Excellent results.
What was the diameter of the graft?
Sir?
What was the diameter of the graft?
Diameter was 7 mm, sir. That is quadrupled semi-T only. Thank you, sir.
Nice.
Thank you very much.
Can we to Rajiv da? Can we connect to OT? I think the rehab protocol was same like we do for routine ACL.
Done.
Rajiv?
Protocol. So
Yes, we are back.
Yeah, so it was Senti bond with back down. Now I have used Ithi bond, true James bond. So Sandeep was victim of Senti bond in Durgapur also. So now you can see the same technique. We have passed the graph. It's 9.
The screw, so.
It can give 8 or counter. Niche graft pull also.
So what is the diameter of the screw, Rajiv?
So here I am using a screw 9 only.
9 by 30?
925.
25.
Any thought process of putting the screw from outside in rather than inside out, as it will do less damage to the graft?
Yeah. See, you can do it either way. But one of your
from outside will damage it less.
Yeah. So what happens? You can put it either way, Mukesh. But since I am doing it inside out drilling technique, so just your head of the screw should be touching the inner cortex. And when you are doing it outside in, you don't know how much amount of graft is there in contact with your screw.
Anyhow, you have done through and through tunnel.
Almost through and through tunnel. Counter. Anyone will take the guide wire out? Guide wire here. Otherwise, again, you will stuck.
For outside in, you have to have the graft in the full in the tunnel.
Yeah.
Till
With
the mouth.
140, he could have done that.
Yes.
140, na? So, Sandeep, this is not my teeth, it's the real sound.
It seems like your teeth sound only.
No, no,
because
no. Hammer, take it out.
We are familiar with
Yeah.
sound.
Take it out. Take it out. Guide wire is out, na? Yeah. So now you can see this is a good
Very-
PCL graft
very well.
there. So just a bit of cyclic loading and then I will put it in 90 degree of flexion with anterior door. Come on. The advantage of having peroneus and semity is that you have a good length there. So you can plan for aperture fixation. So 90 degree flexion. Come on. Take this out, na? This. More. So I need 90 degree of flexion, na? Here. So when you are doing isolated ACL, PCL, ask your assistant to put an anterior door, again toker. So 10. You have maximum size 10, na? You don't have a 10. 10, no 11, na? All right, give 10 then. 10, 30, na? Here, 30.
So,
For
Dr.
tibia tunnel, always use a larger screw.
So what did you just do? Can you just tell us?
Hello? Yeah, with the toker, I try to put the toker in between the graft and the tunnel. If it goes easily, it's to 2 size more. If it goes with difficulty, or if it's not going, you can use same size. So I think it's going with a bit of difficulty. I could have preferred 11, but 11 is not available, so I will put 10. And anyhow, for tibia, I plan for a supplementary fixation also. I will always put a suture disc there.
Yeah.
Done? Yeah. So one person should be ready. Push. Anterior door, yeah. We can put the screw. So you can see the position of the limb.
Yes, yes.
And at this position, take the guide wire.
Assistant giving anterior drawer, that is the important step there.
Take the guide wire out. Guide wire. Hammer and guide wire out. I will put it. Take the guide wire out. It will not come like that. Yes, fantastic.
What's the size of screw here?
10. But it's good, tight enough.
10 by 30, 35?
Rotate. Rotate, rotate. Put the screw there. Yeah, go, go. Go, go. So I will go at least 10 millimeter inside, but my tibial tunnel was around 45. Go, go, go. Go, 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 go. Go, go, go. Go. Go, 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 yes, yes. Go, yes, take it out. You can see the posterior door is negative now.
Yes.
So just I will show you how this PCL graft works. Water. You can see the sag in the ACL is gone. Please.
Inside pic, please.
Inside picture, you can see the laxity in the ACL is gone, and you can see the whole of the PCL graft is coming from posterior aspect of the tibia. That is your PCL graft.
Yes.
And it's almost 15 to 18 millimeter down. That gives you a good posterior protection. Posterior sag, prevention of the posterior sag. You can see it's coming from here, it's going upward, and at least it's coming 15 to 20 millimeter down to the posterior joint line. And this is the importance of keeping it at least 15 to 20 millimeter below the posterior border, posterior joint line, so that you have a good posterior support that will prevent your posterior translation of the tibia. So I am done. Just I will put a post here, which I do routinely for supplementary fixation.
Excellent demo, Rajiv
Yeah.
Da. Excellent surgery.
Rajiv sir, can you hear us?
Yeah, yeah.
Sir, thank you so much, sir. So thank you so much for being us.
See, after demonstration, you told me, sir, you don't have to go talk. I will like rush for airport. Huh? So live demonstration, I think PCL talk is not needed.
No, sir. It's an excellent demonstration.
Yeah.
We all waiting for our live surgery only.
Yeah.
It's 2:30. People are still waiting for you only without having lunch.
All right, all right.
So
Thank
that's
you
the
so
craze
much.
you
Thank
have.
you so much.
Thank
And
you, sir.
thanks to
Thank
the
you so
OT
much.
staff, assistant, all the OT staff.
Thank you, sir.
Post.
Thank you so much,
Yeah.
sir. We'll break out for lunch and we'll join back around 2:50.
Post. Anyone can put here the post. Post and need that. Yeah. Post and tie. Huh? Chalo. We'll go. One photograph with the team. Yeah. You can take now.
Can I have Dr. Sivanand, sir, for moderating the next session? Okay. Please come. So we have this. Dr. Ashish present his case. These are over. Dr. Venu, yours. So Raman. Should I tell the lecture? Oh, you want to start with that? Yeah. You want case studies? I will. No. You want to start with that? No, whichever. Start with the case study. Moderation. Stop. Okay, then we'll go with the case study. Okay. We'll invite you. ఎట్లాగంటే ఆయనకి
it's a normal meniscus. These are crescent-shaped fibrocartilages. Both have peripheral vascular borders and inner avascular borders. Usually medial meniscus is larger than the lateral meniscus, which is circular in shape. So this is the normal anatomy of the meniscus. Attached to the tibia with coronary ligaments. This is the posterior horn, usually much larger than lateral meniscus, and posterior border is much larger than the anterior horn, and attached to the femur by a deep medial collateral ligament. And this is the lateral meniscus, semicircular, occupies almost 80% of the articular cartilage and takes about 70% of the stress of the joint, or the lateral joint, and usually more mobile than the medial meniscus because it is loosely attached to the tibia, and usually attached to the femur by posterior meniscofemoral ligaments. This is a vascular anatomy. Usually peripheral 25 to 30% is vascular. Medial meniscus is around 30 and lateral meniscus is around 25. Biomechanics. The most important biomechanics is load transmission. Meniscus helps in converting the axial forces into circumferential forces called as home stresses, and therefore helps in shock absorption. And because of the more mobile structure, as the lateral meniscus is more mobile, it will lead to the medial meniscus is more prone to damage than lateral meniscus. So meniscal tears, usually on location, they can be classified into red-white and white-white zones tears. And red-red zones and red-white zones have good healing prognosis and better to go for meniscal repairs. And white-white zones are better to go for partial meniscectomy. The types of tears, based on arthroscopically and clinical findings, can be classified as vertically longitudinal, transverse radial, horizontal cleavage, oblique, and circumferential. Other like complex root tears and ramp tears also there. So according to Cooper's, can be classified under radial zones into ABC from posterior to anterior. It's more helpful in the treatment options, like in in A area it is in all inside technique repair, and in C it is outside in, B it is inside out. And 4 circumferential zones. 0 is meniscocapsular junction, 1 and 2 are outer and mid-third. They can be treated through meniscal repair, and mostly third zone will go for meniscectomy as it's avascular. So diagnosis, physical findings, joint line tenderness, swellings, physical examination by McMurray, and MRI findings will be there. MRI is confirmatory, specificity around 95%. Partial meniscectomy. So initially it was the most common treatment for meniscus, but right now with new modes of treatment in meniscal repairs, this has become less and less common right now. But it has some advantages, like major advantages: preservation of peripheral rim, as only the inner layer is removed, and it facilitates rapid rehabilitation and functional recovery, and we can start full weight bearing almost immediately after the surgery. So in Northernmost Ball et al. Reported around 90% excellent rates, but these are compared to total meniscectomy rates. And usually medial meniscectomy has better results than the lateral meniscectomy. Lateral meniscus better to be preserved than medial. So, and one more study by Bucks, almost at 15 years the patient has good results, but usually 90% good results after 2 years, usually decreases to 62% at 8 years. So indications, so symptoms which are refractory to conservative treatment: avascular zone tears, coexisting degenerative synovial fluids, irreducible buccal tendon tears, degenerative tears, chronic tears. So coming to guidelines, the most important aspect is remove all the mobile structures, mobile tears. So wherever the tear is mobile, just pass a probe underneath, bring it to the center of the joint, then you will know the peripheral edges, posterior and anterior horn edges. So first start with the posterior edge, partially cut it open, then cut the anterior edge, then trim the meniscus. If you have any doubt, always try to preserve it rather than remove the meniscus. And accurate accurate C-shaped contour is not required because it is known to remodel in next 6 to 9 months. So its goals are remove the torn meniscus, preserve as much as meniscus possible, and stabilize the joint by preserving the capsular attachments. That's the most important. So these are the operative settings. These are anterolateral and anteromedial portal markings. So these are various illustrated through which portal. So usually the posterior horn of medial meniscus can be seen through lateral portal, and working portal is usually on the medial side. But the anterior horn is better go for medial viewing portal and lateral working portal. Similarly, in lateral meniscus, posterior horn through medial viewing portal, and anterior horn through lateral viewing portal. Just a schematic diagram how to go with the meniscectomy. The first diagram is of the this is the long vertical tear. Always start with the posterior, remove the posterior part first, slowly come to the anterior, then contour it in the C shape. According to the tear, you can contour it. And this is the oblique tear. Remove all the posterior fragment, then start contouring. So this is the radial tear. First start with the posterior resection, then remove the anterior flap, and then contour. Accordingly, do with the horizontal cleavage. Horizontal cleavage stage, remove the superior and inferior fragments, then go for flap repair with sutures. So this is the case of partial discard with complex tear. The torn discard is removed first, then excision of the lesion. After do the balancing, and in the third you can see the superior and inferior flaps which have been repaired and retained with the peripheral attachments. This is a chronic bucket handle tear, more than 1 year old. Hence the tear is excised, and the last slide is the after balancing of the meniscus. This is a case of partial discard. There is a complex tear here. After the tear excision, this discard place is there. This is removed, and again you see the superior and inferior flaps, which is again repaired with fiber wire passed through a scorpion needle. This is a case of complete discard. Okay. The down one shows the punching of the lesions, and the upper one is after the discydectomy and contouring. You need not go for the complete C-shaped, because by doing so you remove more of the meniscus. So accept the whatever meniscus is there, so that it will contour itself in next 6 to 9 months. This is a case of chronic bucket handle tear. The tear is excised to the tear is attached to the ACL here, and it's almost 3 years old bucket handle tear. So what we have to do is I removed the attachment from the ACL, cleared it, but the peripheral fragment is big enough, so I have to do an inside out repair here, and after the repair, this is a picture. This is a video after the repair. So most of the lateral fragment is retained. Almost 3 to 4 inside out sutures are applied in this. This is a irreducible bucket handle tear. It is also almost 3 years old. So this is a tear which is not reducible, so I removed it. And this is a picture after the meniscectomy. This is a medial meniscus complex tear. I removed the middle fragment, central portion of the tear. So again, superior and inferior flaps are there. And if we leave it like that, again there will be a chance of tear. So I put a fiber wire and repaired it. This is a suture passer after passing the sutures, and this is the end result. We can keep 2-3 sutures also, but here we got stability with 1 suture, so I did only 1 suture. This is a complex tear of the anterior horn. The tear is excised. but there is a peripheral tear in the meniscus. So I did outside in technique, and there is a post picture of the outside technique. So complications are neurovascular, instrument breakage, and anesthesia complications. Post-operative, look for DVT, infection, synovitis. And rehab, usually first post-operative only we can start full weight bearing. Second post-operative week, we can start with rested exercises. And third week, full rested exercise. And sixth week, we can start with sports activities and normal other activities. So conclusion, meniscectomy would provide good clinical improvement when performed with good surgical technique and try to preserve as much of meniscus as possible. Thank you.
Thank you, Dr. Venu. I request Dr. Ashish to present his case.
Good afternoon, everyone. I have a case. So this case is regarding a gentleman, 36 years of age. He is a construction worker and sustained injury as a fall from bike. Then he presented to my clinic 8 days after the injury. And on examination, there was not much effusion or ecchymosis. There was only mild ecchymosis was there. Latchman test was grade 3 for PCL laxity. And valgus test was at 0 degrees, it was grade 3 medial opening was there, suggesting a MCL tear. This was the X-ray. X-ray looks quite normal. There are no bony avulsions or any fractures, nothing is there. And these are the MRI images, which clearly shows the complete tear of MCL from the femoral attachment. And the sagittal section shows a complete mid-substance tear of the PCL. So with this information, young individual who is in a highly demanding physical activity profession. So he's almost like a manual laborer, we can think. So how can we go ahead, Praveen sir, with this information?
So this is a case of PCL MCL.
Yes, yes, sir. So what do? You want to conserve the MCL because femoral MCL, femoral tear from the attachment, MCL tear at the femoral attachment, they tend to heal. There is a tendency for it to heal. So shall we wait, conserve it, the MCL, or do a single stage MCL and PCL?
Yeah.
What is your opinion, sir? How can we go ahead?
How many days old is this?
This is only 8 days old, sir.
8 days old. Okay.
And if you want to do a reconstruction, will you do a repair, MCL repair, plus or minus augmented, or directly only do an MCL repair and defer the PCL reconstruction for the later date?
No, for me, I do both at the same time.
Same time, sir. And what would be the ideal timing, sir? Shall we wait, or 1 week post-injury, is it sufficient?
Isolated MCL grade 3 usually will heal, but if it is associated with PCL and other ligament injuries.
Pardon, sir?
Isolated MCL will heal usually, but,
yes, sir.
But MCL along with other collateral ligaments or PCL injuries, the healing is a little bit difficult.
Yes, sir.
So that's why there is no, 8 to 10 days is ideal time. We can go ahead with both the PCL and MCL at same sitting.
Same sitting, sir.
Yes.
Okay. And ideally, I think within 2 weeks after the injury, I think we can go ahead and simultaneously treat both the MCL and the And for MCL, what would you like to do, sir?
I do augment and repair it if possible.
Okay, so repair and augment. And
Yes.
is the augment like, will you use a graft, sir, or tape, semi-T graft, or?
No, no, my augment, I do routine MCL reconstruction along with it, if possible, repair on the top of it.
Okay, so repair the edges,
Augment
whatever we
with-
can get, and on top of it, reconstruct with the graft, semi-T
Augment
graft.
with autograft only.
Oh, okay, okay, sir.
Yes.
Ravideh, sir, what would you do? Anything you will differ, you would like to differ, or?
No, I do the same, sir.
Okay.
But I'll reconstruct the MCL with semi-T and repair as well.
Okay.
And with PCL.
So the thing is, this so I was planning a single stage MCL and PCL reconstruction, but the patient had other plans. He lost follow-up. He presented after 5 weeks. He took some multiple consultations, native treatment, and when he landed with me, his knee was stiff, just less than 75, 80 degrees RM was there. And his complaint was pain, and he was not walking. So first I thought I would restore his range of movement. So we did, at least for I think 2 weeks, physiotherapy was done. And on re-examination, the residual laxity was there. For PCL, it was grade 3, and MCL like grade 2, grade 3. So how would we go ahead, sir, now? Is the same? Shall we reconstruct both? Or shall we conserve MCL and reconstruct only the PCL? Anything you would like to differ from the earlier plan?
See, as the time goes on, there is a lot of arthropibrosis, and patient will have a limited range of motion and functioning, and functioning will come down, as well as atrophy of the muscles will happen. So for me, if it is MCL 2-3, then also I will augment, and PCL as usual I will reconstruct.
Yes, sir. So I think our plan was also to do a single stage PCL reconstruction and MCL anatomic reconstruction. But due to the financial constraint of the patient, and you all know that we are in Andhra Pradesh, so we are forced to work in a constrained environment of Arogyasri, government-sponsored health scheme Arogyasri. So we are working and doing procedures under that. So first stage, I did this is the laxity video. So this is the PCL laxity, grade 3 almost, and the MCL laxity we can appreciate nicely. Even after almost like this was 8 weeks old injury. So first we did a PCL reconstruction. So same standard routine protocol, like when you do a PCL reconstruction, you have to have a posterior medial portal, a high posterior medial portal, so that you can visualize the tibial stump of the PCL, and under good visualization, you can you can use the jig and drill the PCL tunnel, and this is the femoral tunnel jig. You try to, in a single PCL reconstruction, single bundle PCL reconstruction, you try to mimic the AL bundle, and this was the graft passage. This was biological PCL reconstruction. We preserved the remnants of the femoral and tibial stump. And this was the post-op intra on the table. So my assistant was doing this posterior drawer. So we completed this first stage PCL reconstruction, and we waited for 3 to 4 weeks, kept him on non-weight bearing, wanted the acute swelling to subside, and meanwhile we made him to have a knee range of movement at least up to 90 degrees minimum and protected him on a brace. Especially PCLs are more prone for elongation. So we put him on a dynamic PCL brace, and all the knee RM exercises were in prone position only. So after 4 weeks again, we took him to, for anatomic MCL reconstruction. Nowadays, I think we are familiar that this technique developed by Rob Leprad, which concentrates on reconstructing or recreating the two important ligaments of the medial aspect of the knee. That is the superficial MCL and the POL. The superficial MCL, all the earlier treatment or reconstruction, what we were doing was concentrating on only the superficial MCL. But reconstructing both the POL and the superficial MCL has given us better results. There are articles suggesting giving better native stability of the knee because of this reconstruction. So we planned this reconstruction. In this anatomic reconstruction, you have to create 2 different tunnels in the femur and 2 different tunnels in tibia so total 4 tunnels and 2 grafts. And same side knee, semi-T and gracilis are taken. And if the semi-T is good enough, a good quantity of length is there, then I think we can use only the semi-T itself also. So for the superficial MCL reconstruction, you need somewhere around 16 to 17 millimeters graft. And for the POL, you need at least 12 centimeters graft. So what is the primary function of POL? We always knew that only the superficial MCL is a primary restraint for the valgus forces, but even the POL is a restraint to the valgus and the internal and external rotation, varied degrees of flexion and extension. So the majority stability of the knee, of the posteromedial structure is the POL, especially in extension, it gives a lot of stability. So we have to consider reconstructing both the superficial MCL and the POL. So these are the images. Initially we drilled the 2 tunnels in the femur for the MCL, superficial MCL, and the guide pin you can see for the POL. And once the both the grafts are passed into the femoral tunnel, the semi-T, the superficial MCL graft is rerouted below the sartorius fascia and passed into the upper tibia. And you can, on the other side, right hand side, I think you can see this is the POL graft. Once you fix the femoral tunnel, fix the graft into the femoral tunnel, next you have to fix this POL graft into the tibial. The posterior medial border of the tibia is the insertion point. So here you can see the screw is inserted into the femoral tunnel for the POL graft, and this is the tibial screw for the POL graft, tibial fixation. Actually, ideally the fixation should be done in extension. This is just for a picture sake, we have taken this image. So this is the post-op X-ray. Whenever we are doing a PCL and the MCL, there is every chance of tunnel convergence. There is every chance of tunnel convergence. You can see lot of screws on the medial femoral condyle. So you have to plan accordingly and see intra-op also. You have to check with the II. Definitely the image identifiers helps us to create these tunnels and identify the anatomical landmarks for both the POL and the superficial MCL. And this is the post-op, 1 month post-op valgus stability video. So it looks good. So this is what we did and got a good stability. Thank you.
Thank you, Ashish, for a wonderful case.
Next, tips and tricks of meniscal repair by Dr. Rammohan Reddy, sir.
Good afternoon all. Thanks to Arthroscopic Society of India and Dr. Sridhar's team for inviting me as a faculty. I work at Yashoda Hospitals. Now what I'm going to show is part of what we have read in the textbooks, in the articles, and most of it is what I have learned over the years as in my practice. So you might find some a bit controversial, but not much, and some information which you will not be able to get anywhere. Feel free to stop me at any point, any slide, where you have various questions or clarifications. Okay? Now, meniscal repair is important. You know, it is a buzzword. Preserve, preserve, preserve the meniscus. What are the factors that influence meniscal repair? You have to understand that meniscus repair is very successful in the first 6 to 8 weeks. After that, the success rate goes down. You need to know who your patient is and the pattern of the meniscus. It's very important. You should also know your stabilization techniques. And post-operatively, if you don't protect the knee, then the meniscal repair is going to fail. These factors are very important in your assessment and in your counseling to the patient, the main tips. The next question, are all tears repairable? Think about it. If you look at these slides, the meniscus is pearly white. It is locked in the joint, in the intercondylar notch. Give yourself a certain amount of time while doing the surgery. 5 minutes, 15 minutes, 20 minutes, whatever you set the time. If you are not able to reduce the meniscus, if it is bouncing back into the notch, if there is no hint of vascularity to the tear, then it is a dead tissue. Don't try to waste your time and keep pushing it back to the periphery and repair it against the forces, against the hoop stresses. That meniscus is gone. All meniscus tears are not repairable. Then what is a good tear? Look at this meniscus in the middle picture. Nice, pink and healthy, very vascular. These are the ones which you should target. As I said before, case selection is very, very important. Don't look at the MRI report and say, I'm going to repair this. It doesn't work like that. Only when you put the camera inside the knee joint, you will know which one you want to operate on and fix it. Sometimes you get very lucky. This student had his knee locked for over 2 years. You can see the double PCL sign there in the middle slide. It was repairable. I thought I could not get it. I told the student beforehand that I'm going to take the meniscus out. So when you go in surgery, you should have your meniscal repair kit, even though you don't have the hope of repairing it. So single stage ACL reconstruction and meniscal repair, sometimes possible even at a delayed stage. What is the next tip which is most important? You need to know what is vertical suture and what is horizontal suture. Vertical suture is where you go through the capsule and through the meniscus. Horizontal is where you go through the meniscus only. Why this information is important? When you repair a meniscal tear, sometimes you have to use a combination of vertical and horizontal, sometimes only vertical, and sometimes horizontal for many reasons. Vertical suture has got the better strength as compared to horizontal suture. Why? Because it is perpendicular to the collagen fibers in the meniscus. It's biomechanics. Think in terms of engineering. You want to pull the meniscus to the periphery, vertical suture is the best one. Horizontal sutures, they are good because, as my previous colleague said, if you are working in a minimal budget, horizontal sutures will cover a lot of area to repair. You need lesser sutures as compared to vertical, number one. But the strength is not as good as vertical sutures. Number two, these are good for red in red zones, not for red in white, because the suture can cut through. Also, posteromedially, beyond the femoral condyle, sometimes you won't see properly. Vertical suture might be a problem. So horizontal repair will give you a bit of flexibility and easy to navigate. The three different techniques, outside in, inside out, all inside. You need to know the 3 techniques, you need to know the instrumentation, and finally you have to decide which one is easy for you to practice. Let's see the outside-in technique. It's a blind procedure, completely blind. Either you take 2 big spinal needles or you take the equipment supplied by the company. Sometimes you're lucky and you get into the meniscus through the first shot or into the capsule. Multiple times poking can cause damage to the meniscus, can cause damage to the articular cartilage. These are the company pictures. 2 needles at the same time, you put suture through one and pull through the other. Technically very, very difficult. Is there any better technique for outside in? How can you simplify this? Don't use 2 spinal needles. All you need is 1 proper spinal needle and 1 suture threader. What you do is put 1 spinal needle. If you want to do vertical, put through the capsule, put in a suture threader, pull it out through the portal, and then you pull in the suture material into the joint and outside. Repeat the process again through the meniscus. Pull the suture threader out and again pull it through. You make your life easy. So blindly don't follow what instructions you get from the technician or from the company rep or what you read on Google or what you see on the company website. Okay, this is what I do. Needle through the capsule or meniscus, pull the suture threader into the joint, retrieve the threader through the portal, pull the suture in and outside, repeat the process, and you tie it over the capsule. Outside in suturing is mainly for the anterior 1/3 of the meniscal repairs. As the technology improves, as you get better equipment, the outside in technique is going to be obsolete. So you don't have to think much about this. In a few years, this will be out of fashion. Outside in repair, one of the arthroscopic pictures. I've used here a PDS. You can use whatever you want, the suture material. What are the advantages of outside in? Small stab incisions, no special equipment, and only for the anterior 1/3. Disadvantages, cause damage to the meniscus, can cause damage to the articular cartilage. Difficult in placement, you have to do repeated insertion of the needles. And as compared to inside out or all inside, suture placement inferior to the meniscus is very, very difficult because you are doing it blindly. Now, inside out technique, this is my favorite technique which I use in all patients. You use arthroscope, good visualization, very simple and accurate. You can never go wrong. You can use for vertical as well as horizontal, for superior and for inferior surfaces of the meniscus. This is one technique which you need to master, and it is very easy. In a few cases, you will master it. Even when there is no meniscal tear, when you're doing arthroscopy ACL, practice it. Get the single barrel or double barrel instrumentation from the company, practice it. It's very easy. There are many ways to do it. I will show you a few slides how I do it. Either you take small stab incisions. There are surgeons who take incision across the joint, open up the capsule completely. Why? Because of the risk of saphenous nerve entrapment or the saphenous vein injury. You can use either needles supplied by the company, twin, a set of needles with suture with it, or single needle with suture material separately. It depends on the economy, what your budget is. Okay? You can use either single barrel or double barrel. Passport cannula usually not needed. All right? This is one of the patients I've done. As you can see, I don't open up the skin completely. Small vertical incisions between the sutures where I want the suture to be tied. Pull out the sutures, tie it over the capsule. You can do a bucket handle repair in 20 minutes with this inside out. right? Some more intra-op pictures. What is important here is to learn sliding knot. If you want your suture placement good, tensile strength on the meniscal repair, learn this. I'll show the video later on. It's not now. Okay. So one of the bucket handle tears where I've used inside out vertical mattress sutures. Lateral meniscus, again inside out repair, vertical mattress sutures. See, that's a sliding knot. I had to learn this from my shoulder surgeon colleague because I don't use sliding knots that frequently. All right? See how it goes in. You don't have to tie it and push it into that, okay? So what are the advantages and disadvantages of inside out? Good visualization, accurate suture placement, vertical and horizontal sutures on both surfaces of the meniscus, and it's cheap. For one all inside suture, you can get 4 inside out sutures. That's the budget. You can use Vicryl, you can use PDS. It's your choice. Disadvantages, not much. You might entrap the saphenous nerve branches if you use small incisions like what I use. The instrument set costs about 70 or 80,000 rupees, and it's a permanent set for you. You have to learn about your anatomy, risk to the neurovascular structures. Whenever you place your needles inside, whether it's inside out or all inside, diverge. Don't go towards the midline, away from the midline. If you are using medial meniscus, your needle should go to the anteroportal. If you are using for lateral meniscus, through the anteromedial portal. Sometimes you have to switch. You should be able to switch your camera so that you are not directing your needle towards the midline. So anatomy will help. All inside technique, the company will tell you all inside is the best because it's expensive and they get business. It's good for medial and posterior 1/3 of meniscal tears. It's very quick and simple. No incisions outside. No risk of neurovascular injury. But the suture strength is not as good as inside out. Inside out is you're tying it over the capsule. Here you don't know where the anchor is going and sitting. You cannot see the anchor once it is fired. All right? And I said before, it's very expensive. Inside, all inside, you can put inferior, vertical, horizontal, superior. Easy. All right? Now, common question, a common doubt is how far you should fire in. 12, 14, 16, 18, 20, the distance you have to predetermine. I'll show that in the next slide. The meniscus should be well reduced before you put in all inside. You can't do a bucket handle tear lying in the notch and I push it with the inside anchor sutures. No. The meniscus has to be approximated with the capsule before you do all inside suture. All right? For posteromedial pike crusting, it will open up the joint and then it becomes easy. Don't be afraid of doing pike crusting. I do it even for my knee replacement. It just opens up like a fish mouth. You can put a 1 centimeter instrumentation, it will still go in easily. So the advantages of all inside is good visualization. It's very quick and simple. No need of skin incisions. Very low risk of neurovascular injury. Vertical, horizontal sutures, superior and inferior placements. Now, what are the problems? It is difficult sometimes to put it inferiorly, posteriorly. Very expensive. Now, the all inside sutures, you can waste them. They get stuck while you're putting it through the portals. If you don't put in and properly and you want to take it out, that gone. 25,000 rupees is down the drain. That doesn't happen with all inside out or outside in sutures. Again, if you use a spatula or passport cannula, which the shoulder surgeons use, then you can the risk of losing the suture is better. So there are many companies, many instruments for all inside, different designs, but the mechanics are the same, the purpose is the same. The top left picture is the spatula upon which you slide down the all inside anchor. What's the take-home message? Knowledge of anatomy is very, very important. I don't do just stab incisions, I make reasonably big incisions because you have to manipulate your instrumentation. For me, inside out works the best. Outside in repairs only for anterior tears, but again, as I said, it's going to be out of fashion. All inside, good, especially for posterior, 1/3 of the tears. Now, let me give an example of what I do for a bucket handle tear. There is always a query, how many sutures do you want to use? I've seen surgeons using 15 suture materials, 15 anchors. But over the years, for me, somewhere between 6 and 9 works well. Number one. If it is a bucket handle tear, the first step is to put the anchor suture inside out, take it to the periphery. Once the meniscus is reduced, then it's up to you whether you want to use inside out or all inside. I use one inside out anterior to the anchor suture, one posterior to the anchor suture. Once that's done, I go posteriorly and then use a couple of all inside anchors. Simple. Do not direct the anchors towards the midline. Okay? The depth of anchor placement, size of the patient, is it a child, small height, tall patients? Depending on the size of the patient, your anchor placement will differ. Remember that. The reduction of the meniscus to the capsule matters. It matters whether you're using vertical, which means through the capsule, or whether it's horizontal through the meniscus only. If the meniscus is well reduced and you're using a capsular suture first, fix it at 14 millimeters in a small patient, 16 to 18 in a large patient. Whereas if it is meniscal, horizontal mattress, you fix it at 16 and 18 or 20. But you have to think about it. You have to determine the depth of the meniscus before you push in your anchor. Okay? Once you put in your anchors, just don't pull the thread. Use your probe. Use the probe to push the meniscus to the periphery and at the same time pull the suture so that it does not rip off. Okay? Thank you.
Thank you, sir. It is an excellent presentation and very useful techniques that is day in and day out practice, where economy matters. So I request Lagappan Nair sir to present his presentation on multi-ligament injuries and autograft options and treatment algorithm. This is one of the complicated topic, and the order of fixation is also most important in this particular topic. Lagappan sir will elaborate on that.
Thank you, sir. Good afternoon to you all. It's in the post-lunch session and all of us are sleeping, including me. And I'll try to wrap up very fast and so that we can go home soon. I specialize in shoulders more, and in my practice it is knees just around 5 to 10% over a period of time. And Sridhar was very particular that I should do this, and I had to do a lot of research and reading because I had to catch up on my old memories before I did this paper. So I work at Manipal Hospitals, Whitefield, Bangalore, and yeah. So the objective of this talk is to discuss about the treatment algorithm of the multi-ligament injuries, like what is the order of fixations, etc., and what are the available graft options we have, and also what is the pros and cons of each graft. Now, I will not be going into details of classification because that itself is a big lecture. So we have the different classifications. To keep it simple, we know it's like a single ligament, 2 ligaments, and if it's a combination of 3, and which of the 3. And sometimes all the 4 ligaments are dislocated, torn, and we have a dislocation. And then additionally, we can have fractures and also have vessel injuries. Now, question is to operate or non-operate. Earlier, you see, maybe like 15 years, 20 years back, and even today, I guess, when it is not affordable at all, we just put a cylinder slab and wait on. But if you look at the data, what is the data actually telling you? Operate is to better. So it is better to operate, and operation surgeries have better results. Now coming to acute settings, acute multi-ligament injury settings. So how to plan it? So now whenever a patient is coming to us, so even in acute setting, you have to wait. If it is a closed injury and it is not associated with a popliteal artery injury, there is no neurovascular injury at all, then it is better to wait for 2 to 3 weeks so that we have some kind of a capsular healing which happens. Then we can do a single stage, because when we come earlier, there should be comparison between 2 stage, and where in the first stage we do the collaterals and then we do the ACL and the PCL. But we can do a single stage itself at the end of 2 to 3 weeks once we have adequate capsular healing happens. But when we have popliteal artery injury or a open knee dislocation, so we take care of that first. And peroneal nerve injury also, we have to take first. So in that kind of scenario, you put an external fixator, and external fixator has to stay in place till we have an adequate healing of the vessel, and then we go in. So so again, the same basic principle to external fixation. If the external fixator is more than 2 weeks, then you take it off and have a window period, that is an X-fix free window period of another 2 weeks, and then we go in for the surgery. Coming to chronic injuries, now question is, what are the basic things we do? Again, coming to the same question, single stage or can we do it at 2 stage? Single stage is supposed to be better according to literature. Then earlier, I think Vikram was mentioning about it. Whenever we have chronic injuries, including ACL or even in case of multi-ligament injuries and PLCs, we have to look at the varus malalignment, correct it, with corrective osteotomy, otherwise we'll have a failure. So now in chronic injuries, that's what we have to look at. If it's a very chronic injury, look at a varus malalignment and have that correction as well. Coming to repair versus reconstruction. So when you look at it, reconstruction is the answer. So repair, definitely, if you look at which ligaments respond to repair better. So MCL can be repaired. Internal bracing is an option for MCL. But overall, when you look at the literature, reconstruction is the answer. Coming to timing of surgery, that is what I was trying to tell earlier, 2 to 3 weeks from the primary injury is a good time to do a single stage correction. Now coming to what is ideal graft. So again, ideal graft, it should have a good integration potential, easy to harvest, and should be cost effective. Coming to graft options, we know all about the graft options. We have the B2B, quadriceps tendon, peroneus longus, and the hams. Coming to each, so to keep it simple, the central grafts, that is the B2Bs and quadriceps, we can use for the ACLs and the PCL. That is the main idea. And if you look at so here, okay, the B2B is an excellent option for ACL as well as ACL specifically. Why? Because we have a bone-to-bone union, and the healing is much faster, and return to sport can be much faster if you have B2B fixation. The main complications are patellar fracture, numbness, patellar tendinitis, graft harvesting issues, because we need an extremely small saw, and osteotomes have to be very, very precise when we do it. Then anterior knee pain and sometimes cosmetic deformity. Coming to hamstrings, so all of us are familiar with the hamstrings. BTB has become very, very rare nowadays, but actually there is a resurgence of the BTB now. People have realized the importance of BTB. There have been modifications to BTB harvest techniques. You don't need a big incision. So, but today, if you look at 80 to 90% of our practice of everybody, we use the hams. So hams can be done in different ways, quadrupled and doubled or tripled. So it is easy to harvest. Donor site morbidity is much lesser and greater cosmosis. So these are the cons, because the size can be unpredictable. So we are not sure, even if sometimes we have a gracilis and a semi-2 together might not be enough. Sometimes in those kind of scenarios, I add an additional tape also if I find the size is smaller. So then soft tissue healing. When you compare to the BTP, definitely the healing is a problem. So now, so that's one. And then numbness, cramping on the hamstring area can be there. So coming to injuries, you can have sartorial saphenous nerve injuries, infrapatellar branch saphenous, or combined injuries can be there. Coming to quadricep tendon is an excellent graft, because one side we get a pretty adequate length of the graft, and we also have a bone plug at the patellar edge. Advantage is it can be even used in the revision scenario. It is much thicker, and so it's an excellent graft. We need not use a complete thickness squat. We can use a partial thickness squat. And when you look at the comparison between, the question is, do you have quad weakness if you take a quad? So if you take a partial thickness, it does not cause weakness. These are, again, advantages of the quad tendon again. Then the peroneus. You just saw Dr. Rajiv Raman mentioning about the peroneus. The peroneus is an excellent graft. It's much longer, and the quality of the collagen is much better, and a very sturdy graft. So definitely it is a great choice, especially in PCLs. It is much easier to harvest. So the only problem is sometimes you have the superficial peroneal nerve going in that area, and there could be a small injury to that. And so we have to be very careful with the skin incision when we put it. And isolating sometimes we get a confusion if it's a peroneus longus or if it is a peroneus brevis. So how we identify that is, because the brevis would be having much more muscular tissue there, and the longus would be having lesser muscle tissue, so it would be able to isolate it. And then so I directly do a suturing of both together, so that we get the action is not affected. So the main problem is we don't know what is going to, so there have been a lot of studies are going on as to what happens to the force couples, and if you actually put a force plate, is the gait going to be normal? Is ankle eversion going to be normal? That's something which we don't know about. Coming to allografts, we have allografts. For example, in Bangalore, we do have allografts. I personally don't use them. I've seen them in my training before, but it has its own set of problems. Like the main concern is disease. So infection is the main problem which we face. Other things are possible transmission of disease, expensive, all that is fine. But the main thing, even today in our scenario, Indian scenario, is we have to be extremely careful because of infection. Coming to a large system, so this is a synthetic ligament system, which is, I don't have any personal experience with this. So coming to the next important thing. So now, the tunnel orientation. So now, the main problem which we face is, if the tunnels are not corrected, you don't have it in the correct direction, you can have a tunnel coalition, you can cause a graft cutoff, etc. So if you look at the femoral lateral side, this is the takeaway. So now, so what you can see is, the ACL tunnel can be affected. So now, to avoid the convergence, the FCL and the PLT tunnels have to be made parallel. And to avoid ACL femoral tunnel, the FCL and the PLT femoral tunnels are aimed 35 degrees anteriorly with a flat 0 degrees in the coronal trajectory. So you have to direct it away. That's a simple answer. Then coming to the medial side, that is the MCL side, distal femur side. Again, superficial MCL, POL, and the double bundle or the PCL are at risk. So you can have your superficial MCL and the POL affecting your PCL tunnels. So how do we avoid this? Aim the superficial MCL tunnel 40 degrees anteriorly in the axial plane and proximally in the coronal plane to avoid basically the PCL. The POL tunnel trajectory should be 20 degrees anterior. So it is 40 degrees superficial MCL and the POL is around 20 degrees. So direct it away, and all of them are directed anteriorly, so that way we can avoid the tunnels. Coming to the tibial side, the POL and the PCL tunnels are at high risk of convergence. So aiming the POL tunnel 15 degrees medial to the Gerdy's tubercle and a tibial tunnel, superficial tunnel 30 degrees distally is better. So now, here I would like to, so we have other techniques. The Dilquist technique, what we do is, we can have, especially on the medial side, we can strip the tendon with an open stripper, maintain the attachment on the medial side, that means near the pes side, and use it for a superficial MCL or a deep MCL reconstruction. We can take it up and bring it down, so we can reconstruct it that way. Plus, advantage is you don't need screws, where even at the tibial side no screws are required. Proximally in the femur side, if you want, you can put screws, or even there we can put a suture anchor. So that way the needles can be taken off. So the main thing is preserving the pes anserinatus attachment, using an open stripper, and using this proximal end in a particular way with suture anchors. We can avoid screws and tunnel collision. This is another thing we can do. Again, too much of theory there. So PEL and the PCL. So this is what we do. 50 millimeter medial. So coming to the most important part, the sequence of fixation. So now I'll try to go slow with this. So now we start with the PCL. So we have drilled the tunnels. So ACL, PCL tunnels, everything is drilled. So you pass the secure the fixation in the PCL tunnel, and then you come to the ACL. Again, you pass the graft. So first you pass the PCL graft and fix it only on the femur side. Then you pass the ACL graft and fix it again on the femur side. Then you come to the PLC and pass the graft. Then the posterior medial side, that is superficial MCL and the POL side. And then you come to the last part of the PLC to the fibular tunnel is passed. Next, the most important would be the first fixation is the PCL. So you passed everything. You first is the PCL passed, ACL passed, PLC passed, PMC passed, PLC passed. Then the fixation is here. See, the first fixation is the PCL fixation, then the ACL fixation, and then the FCL, PLC, and then the PMC. This is the order of fixation. And so the main stay is the PCL first, the ACL, and then you go around. So that is about it. And thank you so much for the opportunity. Special thanks to Sridhar and the entire Andhra team, Visakhapatnam team. Thank you everybody. And I've come here in 2019 for the first time for a similar conference. And the same place, same hotel, same hall. So it's a pretty long way. Really happy to see you all. And I would like to invite you for our Manipal shoulder course. We did our first Manipal shoulder course 1 year back, and it was in last June 5th. And we are having the second Manipal shoulder course on December 2nd. So we have eminent faculty, including Ashish Babulkar sir and Professor U. Yonsik. So Babulkar sir would be laying out the program, and all our dear friends, Sandeep, Sridhar, everybody would be coming. A personal invitation to you all. Kindly let me know if you require any kind of help at all. So I was trying, this time the target was, we wanted to focus on shoulder trauma as well. So we are planning to have a synthesis symposium, like on a AO based workshop, especially for the shoulder. That is the first day we are planning on. And then the next focus was on shoulder replacement. So we've been talking about scopy, but shoulder replacement like hemiarthroplasty, total and the reverse. And we were planning to have live surgeries on these as well. So hope to have a good conference and inviting you all. Thank you so much.
Thank you, Ayyappan. So we are very thankful to especially Dr. Ayyappan Nair and Dr. Mukesh Ladda. So Dr. Ayyappan Nair was there yesterday in Ortho and Dr. David Rajan sir meeting. We called few of our faculty members, Dr. Sundar Rajan sir, Dr. Arumugam sir and all. They were busy in different meetings because we asked them in a very short notice. So Dr. Ayyappan was there. He organized a very good meeting last Saturday, Sunday, Bangalore Sports Injury Conclave. He was organizing secretary. Fantastic meeting there. After that, yesterday he was in Coimbatore. Just because of our invitation, Ayyappan was there in Bangalore airport whole night and traveled back, Coimbatore to Bangalore, Bangalore to Vizag. And same with Dr. Mukesh Ladda also. He was yesterday in Pune, robotic knee replacement live surgery. So he was there whole night. He traveled from Pune to Bangalore and Bangalore to Vizag. So that is the commitment they have towards us. So we are very thankful, Ayyappan, and Dr. Mukesh Ladda also. So the third live surgery is ready. Dr. Chirag Tanse is doing that. He has taken a BBT graft and he is ready to show us. Live.
Dr. Sridhar, hi. Dr. Sridhar.
Chirag, hi. We can see you, we can hear you very well.
Can
Carry
you
on.
see the
Thank
monitor?
you.
That's very important.
Yeah.
Yeah, once again, a very good afternoon to all the delegates, and it's my pleasure to be here. This is my second live surgery in Visakhapatnam. Probably about 4 years back, I did one in Omni Hospital. It's a very good meeting organized there as well. And I'm glad that I'm back here, but I think Sridhar is not very fond of me. What I see here when I put my scope is that this is a chronic and neglected bucket handle tear, which is flipped. Now this gentleman, let me quickly give you a brief about the case. If I can just show the camera here. This is a 21-year-old gentleman. He plays recreational football sport, and he had a twisting injury about 6 to 7 months back, following which he had a couple of buckling episodes as well. As we see here in the MRI, if I could see, a complete disruption of his ACL and a well-seen double PCL sign here. Now if I would look at the coronal sections, I do not see anything of my meniscus in 1, 2, 3 films. That means at least his body and the posterior horn of the meniscus is flipped inside, and I can see this flipped fragment here lying in the intercondylar notch. Strangely, he didn't have any sort of a fixed flexion deformity, and since he's a young active guy, and these people with the bucket handle meniscus tear respond well to meniscus repair when it's associated with ACL surgery. So what I've done is I have harvested my a BTB tendon graft. Can I just go to the review of, can we just show the recording of the BTB harvest quickly for 2 minutes for the benefits of the delegate? Audiovisual, is it possible? If I can quickly show
The PTB graft.
Where can I see?
Video, is it possible? Audio visual?
Yeah, is it playing? Yeah, this is my incision. Usually I take the incision just medial to the parapatellar line, to the patellar tendon. If you see here, I do not start it from the tip pole of the patella, but I start it just above the joint line, so that I have more of my incision below. That can facilitate a single incision, even your tibial tunneling. If you see that, that's about 6 to 7 centimeters of incision length. Can we fast forward that? Let's fast forward it, please. The skin and the subcutaneous tissue taken in one nick. I would fast forward it, please. Fast forward, fast forward, fast forward. Fast forward. Then we would separate the peritoneum, identify 1 centimeter of the tendon strip, of the strip of the BTB tendon, and then using this oscillating saw, I would take a rectangular wedge of my tibial tubercle. It's very important. If you see here, I'm taking a little bit of a longish kind of a graft in my tibial side. I will tell you the reason why. Let's forward it, please. I'm taking this like a wedge base, a trapezoid wedge with a broad base and a narrow tip. I've made my markings here. I've used a 2 mm K-wire and made markings there for the pilot hole of the sutures to be passed. I would then, come on, forward it, please. I would then dissect out the tendon from the underlying fat tissue, making sure that the underlying fat tissue is not disturbed. This is done in 90 degrees of knee flexion. I would then bring my knee to full extension, and my fellows would be retracting the skin there. It's a mobile window which I have created. So in a similar fashion of about 2 centimeters of patella plug is what I would harvest. Forward, 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 please. Yeah. I would then use an osteotome and harvest the tendon graft in that fashion. Now forward it, please. Forward, forward. As my fellows are closing the wound there, it's a running suture which we use with 1 number Vicryl. I'm here preparing the graft. If you can see this. Go back, please. Go back, go back, go back. Yeah, that's fine. See, as Dr. Mukesh was telling me that time, there's no, the BTB doesn't look very glistening. That's because we failed to clear out that fat pad. So here I'm using my wet gauze, clearing the fat pad tissues, and you see here for a 1.1 centimeter graft, my plug is well passing. The patella side is passing through the 9.5 mm thing, and the tibial one is passing through 10 mm tunnel. I would then make 2 holes here for the plug. One I would load with the 5 mm ethibond, and the second one I would load it with the 2 mm ethibond, so that I have 2 pulling threads which are loaded to my patellar tendon graft on either sides. Forward it, please. Yeah, yeah, that's fine, that's fine. Yeah, similarly, I would make another 2 holes on the either side. Forward it, please. Load it again with my needles, which are already straightened. Yeah, that's good, that's good. Go back, go back. Yeah, good. Play, please. Forward, please. Forward, forward, forward. Forward. Yeah, yeah. As you see here, now we will size the graft. I have not manipulated the graft much. You see here, the distal plug is easily going through the 10 mm, and the proximal plug is going well through the 9.5 mm tunneler. Now once I've done that, we would then measure the graft. You see this is about 1.1 centimeters in breadth of the patellar tendon, and my bone plugs are also well in place. Now you see that in the distal side, I have a longish plug. Here I have the plug of about 2 centimeters. So this will be my proximal plug, which will go into my femoral socket. That's exactly 2 centimeters. So I will make a marking at 2 centimeters, and I'll make one more marking at about 1 centimeter below that. This is because in case if I feel my length of my graft is long, I would use it, I would push it inside still more. Now here again, look at the length of this. This is about 4 centimeters of the bone plug what I've got. That is including the tongue. So the advantage of the tongue is, in case if I want to shorten out the graft, I still have the tongue which can hold on to my aperture fixation. This tongue gives me a leverage of shortening the graft on the distal side in case if I feel that the graft is too long. I have about 90 millimeters of graft here. So ideally I need 20 plus 25 plus 35. That is effectively about 70 to 80 mm, but I have about 90 mm of graft. Let me see how I can use that. Here we are, about 35 mm is what I have finally. That should suffice. Now we measure it again. This is about 90 mm of the graft length. Okay. Now I would then wrap my graft with a vancomycin soaked saline gauze, and then place it in the kidney tray so that the graft is undisturbed. It's very important that we protect the graft, because in this confusion it should not be that we lose out the graft and find it in the flow. Now here, coming back to my meniscus again, let me see what I can do about this. Let me see if it's a reducible meniscus or an irreducible meniscus. First, what I will do, I will give a valgus stress force and try to open the joint. Give me a probe, please. I would use a smooth instrument like a probe or a trocar to reduce it. This is my first attempt of reduction. It's a tight meniscus. I am able to reduce it, but it is not holding in place. I do not want to lacerate my meniscus. It is a tough reduction. So next what I do, I will rebucket it. Again, I will take a 16 gauge needle. Now I will do my pie crusting to open up the medial joint space. There are 3 spots, either in the femoral side, joint line, or the distal spot at the POL, and the distal spot is my favorite spot. Look at that. I'm just giving a valgus force and doing my pie crusting, and I have a good opening of the medial joint line. that should help me. That should help me get a good access and a good vision for my meniscus repair. The added advantages of a pie crusting is my instrument passages becomes easy. I do not scuff the cartilage when I'm doing
Outside picture, zoom in, please. Outside picture, zoom in, please.
Yeah. That's a joint line which is opened well. Now, before I reduce my meniscus, what I will do is I will prepare the bed for my meniscus tissue. I am here going inside. This is an old bucket handle tear. So I will have to freshen up the biology. There is no much of a bleeding tissue here. So I will gently use my shaver in a reverse fashion mode. Ideally, I should have a 3 mm, 3.5 mm blade, but I am using a 4 mm since the 3.5 mm is not available with me currently. I am using this shaver blade with great care so that I do not unduly rupture the capsule, but at the same time, I freshen up these edges so that I can get some good approximation bleeding edges for my meniscus repair. I hope the picture is clear.
Yeah, yes, perfect.
And in a similar fashion, I'm also going to freshen up the margins of the other side, the contralateral side of my meniscus, which is going to be repaired. Now, as you see here, I am just freshening out gently with great care so that I do not disturb the tissues there. Next, what I will do, I will take the diamond rasp. These are very, very handy instruments, like how we have a rasp in a Bankart's lesion. We have a similar kind of a rasp, but in a conical fashion. I would introduce that, rasp my meniscus so that the fibrous tissues are all void, and I can get good fresh bleeding tissues for approximation. I would also scratch the kind of a capsule on the top and bottom of the meniscus to generate some amount of healing or some amount of bleeding there. As you see here, the vascularity is quite poor because it's a chronic tear, but until unless it's reducible, I would make an attempt to repair it. He is only 21, so I do not want to resect his meniscus. That would be a catastrophe. I'm not going to do that. I'm going to try and save it if it's possible. Again, I go with my shaver here. I freshen out the edges. And now, since I have a good opening, I would go ahead again, give my suture retriever.
Chirag, are you using pump?
No, no pump. I never use pump even in my shoulders.
Till what
Here's
point?
my suture retriever coming in there. It makes my life easier for reduction. I would gently grasp the meniscus and put it back into the anatomy. Once I put it back, I now need to make sure that it stays there before I kind of start suturing. So I will first put a reduction suture, which is through an all-inside meniscus repair technique. Knife, please. Can somebody come and pull my mask up? I will introduce my all-inside meniscus repair cannula here. I will put a reduction suture first, and that would be my first, hold this, first suture. So what I will do, this is a fast fix curved device, all-inside meniscus repair by Smith & Nephew. My first reduction suture will go to the capsule meniscal junction on top, as I've done that. Next, I would take a good chunk of bite through the meniscal tissue, making sure I'm not in the wrong anatomy. I am reducing it properly. I would then push it back, see if it is an anatomical reduction. Once I'm done that, I'll go push it in to a depth of 2 centimeters, making sure that it is holding onto the capsule. I will then gently pull this. Pro, please. I will titrate my tension using a probe. I will always use a probe and then tension, use a probe, tension, so that I'm not over-tensioning the repair here. I've done that. Next, I'll use the meniscus cutter and probably just give me a second to load this. Sometimes these threads, yeah. This is a very nice cutter. I like the Smith & Nephew knot cutter. Very, very nice and very delicate. Now we have the curved ones also available in the market. I have my reduction sutures. Now I need to plan my repair. How am I going to repair? It's a bucket handle tear. It is extending from the anterior horn to the body from down. Pull it up from down. Yeah. So can I have a probe, please? So what I will do, I will have to use all the three modalities probably. It is extending from the body to the posterior horn. As we all know, the three zones. In the body, I may use inside-out suturing device, and in the posterior horn, all inside. And if need may be, in the anterior horn, I will put outside-in meniscus repair sutures as well. Now you see this is a 4 millimeter tip of my probe. Since I've done my pike resting, the opening is as much as 6 to 7 millimeters, which gives me a free passage of my instruments and makes my life much more easy. Now I will take a safety portal. Since I'm planning to do an inside out, I will take my posterior medial safety portal. I will identify the joint line. Joint line is already identified. Dummy marker, please. Identify the posterior margin of my tibia. Once I've done that, this is the joint line. I will go with a curvilinear incision in this portion. Knife, please. Not okay. Here we are. Can I have a thumb and a scissor? Am I visible to the audience?
Yes.
Retract, please. Skin and subcutaneous tissue, making sure I am not damaging any sort of neurovascular structures here. I will gently dissect out the second layer.
Yeah.
That's the
Can you
subcutaneous
change
fat.
the camera position? We can't see it. It's from behind.
Yes.
Gauze,
Thank
please.
you.
Gauze, please.
That's better. That's better.
Gauze, please. As I'm opening up here, you see this. A good window created here, but I should make sure that I go the entire depth up to the capsule so that my knots cinch up to the capsule. And here we are. I have a good team here supporting me. I have my two fellows, Dr. Akshay and Dr. Sukrut, and I have the scrub nurse, Jyoti, who has been very helpful till now, and I have Mohan from Smith & Nephew, and of course, the anesthesia team is wonderful. The ground staff are fantastic. They help me position and start off my surgery in time. So as I've exposed, now I would use this window to insert my spoon. This is a very handy device, a simple spoon which I bend to 90 degrees, and this can be used to protect your neurovascular structures. At the same time, what happens when you do your inside-out repair, the inside-out needles can deflect out through this, and your retrieving of the needles becomes much more simpler and easier. I'm flush.
Hello. We lost the image.
We lost the image.
Come on, show me the sharpshooter. Sharpshooter. What the fuck are you guys doing?
Yeah, the image is back on.
Yeah?
Yeah.
Are
can
we?
see- Yes, yes. Yeah, we're back on.
Okay. So now I'll proceed with my inside out repair. For this, what I will do, I will switch my portal. I will use the anteromedial portal as the viewing portal. Mosquitoes? Yeah. Guys, no talking. Somebody white balance? Okay, am I back with my vision?
Yes.
So here, this is the
we don't
anterolateral
have
portal.
the inside. Yeah, we don't have the inside image.
Can I get the inside image, please?
Yeah, better. Yeah.
Okay, so I will switch my viewing portal from the anterolateral portal to the anteromedial portal. I am here in about 60 degrees of knee flexion. I am using an inside-out meniscus repair device. I am taking one bite here. Look at that, I'm not doing any sort of circus here, one person holding the leg, giving valgus force. My positioning is such that my medial joint space is opening well and I don't need an assistant to hold the leg and to probably help me out with the, as you see here, the needle is out. The first bite is taken through the capsulomeniscal junction. Once I've done that, the second needle gets loaded. Yeah, load. Okay. And I will then punch in my second needle through the meniscus tissue. Pull. Yeah. That's my first bite. Load one more. That's my first inside out suture. I have taken two sutures so far. One is the all inside, that's a reduction suture. Now the next one was my inside out. I will take another inside out suture here. In a similar fashion, I will introduce from the anterolateral portal and my bite through the meniscocapsular junction. This is going to be a little more posterior. The first bite is on. Similarly, load the second needle, please. I'm here. I would then go. Yeah. Excellent. So this looks like a double bucket here. Can you see that? The delegates, can you appreciate? It's like a double bucket handle tear in the posterior portion.
Yes.
But my bites are quite broad so that I have a good approximation of both the bucket handle fragments. Now next, one more please. Similarly, the third one, I will introduce the needle valgus, yeah, here. I've taken the bite through the capsule. There are double barrel and single barrel inside out devices which are being used. I can use either one of them based on the comfort of the surgeon. The Smith & Nephew double barrel is very, very handy. I often use that, which is a meniscal inside out repair set. Here. Yeah, full. Good bite. So I have managed to take my inside out sutures with through the body and the posterior horn as well. And now what I'll do is one by one I'll start tying it. And then I will proceed with the rest of the meniscus repair. So first I would retrieve these sutures. My assistants have tagged them. Otherwise, if you have so many sutures, it's very difficult to retrieve all of them. You may get confused. So it's very important that you tag them with your mosquitoes. I will start suturing them from posterior to anterior. Can I have the knee in, yeah, extension, knee in extension. I will take, if you see this, I will take a simple sliding knot. Can I have the outside picture, please? Simple sliding knot. I will use my shoulder knot here.
The camera is behind your shoulder.
Yeah. Come on. Can we have the picture, please? The shoulder instruments are sometimes very handy. This is a knot pusher which I'm using to push the knot flush to the capsule. Extension, please. I will then extend the knee and tie my first knot. I'll then use a half hitching knots in regular fashion. Once I've done that, I would cut this. One down. Now the next. Similar fashion, a sliding knot. 1, 2, 3. I have the knot here. And this end goes inside the loop. And then slide, slide, slide. Excellent. Come on. Can I have the knot pusher? It's very important that these knots sit flush to the capsule and they do not entangle any soft tissues, or else the patient, one, they would be left with some kind of a medial side pain. If you grab the subcutaneous nerves, you can have burning sensation and pain, which may be troublesome at times. So it's very important you go up to the capsule, visualize the capsule, and push your knot right down there. And this also gives you adequate tension. Cutter, please. Probe, please. I'd come for it later. All this retract, retract. Can I just, yeah, let me just find that. Let me just find the suture material. Relax. Dr. Sukrut. Yeah, this is my third, relax. This is my third knot. Is the outside picture clear? Is the camera in place?
Yes, we can see you.
Yeah, so here I am, my third knot, which is little anterior. 1, 2, 3. Once I've done with that, I will then load it inside. Flush, use the knot pusher. It is just the same steps which we need to follow. One can also tie these suture knots before going in for the second suture. Some people do that as well. I find this easier because it saves my time. Since I already have my reduction suture there, my meniscus is held well in place. So I'm happy doing this after I've passed all my inside out sutures. I'm done with that. Now let me see how it looks inside. Introducing my scope through the standard anterolateral portal. And here you are.
Need inside picture, please.
Yeah, inside picture, please. Can I have the inside picture, please? Am I visible now?
Yeah.
Okay, guys, here you are. The meniscus reduced, repaired, and whatever I do from here is a plus plus for the patient. Now, can I have all inside? Are you happy? Who is moderating the session, please?
Dr. Praveen here.
Yeah, Dr. Praveen, are you happy with the repair?
Yeah. That's good, pretty good.
Well spaced?
Yes.
With good tissues here?
Yeah, the
Can I have?
positive one you're going to put the all inside?
I'm going to put an all inside here, near the root.
Yeah.
Hold. I'm going to use a fast fix curved here so that I can approximate that portion of the meniscus as well.
Yes.
I think we can, yeah, fantastic. This is a fast fix curve. The advantage of this fast fix curve is that it's got a 15 degrees curved so that I can introduce, as the slotted cannula here, I will bend my needle downwards and slide it like a track so that there's a smooth passage. Can you see that? It was so smooth. There's no tissue entanglement. And once I've done that, this is like a kind of a capsulomeniscal bite I will take, needle facing downwards. I'll take the bite through the meniscus and the capsule tissue. Once I've done that, I would come back again. Now I will take the full thickness of my meniscus down out of the capsule again and take a bite. Here we are.
Yeah.
Can you just pull up my mask? From down, pull it from down. Yeah, thank you. So, I will then tension my repair. Again, I will introduce my probe. See, put it in between here before I hold this. Before I pull my thread so that I do not over tension. I'm done that. Now I'll reduce the fragment and then give tension. You can see that?
Yes.
So that I do not have any pull out. Can I have one more fast fix curve? Slotted cannula.
Do you always repair meniscus and go for ACL reconstruction?
What is it?
Do you always completely repair the meniscus and then go for ACL?
Yeah, it's better, isn't it?
Yes.
So because once you have your ACL tunnels, then your fluid is flowing around here and there, and it also gives me a test to see how good is my meniscus repair. I'm going to flex my knee, I'm going to manipulate the knee a little bit. At the end of it, if my meniscus is steady, that means my meniscus repair is stable.
Yeah.
Here we are, I'm going to take another bite. This time what I'm going to do, I'm going to go in the undersurface, take a bite through the capsule, punch, and then here.
The peak implant has come out.
Yeah, that the previous thread was the capsule bite just came out, I think so. So I'm going to remove that peak material from there. Can I have the, yeah, here we are. Can I have a small punch, please? I'm going to get rid of that peak material. That's of no use for me. That is from the previous repair device, which had a pull through from the capsule. I'm just going to dismantle that. Done. So here we are, my meniscus repair, 1, 2, 3, 4, 5 sutures. Now as I proceed anteriorly, what I will do, I will put my knee in 90 degrees of knee flexion, external rotate the tibia to expose the anterior portion. Now, can I have the table down, please? Can I have the table a little down, please? Yeah, fantastic. Hold this. I will take my inside out, outside in meniscus repair device. Load this, Dr. Sukrut. So this is a very, very handy set from Smith & Nephew. You have this kind of a suture retrieving kind of a Netlon wire. So I will first pass my inside out needle. If I see this light here is going to be my guide to where I'm going to pass my suture, and I'm just going to feel that part of it, and my first needle bite will be somewhere over just below the capsule. And my next needle is loaded already with a ethibond number 2, and it's going to come through the meniscus tissue. It sometimes does happen that it's a little difficult to get the right spot, so we need to have a little bit of a judgment here, as into where you want to pierce. You need to have a good bite. Here you are. I am trying to get a good bite through the, can I have a suture retriever? Or else I can have what you call grasper. Grasper is better if I can have that. It makes my life easier. Can I have the grasper, please? I have passed one bite through the capsule meniscal junction, and I passed the thread down there in the meniscus tissue, and I'm trying to retrieve the ethibond in this fashion. I have retrieved it through the loop, so this saves one step of mine. That's the beauty of this repair device. This is a beautiful repair device from Smith & Nephew. Always have it in your armamentarium. Now, as I'm pulling out this device out, you see here, I have one bite through the capsule meniscal junction and one bite through the tissue. Here I am happy with this. In case if I want, I can put in a couple of sutures here just to get the tissues back in place and to give more tension. Can I have one more meniscus repair device? I'll just shift my viewing portal, cannula. Hold this. Come on, fast fix. anything. Give. So I'm going to give a little bit of attention here, push this through the cannula, get it flush to the capsule. Sometimes it does happen if you are taking all the bites in the upper portion, you can have the meniscus everted, but I don't see there because I've taken 3/4 of the meniscus bite. If you take less than half, it can evert or invert. So I'm taking most of the tissues along. When I take my bite, here I am, the next bite, and my bite will go down here, taking about 3/4 of the tissue. And I would then go ahead and tension my repair in a similar way. Can I have the knot pusher, please? I am not hearing from the moderators. Am I on track or am I off track?
Yeah. Chirag, the audience are very fortunate to see the 3 types of suture knots today.
Yeah, even I am lucky to demonstrate that, and Dr. Sridhar has been kind to me to let me do this surgery.
Yes, excellently reduced and fixed it.
Once I have this, do you think I need to put one more suture in between? Dr. Sridhar, you want him to walk full weight bearing tomorrow? Meniscal. Can I have the...
For the audience purpose, Chirag, what is the size of the tear?
Size
of the tear will have any role in the size of the tear in the prognosis of this repair?
I don't get it. Size of the?
Size of the tear.
Size of the tear?
Yes.
Tear, can I have the probe? Subjectively, I can measure the tear. So if I could see the tear here, my probe is 4 millimeters. So I have 4, about 2 centimeters, 2 plus 4, 25, about 25 millimeters.
Yes.
Slotted cannula. Here I am. Yeah. Can I have one? What is it? Okay, take it. We can take it. I'm just putting one meniscus all inside suture just to augment my repair. Here I am. I will just take it in between the 2 sutures of mine. Yeah. I'm happy now. There's good tension, good approximation, good biology.
Yes.
I think, can I have a long needle? Long needle, please. I will further go on to enhance my biology with some blood clots and so on and so forth. Before that, what I would do, needle, please. Needle. I would just do some trephination from outside in to stimulate the biology. Can you see that? I'm just enhancing the biology here so that the vascular channels are open and there is some amount of bleeding. So this anyways, I'm going to tie this later on when I finish my surgery. I'll quickly, do I have time or is Dr. Mukesh ready with this case?
Just one question, Chirag. Because this is a chronic tear, there will be healing problems. So do you augment this with any PRP?
PRP no, because since it's along with it's associated with an ACL tear and I'm going to do an ACL reconstruction, there's going to be an auto enhancement of biology since I'm drilling my femoral tunnels and my tibial tunnels. So there is osteoprogenitor cells which are going to come in. Can I have the scale, Smith and scale, measuring scale? So let me see how I'll augment my repair later. So here I am just going to measure my footprint. The footprint seems to be pretty good in this gentleman. I'm changing my viewing portal into the medial portal and trying to visualize the kind of a footprint what he has. It's quite a good big footprint of about 12 millimeters in the about 12 millimeters in the femoral side, and my tibial side footprint is also around 18 millimeters. It's a kind of an oval footprint what he has on the tibial side. Now, where do I place my tunnel? I usually use a simple condyle pick technique. The tip of the condyle pick is 4 millimeters. I have removed the capsular attachment in the posterior part of the femoral condyle. I'll use this as my measuring gauge. This is my residence ridge, so I need to be effectively behind that. And if I see here, 4 millimeters, that is about, if I am having a 8 millimeters tunnel, I would just be 2 millimeters ahead of that. So I have about 9.5 mm to go at, and I'll be just behind my residence ridge, in between the bifurcate ridge. And since this is my footprint, I would be just erring towards the AM bundle rather than PL bundle. I will make my pilot hole here. Flex. Yeah, beat pin please. Why have we kept it so long, sister? Shorten this please. Condyle pick. Any questions from the audience I can take in between? So I'm trying to figure out which is my best possible insertion site. Yeah, that's good. Can I have the pilot hole? My knee in about 90 degrees of knee flexion. I do not hyperflex, it's not required. I will go, there's auto measurement of this in the beat pin as well, so but I will do it with the endo button reamer. Now once I've, yeah.
So for the sake of the audience, Dr. Chirag, when residence ridge is not found, how do you...
yeah, that's exactly why I use this ruler method. So there are few techniques. Either you could use the femoral guide, which I do not frequently use. That is the best possible technique to put your femoral tunnel as you start off.
Yes.
Freehand techniques, you can use your footprint as your guide. If the footprint is also not there, you can use the residence ridge and the bifurcate ridge, go in between them where it intersects. If that is also not available, then that's a ruler technique which I just showed now. Can I have some pressure in the water? Here we are. That's 20. Yeah, after 20, I'm not really bothered. I may probably have a look till 30 because my bone plug is only 20. I may need that leverage of 10 millimeters more. So once I've passed that 30 mark, I can blindly go and then ream it through and through the cortex. That's my 4 mm reamer. I would then take 8 millimeters reamer, dilate this sequentially. A flower tip Smith & Nephew reamer of 8 millimeters. Any questions regarding this, regarding the tunnel placement? We will view from the anteromedial portal. Since I take a medial anterolateral portal, my visualization is quite good. Can you see this? I am viewing through my anterolateral portal, but I am getting a good view, good end-on view of this, this lateral femoral condyle. Next, I'm going to go with the 8 millimeters reamer. I'm going to go there. 1, 10, 20. Pressure, please. 20, I'm going here 20, 25, here we are 25, 25, 30. So that would be my stop at 30. Next, give me 9.5 mm. Now clear out all this debris. You see there are a lot of debris which comes in because you're using a thick reamer. That's 9.5? Okay. So I'm going to take my 9.5 reamer and then here I am. $20, $25, $30. Yeah, that was 30 and that's what I need. So can I have the passing thread, please? Sometimes these shavers gets clogged like how it is now, so it's very important that you see periodically clean the tip so that the soft tissues are not entangled. If not, the suction doesn't work. Once I'm done with that, I'm going to take the tibial jig. Can I have the jig, please? And place it for about 55. Because I have a good long graft, I wouldn't shy away from taking a 55. Hold this, please. I always use a tip aimer device. Elbow aimer would also work well, but since I want to be precise, I will take a tip aimer aiming device. Identify. So what I will do, first I will mark where I need to exit out. I'm using my radio frequency probe.
Yeah.
This is my medial tibial spine. I would stay flush to the medial tibial spine. We all know that you can have three landmarks here. One is the PCL, about 7 millimeters ahead of PCL, just posterior and medial to the anterior horn of the lateral meniscus. That's somewhere here, or else in continuity with the medial tibial spine, I would just be here, flush, and I would prefer my guide pin exiting out through this point.
Dr. Chirag, for the audience sake, why do you put the angle of 55? Why can't it be 45?
Why will I take 55?
Yes.
See, now if I have a short graft, I will take 45.
Yes.
If I have an adequately moderate graft, I will take 50. Since I have a 90 millimeters of graft, I will take 55 so that more of my bone plug is intratunnel.
Yes.
Does that justify?
Perfect.
Since I've taken my incision lower, I can accommodate my jig well here.
You're not getting it.
One thing over here with the BTB, what we need to make sure, can I have a reamer please? Or else can I have the scale? Can I have the outside picture? So this is my margin of my bone plug which I've harvested. So it should not be that you have to be very close to this. So if I can take a reamer, 8 mm reamer, or 9 mm reamer, 10 mm, yeah. So this is my reamer, and I would at least want to have 2 millimeters scale. 2 millimeters of bone bridge between my tunnel and my graft harvest site. Here you see I have about 4 millimeters of bridge of bone between the margin of my bone harvest site, plug harvest site, and my probably tibial tunnel. So I'm good with this. Also one more thing what we need to know, in case if our skin incision distally is not adequate, we end up probably lifting our jig up to accommodate that, and that will shorten the tunnel. Here I'm good. This is my joint line, my tunnel length will be adequate. I think I will get about 40 mm of tunnel here, which will probably be just right for my tibial plug. Go.
Dr. Chirag?
Yeah?
Sorry to interrupt you.
Yeah.
Dr. Mukesh is ready with his surgery.
Yeah.
We are swiping to the other theatre. Once you finish the tunnels, we'll come back again.
Yes, please.
Thank you, Chirag.
Thanks. Yeah, go. Yeah, Mallet. Yeah. 10 mm, remove. 10 mm, remove. Keep 725 screw out. 725 screw out. Call somebody. Call somebody. What is this, right? Grabber. Grabber, grabber. Knife, knife, knife. Load that, load the things. Keep the screw, pin. Keep everything ready. Come on. Give me the graft. Yeah. Give me the thing, no? Give me the graft. Graft. Tunnel notcher. Look, come, hold this, go. Come on. Dr. Gandhi? Gandhi. Gandhi, I just need 1 minute to hold it. You knife, knife, knife. And probe. Probe. Give me a probe. Probe. Dr. Gandhi? Just call Gandhi, no? Hold this. Yeah, 1 minute, I'll just show them the insertion. Yeah, 1 minute.
Hold it, hold it. Hold this one also, don't leave.
Wait.
Hold this way. Okay?
Yeah, am I audible?
Yes, please.
Yeah, so this is called a tunnel notcher. I mean, if you see this is a very, very helpful device. Now,
just hold.
now I pass my graft.
Don't do
Before
anything.
I
You
pass
just
my
hold.
graft into the tunnel,
Don't do. Let me.
I would notch this tunnel here.
Okay,
Notch.
Yeah, yes.
Wanted to show. Yes. Notch it. Yeah, notch. Because these are tough bones and putting a bio screw sometimes becomes a challenge. If it is a metal screw, it is still better, but nowadays patients demand bio screw, so I would notch it, and
So
then
whenever they want me, I'm ready now.
I would pass my
I'm ready
graft.
to show them the graft.
Here we go, the graft inside, about 20 millimeters, yeah, just right here. This is my marking of my graft. Here is my ACL graft. Now what I will do, there's a very important step. I wouldn't want to lacerate my graft while I put my screw, so I will insert my Netlon wire, and this is a very, very helpful. If you see this, can you see this outside picture? A very nice cannula which I have, which is preloaded with the screw. Can you see this? Moderators?
Yeah, yes.
Yeah, so I will introduce this along with the screw
Yes.
into the desired spot here,
Yeah.
so that when I insert my screw, I do not lacerate my graft. Here it goes, my cannula flush here, protecting my graft. And my screw here would go inside without cutting the graft tissues. I am using a 725 Smith & Nephew screw. Can you see that squeak sound? Can you hear that squeak sound?
Yes.
Sometimes it does happen that if you're not protecting your graft, the graft can get lacerated. But here you are. This protector doesn't prevent you from lacerating the graft. Hold this, please. I may go 2 threads further, 1, 2, 3, 4. That's my screw, which is flush. Once I remove that, you see that the graft is not lacerated a bit.
Yes.
Pull out the Netlon wire, and here you are.
Yeah, perfect.
Flush to the bone plug inside, that's my 20 and 30 mark, and this is your ACL graft, which is flat and anatomical. I would take this opportunity to thank the Vizag Arthroscopy Association and Dr. Sridhar once again for putting up this show. Thank you.
Thank you, Chirag.
Thank you very much. That was a wonderful presentation.
Off.
Wonderful graft position.
Remove the mic. Loop it around. Loop, no? Loop it around, sister. So what's the length we
Dr.
have
Mukesh,
here?
you're live on.
Yes. Yeah.
Can you hear us?
Yeah, I can hear you now. Can you hear me, guys?
Yeah, we can hear you clearly.
So I've taken semity and gracialis both. This guy on evaluation under anesthesia shows he's having grade 2+ pivot. He had a history of fall and complaint of instability. So on MRI, I think it's not here, but I have seen his MRI. I am suspecting query a ramp lesion here as per MRI and as per the pivot shift grading. I usually take semity and gracialis both because I think most of the times with semity you don't get enough 8 minimum diameter. So this semity and gracialis both have been quadrupled. So this is an 8-fold graft with 8 on femur and 9 on tibia. Okay, can you hear me?
Yes.
Yes.
So can you see here? Now I'll just show you the pivot shift test here. Is my knee visible?
Okay.
Gentlemen, can you see the knee?
Yes, we can see the knee, sir.
So if you see the pivot shift here, can you make it out?
Yeah.
So whenever under anesthesia I get this test positive, I harvest the graft first. I don't bother to go for diagnostic scope first because pivot shift is pathognomic for ACL tear. You won't have pivot shift if it's a locked medial meniscus. Okay? So the first portal is in line with the lower pole of the patella and just lateral to the patella border. So it goes in, you get a giveaway feeling, you extend the knee and go in again. It's ulta. I want it this way. Okay, where's the scope? So you saw the excellent demonstration by Chirag, the way he reduced the meniscus and repaired it very well. So let's enter the joint. Is it locked? How to lock it? I don't know. It's locked? Lock. So the water is not going in. There's some scratch mark. So can you see the inside image?
No.
Can someone focus there?
Yes.
Is it visible inside image now?
Yes.
So you can see I am in the suprapatellar pouch, a small medial plica is there. You just rotate it and you see your patella there. You can see the whole, examine the whole patella. Sometimes in chronic PCL, you need to see the secondary signs of
patella cartilage. Go to the medial gutter, looks nothing. Come in the suprapatellar pouch. Go in the lateral gutter, looks nothing except bit of synovitis. That's your popliteal hiatus and nothing. Always make this as your routine round. Then you just flex the knee and see for the cartilage on the medial femoral condyle. Flex it completely, looks to be fine. Then you see the intercondylar notch over there. Then you see the lateral cartilage of the lateral femoral condyle. And you come in then. And there you see a little bit come out, don't go much in. I usually make single little medial portal. I don't make two portals. Guys, you are coming in my way. Please, have you finished? Have you done? Okay then, let me do. So what I do is, I take a needle here on the lower pole of patella and just go below it, and you can see my needle coming in very well. You can see the trajectory should be towards the posteriorly. This trajectory I want to drill the tunnel. Okay?
Yeah. Okay.
Oh, just lights on, please. Someone be here, please. Right. So the medial lower portal should always be a horizontal portal. Don't make it vertical, otherwise invariably you will iatrogenically cut the you will have radial tear in the anterior horn of the medial meniscus. So always low anteromedial horizontal portal. Where is the foot switch now? Or it's in the hand. Suction on, please. There is no speed here. What's the speed of the shaver? Come on, I will not keep doing the whole day. Why should I stop? You should have done that. Keep it loose, guys. Give me some space to work, please. Okay. Is suction mode on? Yeah. So now you can clearly see a high anterolateral portal gives you a bird's eye view of the tibial footprint. So see that your portal should be high. You may see there is partial attachment, might be a bit of fibrosis, but you see this ACL doesn't have any life, though you may see it partly intact, but it don't have any life. So I'll just excise that remnant stump of the ACL so that you have enough space to see the footprint, because the most common problem for ACL failure is tunnel malposition. Some doctors may say you can preserve the ligamentum flavum because that adds to biology in healing of the graft. But we all know the graft heals at the mouth of the tunnel, not in the tunnel. You may sometimes be able to preserve this remnant on the tibia for so-called proprioception. But that's a theory, not proven yet. The shaver blade is too old, it seems. It's not cutting anything. But why it's not cutting anything? So try to preserve some of the fibers on the femoral footprint so that you can be able to go exactly in the center of the footprint. There are various ways to identify and place the tunnel. Yeah? Anyone asking something? So let's do the diagnostic round. Don't internal rotate. Please, one sec. Yeah, this way. So I always do a Gilchrist view. Go in the posteromedial. For that, you keep the knee in 20-30 degree flexion. Give a valgus force. I have not done any kind of pie crusting here, but still there is a mild grade 1 laxity. May I have probe, please? Why we have put this? Why we want 2 inlets? Can't we have 1 only? Yeah, that's better. No, I don't want anything here. Can we increase the height of the inflow? Please let him do. He's standing ideally. Just hold this. Hold this. Why it is leaking? Yeah, come on. I hate this kind of instruments. The clarity goes, okay? Now it's there. Hold this. Can you reduce the height of the table a bit? So now you just see the meniscocapsular junction here.
Yes.
So see how beautiful it is. There is no tear in the medial meniscus from the femoral side. You elevate the meniscus, see whether it is torn there. Hook the meniscus, try to pull it. If there is subtle movements in the medial meniscus, I'll suspect some kind of tear. But here I don't find any movements in the meniscocapsular junction, so I don't suspect any tear because this is the dark area of the knee, the posterior medial corner. So always read your MRI carefully and then assess the movements on palpation. Give me needle, 18 number needle please. And this is, you can see there is no ramp and nothing. So make it a point that you always do a Gilchrist view. You palpate with the help of 18 number needle, see whether there is any ramp or not. So there is no ramp lesion at all. And the medial meniscus is quite clear. You can see the root attachment of medial meniscus. Yes. You can even see the white shiny fibers and the PCL attachment just below the white shiny fibers. So be careful when you do the PCL tunnel. It should not be high enough. There are chances you may do iatrogenic injury to the root of the medial meniscus. Let's do figure of 4 and assess our lateral side. May I have the probe please? Thank you. Is someone there listening to me?
Yeah, yes.
Okay. Who is the moderator?
Dr. Praveen and Dr. Aslam.
Okay. So I don't see any tear here in the lateral meniscus as well. Quite clear. You can see the popliteus tendon very well, popliteal hiatus. There is some injury on the superior surface here, but it's not communicating inferiorly. As you see, this is the normal laxity. Always have that tactile feel. So I'm not going to do anything to this partial upper surface lateral meniscus tear because it's very stable. And no cartilage injury. So we are dealing here only with an isolated ACL injury in this young gentleman. Yes. So you can see the whole footprint of the femur here. Chirag has shown a way to measure and go in the center. Yes. So what I do, usually I use an offset guide. I don't go without offset guide. So this offset guide is usually 6 mm and then it hooks behind the posterior lateral condyle here. You see there?
Yes.
And then I am assured that I am not going to do the posterior condyle blowout. Now some people say you can't change the position, but just rotating it 10-15 degree here and there, you can see I can change my entry point. So please give stool to sister. Let us sit for a while. I do my ACL in leg dangling position. Sit down, sit down. Just a minute, just a minute. So my 6 mm offset guide went in, hooked. Now sister will bend the knee. Please bend the knee, flex the knee, flex the knee. That's fine, that's fine. So here you see I can easily rotate it little superior, little inferior. I'd prefer to go in the center. Please go ahead. Move. Move. Move, move. Move means go ahead. Okay. So this is 4.5, I think 2.4 mm drill bit which will go through and through. It's on ream, do on drill. Drill only? Okay, yeah, please. Okay.
What is the flexion of the knee? Is it 110?
Flexion is almost around 110 to 120.
Okay.
Come out of the skin there. may have the artery forceps here. So depending on the size, sometimes you may use, if it's pure 8 mm, I usually prefer to have 6 mm offset. If you find the patient have big anatomy and you got a big graft, say about 9-10 mm, then you can use 7 mm offset as well.
Yes.
So now take 4.5 mm. So as I remove this, you will see I have enough posterior bone there. I have not done any injury. See there? And sorry, the light source came out.
Yeah.
And I am almost in the center of the ACL. Yeah. So let him drill. Now he will drill with 4.5 mm through and through. And while drilling only, we can see the depth of the tunnel.
Yes.
Don't move, go with finger. Slowly drill, drill. Just little less, little less, little less, that's all. Yeah, that's fine. Go in. That's the problem. Go in slowly. Some issues with the drill. So you can drill with 4.5 and then you can use the scale to assess the depth of your tunnel, but usually in this anatomical single bundle ACL reconstruction, you get tunnel length somewhere around 35 to 40. If the patient is small, you may have even 30 sometimes. That's the beauty where you can use the adjustable loop without any fear. So he is drilling in, so we get 20. Once you reach the other cortex, do let me know. Okay? How much it is? So it's 25. Please go in, go in, go in, go in, go in, go in. It's 30, 35, go, keep going, keep going. 35, 35, go, 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 go continuously, 40. So it's a 40 depth. Come out, come out. My graft is around 70, so I'll prefer to put 15 mm graft in my femoral side. So 8 drill bit will go 15. So 15 is the minimum depth we should be aiming for to put the hamstring tendon into our femoral socket. If you have a small graft, suppose sometimes you may have quadruple small patient and you have suppose say 6.5 mm only. So in that you can use 15 over there and rest you can use in the tibia, or else you can do all inside technique where you can easily make socket on both the sides and you can do well with the smaller graft as well. It's so loose, it's always getting out. Hold, boss, hold this. Slowly go in, rotate it from here, you can't, and I want 15 mm in, okay? Chal, go in please. Just a sec, just a sec. Okay. How much it is? Chalo. This is 20 and that is 15. Just go a bit in. Go, 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 go. Little, go. Come out, come out, come out. So we have done round. Just remove it. Just remove it. We'll pass later. We'll pass later. Just relax, sister. Make the knee 90 degree again. And now give me shaver, please. So this is how you just clear the mouth of your tunnel so that there should not be any remnant fibers at the aperture of the tunnel. So if you are planning to do a single bundle anatomical ACL reconstruction, the aim is to get more of AM bundle and less of PL bundle. Always assess your tunnel from the anteromedial portal so that you come to know where are you exactly. Artery, please. Just a second, let me clear a little fat from here.
Using an adjustable loop plan.
Okay. And hey man, what's the problem? Give me the artery forceps, please. By the time you ask, I'll just take. So just open the portal a bit, and then you pass your scope. What's wrong here? So you can see the tunnel there?
Yes.
Is it visible clearly?
Clear, very clear.
So you have not breached the posterior cortex at all, and you are aiming for more of AM bundle. That's what I was saying, ki we can either go more on AM or in the center or more on PL. And the footprint coverage is not as much. But you have excellent stability with this single bundle ACL reconstruction. Now we'll plan to make our tibial tunnel. So I'll just clear a bit amount of fat. So the anatomical landmarks which you need to see when you are making your tibial tunnel is try to clear this bit of fibrosed, hypertrophied stump of ACL on the tibial side. Try to preserve as much as you can, but if it's coming in your way of proper tunnel placement, don't hesitate to remove that stump. You should be able to see the whole anterior horn of lateral meniscus very well and stabilize your camera. So this is a tip hammer? It's an elbow hammer. Give me tip hammer. Probe. Probe. So this is your anterior horn of lateral meniscus. This is the posterior border of anterior horn of lateral meniscus. You come in line with it. That's the medial tibial spine. That's the lateral tibial spine. And you can see this is the whole footprint of the ACL. So try to be in the center of this. So somewhere here my tunnel will come, which is center mediolaterally as well as antero-posteriorly. Get the jig, please. Yeah, tip hammer. So there are two types of jig, tip hammer and elbow hammer. I prefer to use tip hammer because I want my bead pin to come exactly where I want it. Yeah. The angle is somewhere around 50, 45, 50, around 50, 55. See that you are between the anterior border of your MCL and the tibial tuberosity, so that you don't damage the MCL fibers when you are drilling. Come on, go ahead. Yeah. Go slowly. Put your hand down. You are lifting the whole jig. Yeah. You are not in line. Come on, little up. Come on. Yeah. Slowly. Slowly. Come in. Not yet. Go in. Go. That's fine. So you know that's the tip which is coming there, but the entry is exactly where my jig tip is there.
Yes.
So if you want to confirm sometimes, again use 4.5 mm drill bit, please. 4.5 or 5 mm drill bit, please. Array 4.5 which we have used to drill the femoral channel. 4.5 initially, so that we can show them if they want to do some eccentric reaming, the way to do it, and how to assess we are exactly in the center or not. So do sequential reaming down there. Initially start with 4.5, hold the guide wire with an artery forceps going. Go! Yeah. Come in. Go out, come out. Hold the guide wire now.
Hold, sister, you hold it, you change it to, you change, sister, come out a bit, not completely, a little bit, more out. Take out the guide wire a bit. Bhai sahab, so what are you doing? Why are you flexing the knee? We are into tibia only. We are not doing anything to femur. Come out a bit. So you can see where exactly you are, your tunnel. You can see that?
Yeah, perfect.
So you know exactly you are in the center. If you feel that you are in the center, you can use directly 9 mm, just go in. You can use directly 9 mm, or sometimes if you want to do some eccentric reaming, you can rotate the bead pin here and there. You can see that?
Yes, yes.
So if I am suppose more medially, I have to shift it little laterally, I will shift it here right way. And I will do my next reaming. Got it?
Yes.
So I am quite happy that I am in the center, so I am using directly 9 mm drill now.
Yes.
Because that's what is the length on the tibial side, the thickness. Please go in. Okay, yeah, come out. Sister, close the tunnel. Keep the finger on the tunnel. Keep the finger there. Keep your finger, bus. Plug it for, keep your finger for a while. By the time you will insert, my things will be done. So you can see we are in line with the posterior part of anterior horn of lateral meniscus.
Yes.
And that's almost in the center of the tibial footprint. Pass the guide wire, please. Loop. Ultra button, please. Ultra button, adjustable implant. Is it ready? It's in your hand, something there.
Dr. Mukesh, are you going to convert these into rectangular tunnels?
This is the place, at this time I convert it into rectangular tunnels. Now here I have done 8 mm, so my graft size should be like 9 mm. So while doing the rectangular tunnel, this diameter remains the same, and I will increase this to 2 mm below.
Okay.
So I will have more footprint coverage here. You are getting my point?
Yes, yes, got a point.
So I keep this 8 mm like this only. So my punches are 8 by 8.5, 8 by 9, 8 by 9.5 and 8 by 10. So it will increase 2 mm and I will have more footprint coverage here.
Right. So
And similarly on tibia, if you see, I have some space more anteriorly here. Right. Posteriorly I am bang at the spot. So what I will do, this is now 9 mm. So I will keep it 8 mm first and I will again convert 2 mm more anteriorly. So it will come more here.
Right.
So it will cover more footprint. Got it?
Got it.
Now we'll pass our guide wire. Flex the knee, sister, please. Flex the knee. Flex the knee, flex the knee. Pull it out, yeah. Apply artery to it. Leave it. May I have something to pull it down? Here. Give me something. Retriever or probe or retriever, whatever you have. You don't have retriever? What we use in shoulder? Yeah, it's already out. So now we'll just leave it. Give me small mosquito. Take it up. One thing which I want to show here on the tibial side is, give me nibbler, retractor, just leave it, it won't go anywhere. Retract it, show the tibial tunnel from here, outside view. Are you guys able to see that?
Yeah.
So there is some soft tissue always round there, some capsule and all. So while passing the graft, it may tend to invert in the tunnel. So I clear the mouth here and I don't want any soft tissue to go in the tunnel except my graft.
and I clear the mouth here completely. You can see that's the anterior border of the MCL where I. So my graft passage will be much easy as this soft tissue won't come in my way. Now give me the graft and marking pen. We are using Smith Nephew's Ultra Button, the adjustable implant. Hold it tight. So the total length of the tunnel is 40. So we will mark here from 1 to 4. That is 40 here. The length of the tunnel on the threads, and we are planning to put 15 mm in the femoral side. So this is 15, 14 and this is 1. So around 15 mm graft will go inside. Okay. Before you go in again, take the sizer. I always pass the graft to the sizer before I go, because that shapes the graft and it helps in the easy passage. Otherwise, if sometimes the graft is too tight, you struggle in pulling the graft. So this will give it the shape and it will easily pass through your tunnel. Hold it. One sec. Pull it, sister. Pull it. Yeah, just hold it. You know how to pull the graft? Okay, you come on this side then. Sister, you hold here. You hold the graft here. You be in my position. You be in my place. Come back. Just a second, just a second. Hold this. You hold this. You please take the trolley away. You bend it, keep it equal. And now we see the flipping of the button under vision. Why it is so hazy? Okay. Switch off the light for a while. Yeah. Pull in. Pull. Yeah, the button going in. Can you see?
Yes, yes.
And you can see the button flipped up to our desired mark. You can see the button flipped completely.
Yes, yes.
And here is our marking there, exactly at 40.
Yes, exactly.
And the sister is pulling the graft down to see the flip is complete or not. So the flip is complete, and now you see how the graft comes in. You pull, yeah. Pull the graft. Yes. Yeah. So slowly, so if he is having some pressure to pull the graft, that means your tunnel and graft mismatch is negligible or no. If the graft comes very easily in your tunnel, so pull it. Go up to desired marking. Yeah. So he had gone up to the mark where we wanted it. It's all done. Just a minute. We'll see from the high anterolateral portal again. And there is your ACL. We'll just clear the bit of mug, the debris. Because of tunnel placement, you have some debris. So this is kind of a wash after you finish your graft passage.
That looks very wonderful.
And that's your final ACL. Yes. And please extend the knee. No, don't. You come from this side, sister. You stand there. So extension. So you can see there is no impingement at all, even in 0 to 5 degree of hyperextension. Actually, this step has to be seen when you pass the guide wire. But I was quite sure because I was exactly in the line with the posterior horn, part of the anterior horn of the triangle. Give me the probe, which is seen between the ACL and the PCL, called as Howell's triangle, If you are not able to see this triangle after your surgery, that means your tunnel is too vertical. So this triangle should always be visible after surgery. If your tunnel is too vertical, patient will have loss of flexion because ACL will impinge on PCL beyond 90 degree. Okay?
Okay, sir.
So now we'll do tibial fixation and it's done. Okay?
Yeah, okay, sir.
Any more questions?
Any questions from the audience?
Sure. Keep it on the trolley. Yeah. Just retract it.
What is the size of the screw you are planning to use, sir?
Please reduce the height of the table. Regarding the size of the screw, I think there should be no fixed norm. It all depends how easy the graft goes and how tight the graft goes. As you see there, it's exactly at the mouth.
Can we have a bigger picture, please?
Can you see that? May I have the trocar? The trocar sheath ka trocar. You don't have?
Can the outside camera be a bigger
Please
picture?
reduce the height of the table so that my knee will be flexed in 20 to 30 degrees, not beyond that. You don't have the trocar. So if you see, if I am easily able to pass the trocar, I'll go one size above. If I'm not able to pass the trocar, I'll go with the same size. If the trocar is too hard to go, I will even go one size under. So here it's a 9 mm, the trocar is easily going in. I will use 9 by 25 BioSure or BioSure Regenous, whichever is available. So that should be the norm, I think, rather than fix ki one size above. 9, 10, 25. We have dealt with 9. Yeah. So I want 10, 25 as the trocar is easily going in. So while you put your graft, see that you rotate this ethibond round your fingers, pull it hard and do posterior drawer, keep the knee in neutral rotation and round 20 to 30 degrees of flexion. Provided patient don't have pre-op hyperextension. If patient is having pre-op hyperextension, I'll prefer to keep knee in neutral position and give posterior drawer. And while preparing tibial tunnel, in case of hyperextension, I'll make it little posterior to prevent roof impingement. So that's the screw going in. And now I'll again put my scope in and I'll ask my assistant to give a bit amount of final fine tuning. Give me the scope. Give me the scope. So that's the adjustment which can be done with the adjustable loop and not possible with fixed kind of loops. Chalo. So do some. Can you see? Chalo. Pull it up.
Can we have the inside picture?
One sec. Is inside picture visible?
No.
Inside pic, please. This inside picture.
Yeah, I got it.
Okay. Now please pull it. Pull. So you can see a slight adjustment is done about a millimeter or two. So always mark your graph up to 15 only, so that this fine 1 to 2 millimeter adjustment needs some space in the femoral tunnel. Got it?
Yes.
Yeah.
Okay, so it's all done.
So would you like to put any post? Tie the threads around any post.
For ACL, I don't use dual fixation. Single screw fixation is sufficient and it doesn't give any laxity. But if I am doing PCL, definitely I'll go for dual fixation. One is aperture, that is screw, followed by either suture disc or a post.
Okay, sir.
So that was a wonderful demonstration. Thank you very much, Dr.
Thanks to the whole OT staff, anesthetist, the company guys, Dr. Sridhar, whole staff of Medical Hospital, our anesthetist sir, who have patiently on Sunday agreed to give all 4 patients. So nice of you, sir. Thanks a lot to everyone. Thank you.
Good evening. Good evening, everyone. So we have come to the last session, that is a workshop. We have 2 stations. Before starting the workshop, I would like to give big thanks on behalf of IAS as well as Andhra Pradesh Arthroscopy Association. We thank each and everyone, all the delegates who have participated, and all the faculty who have come all the way and gave to us live surgeries. And I thank our chairman sir, Dr. Sivanand sir, and the national faculty, Rajiv Raman sir, Chirag Thans, Mukesh Ladagaru, and also the regional faculty and Vikram from Delhi. I thank each and every one, all the faculty, and also all the audiovisual guys who have given excellent transmission, live transmission from Medicover to the Novotel. And I thank Smith and Navi guys who are who have given all the support in terms of instrumentation, workshop instruments, as well as their 4K cameras at Medicover Hospital. And I thank Novotel people for giving the very good venue and a sumptuous lunch what we had in the afternoon. So it is the entire session is recorded and it is available in online in Indian Arthroscopy Society website, and you can ask for the link. It is available in YouTube. And I thank one and all for giving a very good academic feast, and I thank Dr. Sridhar, who is the man behind. He dedicated all his almost 1 week. He stopped his surgeries and he worked day and night to make this program a success. Thank you very much. Yeah, now we have arthroscopic simulation workshop. Those who wants to have hands-on, please come forward. We have 2 stations. Dr. Raviteja is moderating one station, and I will be there to help you in the another station. Thank you.